you can recognize Dr. Peter Cotton, who was talking about ERCP quality before many people in this room were even born, certainly before I was a gastroenterologist. And Dr. Martin Freeman, who we have the honor of having with us today and will hear speak, who has published extensively on quality in ERCP and taught us lessons that all of us now follow today. So for the purposes of this talk, we're going to focus on quality indicators, and the reason specifically that I chose this is because the ASGE-ACG Joint Quality Indicator paper on ERCP will be updated this year, and that will come out in the next few months, and I'm on the writing committee for that paper, so I want to share with you changes that are coming. We'll talk about what the benchmarks are related to those quality indicators, with advice on how to achieve and improve on them in your practice. And then I'm going to make some hypotheses, Dr. Garch would like that, about where the field is going and what I think the future holds for quality in ERCP. So as we go through this, I'd like you to focus on these two areas. What really matters in ERCP and ERCP quality, and then what you can control. And I would put forward that the two don't overlap, that there's an intersection between the two, and that that's where we should spend our energy as we try to get better and better at our ERCP skills and outcomes. So when I look back at ERCP and even healthcare quality in the United States, this goes back all the way to 1999, when the Institute of Medicine released the report "To Err is Human, Building a Safer Health System." And this was in response to multiple reports of deaths related to medical errors in both the scientific literature as well as in the lay press. It took until 2006 for the ASG and the ACG to issue quality indicators, and this was a document that was common to all endoscopic procedures. We didn't have a specific quality document in ERCP until 2016, and that's the document that will be updated this year. So I want people to have a good understanding of what I mean when I say a quality indicator. This is a measurement of quality that is tied to a target or benchmark, so keep that in mind as we start going through these. Quality measures can fall into three general areas, including process measures, structure measures, and outcome measures. Looking out across the room, I would guess that most of you are clinicians and care for patients. Some of you may have leadership roles in your department, but many of you don't, and you're not involved in structural quality issues. And so this document actually doesn't cover structural issues, and I won't be talking about those. So I want to compare and contrast the other two, process measures and outcome measures. Process measures are generally easy to measure and to track. We're talking about things like the number of ERCPs you do per year. Whereas outcome measures are often difficult to track and difficult to measure, either through bias or through capturing complications like adverse events and things like that. Process measures are not typically prone to bias, whereas outcome measures are often prone to bias and interpretation. Did my patient really have a post-ERCP pancreatitis, perforation, etc.? Process measures are usually easy to comply with, whereas outcome measures show marked variability in clinical practice. Process measures don't typically impact quality of care significantly, but most outcome measures generally have a great impact, and we'll talk about which ones those are and why the new guideline will focus on outcome measures more. So the writing committee, as we looked at this document and thought about what changes we were going to make, we've drastically reduced the number of items that are in this guideline. If you're familiar with the guideline, there's, I think, 23 quality indicators. And we went through and kind of honed away everything that we thought was either not relevant to patient outcomes, subject to bias, things like that. And these are the four quality indicators that we've removed. So these are things like the volume of cases that you do each year, how often you complete an ERCP report that's accurate. Everybody should be doing that anyway, right? So this document, we're trying to get people to strive to do better and push the field forward. So for the remainder of this session, I'm going to talk just about the priority indicators. There are some in the paper that are not considered priority indicators, and it should make sense what that means, right? A priority indicator, it's a priority, it's important, it has direct impact on patient outcomes. So the first one is frequency of cannulation, and we've set this at greater than 90% because this is an essential first step to successful ERCP. We also know that there's variability among providers in terms of the success of cannulating the duct of interest, and then that correlates with morbidity and poor outcomes. We have now old data. The first reference there is from a study that Peter Cotton organized, and this was a voluntary registry of 85 high-volume ERCPs. All of them had cannulation rates greater than 80%, and more than 3/4 had cannulation rates that were greater than 90%. So we think that this benchmark of greater than 90% that you get into the duct that you want to get into is a very reasonable one. And that's confirmed by more recent data. The second reference is from a recently published paper from the Netherlands. The Netherlands, if people aren't aware, have recently moved to a process where there's mandatory information entering into a registry about the outcomes from their ERCPs. And what they saw a couple years after the registry was instituted was that cannulation success was 90%, and without surprise, lower rates of success occurred in providers that have lower numbers of procedures. That's what Marty showed a long time ago, right? That the outcomes, the complications are directly related to your volume of procedures, and we'll talk about that again in a minute. So I mentioned that I'm going to give you some tips about improving your benchmarks. Here's the first one. So these come from the quality committee from the ASGE. This document was read by Raj Kaswani. And the tactics that they recommend to improve cannulation include use of a prone position, deep sedation, use of a sphincter tome rather than a cannula because it gives us more options about the angulation of the insertion of the tip, especially if you're going to be doing a sphincterotomy anyway. And then the last two are physician-guided wire cannulation. There's more and more data showing the physician guiding the wire is both associated with improved rates of cannulation as well as decreased rates of complication. And then having an alternative cannulation technique like needle knife sphincterotomy, fistulotomy, double wire technique like we saw in the live session yesterday that Dr. Freeman used. Both of these final two recommendations assume that you're a provider that is skilled and has high volume. Not everybody is in that position, right? Some people don't do ERCP as often as others do, and if you're blessed to be at a medical center that has a technician that is very skilled, maybe doing more ERCP than you are because they're working with multiple different providers doing ERCP, in that setting it may actually be better to have your technician manage the wire. So those two recommendations are with that caveat. The next priority indicator is for the success of complete stone extraction, and we've placed this at 90%, and this is a priority indicator, and this is an outcome measure as opposed to the last one that I showed you as a process measure. But again, very important. What's different in the new guideline, or will be, is that we're not stipulating that for stones under 10 millimeters. The old guideline gave that benchmark of 90% for small stones under 10 millimeters. And the reason we're changing that is because we think the majority of stones are already under 10 millimeters. I would argue that most, I would say 90%, at least in the United States, are under 10 millimeters. So if you have 10% left that have to be removed, that you're already at that benchmark. And in a very rigorous systematic review and meta-analysis conducted by the Standards of Practice Committee, they found that complete clearance of stones using large stones greater than 10 millimeters using sphincterotomy and large balloon dilation was achieved in 85% of cases. So if we've got only 10% that are large and we get 85% success with these two approaches, then we're close to 100% and certainly over 90%. It's important to realize that the data that's out there that even inform that meta-analysis is usually center-based. There are very few studies that report outcomes and performance on a per provider level, and we'll talk about that more in a minute. So my tips on improving stone extraction are to use balloons over baskets, especially for stones under 10 millimeters in size, and then use alternative techniques for large stones. We saw a presentation in the plenary session on this, and a question came up, I think, from Dr. Garge about using balloon dilation, and that's definitely recommended from the Standards of Practice Committee to use that approach for large stones. Alternatively, you could do EHL with sphincterotomy. An important caveat here is if you're using large balloon dilation to facilitate stone extraction, the inflation time should be a minimum of 1 minute, because lower inflation duration is associated with increased risk for post-ERCP pancreatitis. And then going back to the Quality Committee's guideline, the use of intraductal ultrasound or cholangioscopy can be important and useful to confirm clearance if there's a doubt. And that recommendation is coming because missed stones often lead to complications later, right? The patients re-present with cholangitis, gallstone, pancreatitis, something else, and so it's important that we know that we got all of those stones out. The next priority indicator is for rectal NSAIDs in index ERCP, and by that we mean somebody that has an intact papilla that's not had a prior sphincterotomy. This is new. This was never on the guideline before, so this is a new one that's been added, and we've set the benchmark at greater than 90%. My former colleague and dear friend, Joel Munzer, is the one who published the landmark paper that showed the benefit of rectal NSAIDs. That study was done in high-risk patients, and so often that's been interpreted that average-risk patients don't need rectal NSAIDs. That is absolutely not true. There is now overwhelming data that even average-risk patients could benefit with a risk reduction for post-ERCP pancreatitis of 50%. Despite that, fewer than 50% of eligible patients had actually received rectal NSAIDs in a subsequent study published in 2020. Keep in mind that rectal NSAIDs are contraindicated in patients that have allergies. They can have anaphylaxis. I've actually reviewed a case legally for that, so keep that in mind. What a relative contraindication to rectal NSAIDs has been renal failure. And our group this year will have an oral presentation at DDW showing that rectal NSAIDs in the setting of renal failure, which is early, chronic kidney disease stage 1 or 2, is actually safe and doesn't further worsen kidney disease or lead to permanent damage. And then the most recent interesting publication that ties into this priority indicator that Joe just published in the Lancet is that pancreatic duct stents show actual additive protection even with the rectal NSAID. So I think you saw a case yesterday where Dr. Freeman placed a pancreatic duct stent. He's going to be talking about that and reducing risk in the postgraduate course. So for the remainder of the time, I'm going to talk about adverse events in ERCP and then future predictions for ERCP quality. So the writing committee has really focused on adverse events and rewriting the quality indicators, and that's because these adverse events are the ones that are associated with significant cost, harm, and even mortality. As I mentioned before, these sorts of outcome measures are very difficult to follow. They can be gamed, and there can be bias in reporting. And so for right now, the recommendations are probably going to be process measures, i.e. document this, document that. But it's my hope that the future will see us actually setting benchmarks that are performance measures, i.e. if you are a skilled endoscopist, your post-ERCP pancreatitis rate should be X. And I do think that these are the areas where the greatest impact will come. Okay, these are actually 5 different quality indicators. Every one of them is priority. So you can see, as I mentioned in the last slide, none of them are giving you a benchmark that says you should have a bleeding rate under 1% or 2%. And we'll talk about that in a minute. But there's 5 of them, dealing with unplanned or prolonged hospital stay, documentation of post-ERCP pancreatitis, clinically significant hemorrhage, post-ERCP cholangitis, and then documentation of an unplanned biliary intervention within 30 days of ERCP. And what we mean by that is that for most cases, there's some exceptions that we could talk about, but for most cases, the patient doesn't need another ERCP 30 days after their first one. And so when that happens, or they need something like a PTC, it's because we made a bad decision, or we missed something, or we made a mistake, right? And that patient is having to undergo another procedure. So that's why that one was added. I realize that nobody's going to be able to track all of these in your practice. And so the 3 of the 5 that I just highlighted in blue, number 1, number 4, and number 5, are really the ones that I would choose or recommend that you focus on if you're going to track quality measures. And of those 3, I would say documentation of an unplanned or prolonged hospital stay is the best time and effort for you. And why do I say that? Because that quality indicator actually captures multiple other ones below it, right? It captures when the patient is having cholangitis because they're going to get admitted or come to the emergency department. If they have pancreatitis and it's bad, they're going to come in. So just that top one is probably the best one if you're going to track any of these. So overall, our recommendations for adverse event quality indicators is that there's benefit in tracking them, even if you do it only in your group. And we say that because we understand that different cohorts have different risks, meaning the patient population that Dr. Garg sees at his hospital may be sicker, therefore may have a higher rate of a complication or a bleed, right? They come in with a greater coagulopathy. But there's benefit in knowing what happens in your group. If you have a group of 3 physicians, you're seeing likely the same population. If my rate of post-ERCP pancreatitis is 15% and my partner's is 5, I need to be getting better. And we're going to talk about that in just a minute. Next, the denominator for bleeding, perforation, and possibly pancreatitis should be in patients with native papilla, because those don't occur usually if they've already had a sphincterotomy. And just to compare apples to apples, that's what your denominator should be. And then ideally, we should remove recording from the scope of the individual provider. I'm going to close with predictions about what I think the future holds in ERCP quality, touching on 3 different areas. So the first area that I am thinking about is in natural language processing. Many centers around the world, and certainly across our country, they have EMRs, they have electronic medical records, and those are getting better and better in talking to each other, right? Before, early on, I couldn't tell what would happen at a hospital across town, but now we can. And so I predict a future where we can use natural language processing and AI, as well as that electronic medical record, to get very accurate and specific data on individual providers' complications and outcome. The next area I would say that's really going to change ERCP quality is simulators and virtual reality training, not just for our trainees, not just for our fellows, but Dr. Garg talked about getting better and expanding and learning new skills. I think this is an area that could really help people that are already established in their field learn a new technique in a safe way. And I would go further to suggest that this third field could be combined with that second one. So this is a paper that Joe Elmunzer and the SBI investigators just published, that the bottom reference is the most recently one. But what these investigators did was they used videos from the SBI trial, the Stent versus indomethacin trial that I mentioned earlier, that was published, that showed the benefit of stents. And they used videos that were recorded not only of trainees, but of attending doctors doing ERCP. They formed an expert panel and they used Delphi method, as well as 3 reiterative validation exercises to look at skill. And they deconstructed ERCP into 6 technical elements, things like a lineup and how you approach the papilla, and then 11 sub-elements. And their recent publication in February showed that this tool can be used to differentiate between ERCPists of varying skill and experience. So think about that. Now we have a tool that is objective, that accurately measures that, and if I'm a physician in Arizona and I want to be mentored or coached by Dr. Garg in India, we have a tool that we speak the same language, we could have video, you could do it in your own time and understand what this person is doing or not doing, and you could give feedback and tips, right? Like, this is just like the tip of the iceberg. So I'm going to close with these 3 B's. Be aware of your own QIs. Even if you don't share them, we provide annual and anonymized data to all of our endoscopists on their ERCP outcomes that a nurse tracks, so it's very objective. But you can see what yours is compared to your partner's. Be striving to improve. This goes back to some of the things that you said. I've been doing ERCP for 25 years. I am better this year than I was last year, and we should all be working to do that. And then finally, if you are in the position of being an amazing ERCPS with amazing quality indicator outcomes and benchmarks, be humble. If you can help a colleague get better, that benefits our patients, and that's what we all went into medicine for. Thank you.
Thank you, Dr. Michelle Anderson, for a very pertinent talk. Quality control and day-to-day practice, particularly ERCP, and we all should be following what you have tried to teach us. Thank you very much.
I request the chairpersons to please felicitate Dr. Michelle Anderson. We now move on to the live transmission from Vedanta. To moderate the session, I call Dr. Suprabhat Giri, Dr. Jimmy Narayan, Dr. Deepak Sharma, Dr. Saroj Kumar Satapathy. And to chair the session, I call Dr. Jayesh Soni, Dr. Prachesh Ashdir, Dr. Manish Gupta, Dr. Gaurav Pandey, and Dr. Monish Kataria. Over to
Am I audible in the hall? Am I audible in the hall? Dr. Sawan? Dr. Sawan?
So chairpersons are coming. Just a minute, please.
Yeah, but am I audible?
Yes, you're audible, so you can go ahead.
Okay, so thank you, and we are back to the live endoscopic session from Medanta, the Medicity. And just to give you the brief of yesterday cases, the case which is done by Professor Michelle Anderson has a necrotizing granulomatosis in favor of tuberculosis, Jenkins, done by Dr. Amit Mehdev. And that case is also stable on Ryle's tube, and tomorrow we are going to discharge him. Professor Dr. D.N. Reddy did the bilateral hilar stenting. Patient is stable, no fever, and the bilirubin has dropped down by 4 milligram. Both rectal ESD and ampulectomy done by Nihos as well as Honchi, both are stable. Arma procedure by Vikas is also stable. Pankaj is the esophageal ESD. Post-procedure patient is stable. Achalasia cardia done by Jahir is also stable. So now we are starting the session, and I request Dr. Jubin Dev Sharma to present the first case for T.S. Chandrasekhar. Over to Jubin Sharma, please.
Thank you so much, and once again, welcome to day 2. The case today we're starting is a 42-year-old male who has chronic calcific pancreatitis, and he has underwent multiple ERCPs, and the current issue is tight biliary stricture, for which we are planning for an ERCP. We'll go to OT1 for this case.
I must congratulate the outset Dr. Rajesh Puri and his team and Medanta team for this wonderful organization, HGA also. And I am one of the state-of-the-art endoscopy unit here. And my case, we have been briefed about the chronic pancreatitis with a stricture in the biliary system, the lower CBD, and LFT changes there. Now the question is whether it should go for surgery multiple times. You have done it, plastic stent, or we should go for the metal stenting. We can try once more with a young patient. So we will try first how, and we have been informed that already the technique of cannulation has been described in detail. So my duty is to tell you that when you are deploying a fully covered metal stent, and what are the precautions need to be taken. And this patient has come with a cholangitis, and plastic stent has been removed. Now I should look at the major papilla is like that, and minor papilla. You can see that sometime in chronic pancreatitis, minor papilla also be very prominent. So you should be very careful this. And usually the pancreatic orifice will be here, and you go to the apex, there will be a biliary system. So I'm not going to the technicality of the cannulation. And I'm ably supported by Dr. Ajay Kumar is here and Dr. Sanjay. So they will guide me also. And we have a very good technician, endoscopy technician. Mr. Bhagwan is also there. The patient is lying in the prone position. I'm using 190 series Olympus endoscopy system. And I'm using now the Ultratome XL sphincterotome of Boston Scientific. And we have the thermo guide wire. So let me see whether I'll go to the apex and the cannulate, and that is my first choice would be there. So I will just go to the biliary opening from below upwards and left to right and along the 11 o'clock position. Okay, guide wire, please. Guide wire. Okay, so this is the pancreatic. So they are very close to each other. So I know that where is the pancreatic orifice now. So what you have to do is you go up and to the little left, then you will have the biliary opening. Okay, see this? Most likely. Okay, you go there now. Sometimes what happens if you remove the plastic stent and there can be some spasm will be there. Okay, now I am trying the, I know the pancreatic orifice very well. And here cannulating pancreatic duct or guide wire going in, you don't have to worry because chronic pancreatitis is really going into the kind of the pancreatic post-ERCP pancreatitis. So I am just searching, there is some debris there. If I am not able to see the biliary orifice, I may wash that area. Okay.
Good.
Yeah, we got the biliary system. You know that it is already the many times that we attempted. I told you how to identify the pancreatic orifice. Go up onto the thing. Now I am asking Bhagwan to aspirate the pus so that we can send it for culture. Whenever you want to inject the contrast in a cholangitis patient, better to aspirate and slowly inject the contrast. That will prevent the biliovenous reflex. So the patient will not have cholangitis. Now we are quite sure that we are in the. Can you just show this now?
No, just jiggle it.
Yeah.
Jiggle it.
Just jiggle it down. And Ajay is telling some the tidbits for the aspiration of the. So you can see that. Can you focus it here? Okay. Now this is almost like a white bile. No, the bile is coming. So it's not very purulent, but it is infected bile only. So he is going to aspirate something. Now another important point here is I'm going to place a fully covered metallic stent and I need to know the cystic duct opening. So I would like to place the stent below the level of the cystic duct orifice so that the patient may not go into cholangitis. I mean the cholecystitis. That is a very important thing. So what I am going to do is after the aspiration, this is going into the left intrahepatic, the right posterior duct. Can you just withdraw it now?
So
And I
Dr.
want to
T.S.
make it to the
Chandrasekhar,
right anterior duct so that I'll be more stable, but doesn't matter once you go into the duct. Now I am going to inject the contrast to know the cystic duct. Sometime in the prone position, you'll be able to see that. What do you think, Ajay?
Oh, yes.
We should be able to do that, Sanjay?
Yes, sir.
Anything? Okay, we are injecting the contrast after the aspirating it. So you can see the right and left. The patient is the prone position. And if you don't see that, what we do is 3-4 centimeter below the hilum, we will try to put it. Sometimes you rotate the patient and try to find out. You see the stricture there. I was told they already taken the breast cytology very recently. The patient has come with the cholangitis. So before submitting for surgery, we thought we will try once with this.
So
And
Dr.
you are able to see
Chandrasekhar,
the cystic duct now.
Dr. Chandrasekhar, till
Yeah.
you are now you are planning to do a metal stand. We are going to Amol room for a few minutes. Once you are ready with the metal stand, we'll come back.
Okay, I'm going to now the main point here is the cystic duct opening we have demonstrated. Now I'm going to place the metal stent. I'll come back to you now. Okay.
Over to Amol Bapai room, please.
Yes, so the case that we have right now is a 43-year-old male who has a long-standing constipation Incidentally, he came for a colonoscopy and this was a lesion in the rectum. The plan is to do an ESD. Over to you, sir, in OT4.
Good morning.
Good morning.
Good morning. And are we audible there? Hello? Can you hear us?
Yes, sir, you are audible, sir.
Okay, yeah. So, hearty congratulations to Rajesh and his team from Medanta for this fantastic conference. And I have Honchi with me to help me with this case. And do you have the endoscopy view? Yeah, so as you can see, we've just put in the scope, and this is a pretty large lateral spreading tumor in the rectum, in the distal rectum, which is starting at the anal verge and going inside for about approximately about 8-9 centimeters. That's what I would say. Yeah, 8-9 centimeters. And it's about circumferential. So it's pretty large. And it looks like a granular LST. And but the nodules are not too much. So let's put NBI and let's look at the pit pattern over here. Now what I'm going to do is I'm also going to flush some water. So what do you think, Hanchi? Meaning it looks majority like a JNet 2A.
Yeah, I agree. So they are quite regular in appearance. Some of them looks like a serrated
Serrated.
area,
Yes, there
but
is
there are
also
also areas that look suspicious of adenoma.
adenoma.
Yeah, so maybe a mixed lesion.
That is what.
But anyway, I don't see any 2B or even 3 areas. So this
Yeah,
should
this
be a
is-
good case
should
for
be a-
on-block resection by
Right.
ESD.
Right.
So what will be your strategy in this case?
Okay, so you see, what I thought was, and correct me if I'm wrong, because so when we squirt water, the water is going posteriorly at around 9 o'clock. So this edge of the tumor is probably the most dependent part, the gravity dependent part.
Yes.
And this is the anti-gravity. So what I would propose is we start an anal incision and we do a tunneling kind of a procedure and we tunnel all the way across. And then once we have the tunnel, then maybe we can take this edge first.
Yes, yes.
And then we go finally to this edge. So
Yes.
that would be the plan. What do you think?
Yeah, I fully agree. So I think a pocket method in this case would be quite useful. The main difficulty would be the initial cut near
Yes.
the anal canal. I
Yeah.
can already see
I can see
the
quite a bit
hemorrhage.
vessels there. There are quite a few
So I think
hemorrhoids over here. So,
once you get through here, it will become much more smooth.
I know. So can we have the needle, please? Yes. I'm
So
going to inject.
Dr. Amol, if you can give an idea what is your plan, how you are going to proceed, and Dr. TSC is ready with the stent, we can come back, but if you can tell the audience.
Okay, so Rajesh, as I mentioned, I plan to start with an anal incision and tunnel my way across the lesion and then take the gravity side first, the edge, and then the anti-gravity side first, the later. So that would be the plan. And then we may have to modify the plan a little bit on our way, but that's the broad kind of a plan that we propose. So that is how it is. So we will continue working, I'm sure, and we will keep coming, y'all can keep coming back over here whenever you feel it's important. And if there is something important happening over here, we can always call you back. So we'll keep that strategy and we can go ahead with the other cases as well parallelly, because this is going to take a while.
Thank you, Dr. Amol, and we can go to TSC room where he is ready with the stenting. Dr. Zubin, please. Dr. TSC, you are online.
Would you like double pit test and in that?
No.
What is your policy?
Yeah.
Dr. TSC, you are online
7:50.
in the hall.
Okay, now what we did is we identified the cystic duct opening and below which we measured it at 2 centimeter. Initially, our technician gave me 6 centimeter long covered stent, and we measured it at 2 centimeters. It's all to prevent cholangitis. There are two important aspects of covered metal stent is, one is prevention of the cholecystitis after deploying it. That means the stent, the proximal point should be below the level of the cystic duct opening. Number two is migration. Either it can proximally migrate or distally can migrate. And to prevent that, I think we need to have something like we can put a double plastic stent as 7 French will be better. Now what I have done is, are you able to see the cystic duct opening? I have used a Hanora stent, fully covered stent that is removable. So never ever put the partially covered stent, will not be able to remove it. Then of course you can go for surgery with that also, and make sure that we have seen the cystic duct opening in the prone position, and my guide wire is into the right posterior duct. You should have a thorough anatomy of the right posterior, right anterior duct, left duct. So before doing ERCP itself, you are very clear. Yeah, this is from the Boston, the 4 centimeter stent, and I'm going to deploy it now. And during deployment, that's a very important technique, is either it will get sucked into the common bile duct, or it may this one. So this is the one I think Ajay is showing, this biliary stent. So you must have that 6 centimeter, 8 centimeter, 4 centimeter, depending on here the cystic duct opening is a little on the lower side. So now I see you see the yellow marker endoscopically. I keep it little louder so that we will have there can be shrinkage to the tune of 30%. So I have to give leverage. So neither the stent should be sucked into it, or should not, and it should partially cover. So just not do this mistake. So I am asking Bhagwan to deploy the stent. Here the thing is, he will remove the outer cover. Right, 1 minute. So we always hold it like that, and you see that it is the yellow, and we are able to cover it just below the cystic duct opening. Ajay, you are happy?
I think this is the ideal situation.
Yeah.
Yes.
And what about Sanjay? We have two experts here for assisting me, because this is 1 minute. Okay, this is working. Deploying it. Oh, fantastic. Now let me see this. The bile is coming freely now.
Normally, this needs a clap from the audience.
Thank you, Dr. TSC, for the excellent case. And
so we are going to deploy a plastic stent so that the migration will not be there. So the learning point is, after multiple times of ERCP, to identify the biliary opening can be difficult. In case you enter into the pancreatic duct, go to the up and to the left of the pancreatic opening so that you will identify the biliary opening. Aspirate before injecting a contrast and identify the cystic duct opening. Select the stent according to the level of the cystic duct opening in the ampulla. We have selected a short stent, and make sure that there is no migration. Make sure that the proximal part of the stent is below the level of the cystic duct, and always have experts around you to guide you properly.
so
Okay?
thank you, Dr.
Thank
TSC.
you.
Thank you.
And,
And I request Dr. Jubin
And
to
you will
shift
have
to-
a lecture on benign stricture, whether stenting versus surgery, today afternoon by Dr. Ajay.
Yeah,
by
so
3:30.
Jubin, we can shift to Dr. Dong Wong Seo, where he's ready with the contrast EUS. Thank you, sir. Thank you.
Thank you, Rajesh.
Yes, for the next case, we have a 24-year-old female who had an instantly detected pancreatic uncinate process NET. Previously, we had done an RFA once last year, but there is still a recurrence. The plan is to go ahead and move with again RFA. We shift to OT2.
Hello.
Hello.
Do I look good? I cannot hear.
Good morning, everyone. Are we audible?
Yes, you're audible. Can go ahead.
Okay, Professor, you're
Okay.
audible. Okay.
This lady has a small neuroendocrine tumor in the head of the pancreas. And last August, she received the EUS-RFA 1 time. This is second session of
EUS.
EUS. And we can appreciate round hypoechoic mass in the head of the pancreas. Yes, that area. If we measure the dimension, can you check the dimension?
Yes.
It's less than 1 cm. It's about, yeah.
6 to 7 were very small lesion. But previously they did FND and they realized that there is a remnant neuroendocrine tumor
Yes.
in this area. So if you apply E-flow, then if there is visible tissue, then we can see some vascularity inside the tumor.
So we can see at the center there is this, what the professor is talking about.
So I think there is still viable tissue in the neuroendocrine tumor. So to check the viability and to check which area is viable, we are going to use contrast enhanced EUS.
Okay.
So we are ready.
We are ready with the contrast.
And change the view into contrast enhanced harmonic view. Yeah.
Yes.
Okay. Then we will see whether this area, the pointer.
Yes.
This area is enhancing or not. We need to focus on this area.
Right.
Okay. Inject contrast. Neuroendocrine tumor generally.
There should be hyper-enhancing, Professor.
Hyper-enhancement after contrast injection.
Right.
We are using Sonoview. This area is.
Yes, we can see over here. Yes, yes. Immediately it gets.
There is vascularity.
Yes, yes, yes.
There is vascularity. So even after one session of EUS-RFA, there are still viable tissue.
Viable tissue is there.
So we are going to ablate this area by repeat EUS-guided RFA.
So, Professor, how many sessions usually does these kind of lesions take? How many sessions are required
It
usually?
depends on how aggressively you do RFA at the first session. But this kind of small lesion generally requires just one session of RFA. But in this case, we need to do.
We need to do a repeat
session.
Second session.
If you wanna ablate the whole lesion in one time, we need to include the safety margin, like not the 5 millimeter safety area.
Should be also ablated.
Yeah, it should also be ablated. That's the principle of HCC RFA. But in pancreas, it's going to be difficult to ablate the larger area because of the risk of pancreatitis.
Absolutely.
Yeah. So.
Okay. So, what is your strategy, Professor, for PD stenting, pancreatic duct stenting before?
If the lesion is very close to main duct, then we need to insert pancreatic stent before starting RFA to protect the pancreatic duct stricture.
Okay.
But in this case, the lesion is located in the near the Wuchinate area. So there is some distance between the lesion and the main pancreatic duct. So we don't need to insert pancreatic duct stenting in this case.
Okay.
Yeah. So we are going to prepare EUS-guided RFA.
Yes. So we prepare the probe now for the EUS-guided RFA. So first, Professor, we'd like to just show the audience the device that we are going to use.
We are going to use.
Please focus on this.
EUS-RFA probe, which is produced by Samed company and distributed by Taewoong outside of Korea. And it has 1 cm electrode active part.
Yes.
And the rest of the needle is insulated part. So we are going to use 1 cm electrode for RFA of this lesion.
So, Professor CEO, till you are preparing, we are going for a couple of minutes to other room.
Okay.
Once you will be ready with the device, we will come back to you.
Okay.
I request Jubin to go to Dr. Rajkumar Wadhwa room where he is ready with the small intestinal stricture dilatation. Over to Jubin.
Yes, for this particular case, this is a 51-year-old female who had a stricturing Crohn's disease. 2014, she had an intestinal resection and anastomosis. That biopsy was with Crohn's disease only. Currently, she was on ustekinumab, and now she has pain abdomen, recurrent obstruction for last couple of months. And the plan is to do a double balloon endoscopy, try to reach the site of the stricture and dilate it if we can. Over to you, sir, in OT3.
Hi, good morning. I hope everybody can hear me. Is my audio?
Yes, sir, you're audible. Go ahead.
Okay. This is a 51-year-old lady. I think she had undergone multiple times earlier surgery and then subsequently small bowel stricture recurrences and once dilatation has been done. Now we are standing actually at the dilated stricture, previously dilated stricture, and we are trying to dilate a stricture proximal to that. So this is a stricture, we cannot go deep inside, but we still can visualize the stricture. The characteristics of the stricture which I would like to dilate will be less than 4 centimeters and no active ulceration like in this patient. This is a healed stricture which does not have any active ulceration, does not have any fistulas or internal fistulization or abscesses on the radiology. These are the contraindications. Normally, I will measure the size of the anticipated stricture and then do the dilatation. Maximum dilatation I will use will be 15 millimeter balloon, because beyond that the complications increases significantly. We will gently try to push our balloon out along the stricture. Guide wire has been passed earlier. We are likely to recoil back a little, and you can see the stricture which was dilated last month here. Balloon dilatation of the strictures, especially in Crohn's, can lead to a recurrence in about 50% of cases in 5 years post dilatation. So we need to keep this in mind and advise accordingly to our patient. Now we can see the balloon out of our area, and we will ask the dilatation to be done. Can we inflate the balloon, please? The other precautions which you need to take in this situation is you need to have an absolutely new CRE balloon. Previously used CRE balloon, you will not be able to reuse it back again because of the length which goes inside. Open. Go to the maximum. You can see the maximum length we are trying to achieve. 12 millimeter we are now. We'll hold it for about a minute there. We can have a fluoro on, please. You can see we are about 100 centimeters nearly inside, and we have obliterated. I'm sorry, the fluoro was not on earlier. We have obliterated the thing. The special thing here is I personally don't use a contrast because this balloon cannot
Dr.
be used.
Jubin, can we show the fluoroscopy of the CRE dilatation? Please go to fluoroscopy also. Endoscopy plus fluoroscopy.
Can I get a can fluoroscopy image be seen there?
No, fluoroscopy image is not visible.
Now you can see that we are deep inside, nearly about 80 to 100 centimeters inside the terminal ileum in the small bowel. As you can see the scope, you can see the balloon completely obliterating the waste there. This is what we will call it as a successful dilatation. We will gradually reduce decrease the inflation, since now we are holding this for about a minute, and then see the outcomes of. Do you encounter any bleed while dilating? Usually, if you are taking an active ulceration, perforation and bleeds are common. If you are taking healed ulcer or fibrotic area, then the bleed and the ulcerations both are uncommon. Rarely you can have bleeding, but they stops on their own majority of the times. Deflated.
My question is about. Thank you, Dr. Vadhva, and Professor Dong Wong Seo is ready with his RFA case. So can you demonstrate the endoscopic view which Dr. Vadhva is dilated? Can we make the endoscopic image bigger? How do we reach this? Endoscopic image of the CRE dilatation, can we make it bigger?
Yeah, I will be taking this time only till 12, because you can see the
Jubin, can we show the endoscopic image? Yes, that is bigger. Yes.
You can see the small ruptures at the end here, which indicates that active dilatation has occurred. If the patient remains symptomatic, then probably up to 15 millimeter max we will go. We will not dilate it beyond this. If the patient requires beyond this dilatation, surgery is better. Strictureplasty is better in these circumstances.
Thank you, Dr. Badwa, and we switch over to Dr. Dong Wong's CEO room where he is ready with the RFA device.
Hello. Hi.
Am I audible?
Are we audible?
Yes, you are audible.
Okay.
Okay. So in the meantime, we already inserted the RFA electrodes into the instrumental channel of our endoscope, and you may appreciate the RFA device. Here, this is RFA.
Please focus on
device.
this needle.
Basically, the handle and the system is very similar to EUS-guided FNA, FNB needle, but on this area, there is a irrigation channel. During RFA, when you apply electrical power at the active electrode part, creates a lot of heat. So we need to cool it down. For the cooling, we are inserting cold irrigation saline into this channel, and blue is cold saline going inside, and the white is coming out. Why is it needed? Because if the active electrode create a lot of heat, then it may create the phenomenon called charring. So this charring, actually, when it happens, it suddenly increases the impedance around the electrode. So for the delivery of energy around the tumor area is becoming difficult. So to prevent that,
So the depth of penetration will be lower if a charring happens.
Charring happens.
Right.
Charring actually increases the impedance a lot.
So what is the wattage that you have set, Professor, for this particular
For
case?
this one, we are going to use, this is small lesion, so we don't need to use very strong power. I think I'm going to use 20 watts in this case. And so the setting
we are
is
setting
already
at 20.
20 watts.
Okay.
Yeah. So I'm gonna.
So for larger lesion, you'll go for up to 30.
Yeah, up to 30. Sometimes I use 50 watts, but 50 watts can create the rapid bursting of tissue and create bubbles. So then the
slow
view is very difficult.
It's kind of a slow cooking process that you call, right?
Yes, I call it slow cooking.
Right.
Can you appreciate the electrode tip here?
Yes.
There are vessels.
Yes.
There are vessels. This is gastroduodenal artery branches. So we need to avoid intervening vessels. So I'm gonna pull my scope back a little bit to get a better angle.
Yes.
Like this.
Yes.
And then I'm gonna do puncture of this lesion, like this.
Yes.
And further. Okay. Remove the
flow. Yes. Yes.
Now I want to check again whether the lesion is punctured correctly or pushed it away. I think it's not.
Yes, so this is the lesion, right? Yes.
This is the lesion.
Yes.
So we are not penetrating through the lesion.
Yes.
The needle angle is, I think, favorable.
Yes.
So I'm going to puncture a little deeper.
Yes.
On this part first.
Yeah, okay.
Okay. We reach the
distal most part of the tumor, right?
And then from here, I'm going to use E-flow again.
Yes.
To see which area is actually ablating.
Right.
So please apply start ablation.
So we have switched on the ablation now.
Yeah. We need to see the area.
Yes.
Which is ablating.
Yes.
Yes.
So this E-flow increase, this is the part that we are ablating actually.
Stop. This is small lesion.
Yes.
So we don't need to use
too much amount of ablation.
Yes.
So Professor, you always talk about linear ablation and point ablation.
Yes.
So you prefer which one?
This is small
lesion.
So we do not use the
linear ablation.
This is point
ablation. Yes.
But I think we did ablation on some parts.
Yes.
This area
There is some part is still remaining. Yes.
So we need to ablate this area again.
Right. I switch on the flow again. Oh, sorry.
Not yet, not yet.
Okay.
I think we are in.
Yes.
Okay.
Switch on the flow again.
Yeah.
Right.
Again, and
Do we
start
switch on?
later.
Okay, on please.
Start on.
So you can see how professor is kind of putting the needle deep inside the
Yeah,
tumor,
yeah.
using that E-flow
Yeah.
for where he's
That
burning and doing it.
area is burning.
That
We
that
are-
area is burning. Okay.
Okay.
Stop.
Off.
Okay. Okay.
Let's see.
So now we're going to check again that the area that we have ablated.
Because of echogenic cloud formation, I
Right.
think the area actually shows
Shows hyperechogenicity.
Yeah.
Yes, 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 absolutely.
We will apply
Flow again.
flow again.
Right. To check for the viable tissue if there is any.
I think I don't see any
No flow.
vessel,
Yes, yes,
vascular
yes.
flow inside the
Right,
vein
right.
because of ovulation.
Right. Initially, there was some flow in the center. It's
Right.
completely gone now. Yes.
I think it is
Ablated.
satisfactory.
Yeah. Okay.
So I'm going to stop ovulation here.
Right. So, Professor, once we have done this ablation,
Mhm.
so how do we follow up these cases, or what is the protocol that you follow?
It's 6 months later and
Mhm.
1 year later.
Mhm.
And if there is any remaining lesion
Mhm.
or generally recurrence occurs within the 1 year or 2 year period.
Right, right.
Even though we are trying to ablate the whole area,
Mhm.
some we are macroscopically ablating the lesion.
Right.
But
So thank-
microscopically, there can be some remaining
Peripheral tissues remaining. Okay.
Right.
So thank you, Professor CEO, for the great demonstration. A big round of applause for him.
Thank you.
Thank you very much.
Thank you.
Thank you, and we are going to Dr. Ajay Kumar room. Jubin, may I request you to give the history and proceed with the case?
Thank you. Thank you very much.
Yes, the next case is a 61-year-old male who had complete dysphagia for last few days. And on an endoscopy, there's a growth in the mid-lower esophagus. The plan is to do an esophageal stenting. We are going to OT1. Over to you, sir.
Good morning, everybody. And Rajesh, congratulations for a wonderful meeting and for wonderful cases. Well, friends, as told to you by Zubin, that there's a growth at around 30 to 32 centimeter from the incisura, which was non-negotiable. So I like to reinforce a point here. Then when it is a non-negotiable, when you're dealing with the upper GI problems, it's very important to have an ultra-thin scope in your armamentarium. Ultra-thin scope that I'm using is 5.4 millimeter dia. It's a 190 series Olympus scope. Why it's important? Because it's important to identify the lower end if it is possible. And if you can identify endoscopically, that's the best thing. So what we'll try to do now is to try to negotiate this with the ultra-thin scope and see if we can get past this narrowing. Hopefully we'll be lucky. Oh yes, we are. See, those who deal with it, all of you will understand how important it is, because we have been able, now we are not operating in the blind. We know what it is underneath, and we know what the lower end is. So we can actually select our stent according to that, and we can also deploy it actually under vision. So here, if I have to go come back, I've already, it's important to see the fundus area. That fundus is free. So now we identify, before I come out, what I'll do is, I'll push my guide wire in. What I'm using here is a stiff jag guide wire. Well, some people may like to use a metallic, but don't use the soft, because it can be a bit difficult. It can create technical issues when you are deploying the stent over that. So while coming back, it's important to define the anatomical points. And here we have G junction at around 40 centimeter. So this is about from 32 centimeter upper end of the growth, G junction at 40. And now we need to see where is the lower end of the growth. You'll appreciate that we have reached the place where we have started seeing some blood, and here is the lower end, and this is at around 35 centimeter. So about 5 centimeter above the G junction. So if I have to take about 12 centimeter stent, our plan is to introduce a partially covered self-expanding metallic stent, because then we are not thinking of removing the stent in future, so we don't need a fully covered. And we know that guide wire will not go any wrong places, because we have already seen that it is going to the antrum. There's another advantage of negotiating the growth. And this is the area that we have to make sure that stent remains above this area. And this is, okay, that's another way of doing it. I personally don't use it, but those who use it is no problem. The advantage of this technique is that I can put my scope besides the stent and I can avoid fluoroscopy. If you are putting markers, there are two ways to do it. You can put an injection just above where you want to deploy the stent. And secondly, you can use the markers, coin, or any surgical knife under fluoroscopy outside. The problem with that is that you need to have a fixed spot to put the marker. Otherwise, it can move with the respiration and can go wrong, can misguide you.
Dr.
Yes.
Ajay?
I'll plan to put it under vision.
Dr. Ajay?
Yes.
Till you are preparing with the stent, we are going to Dr. Amol's room.
Okay.
And we'll come back in 5 minutes time.
Sure.
Dr.
Sure.
Jubin, we can shift to Dr. Amol Bapai room where the rectal ESD is going on. Dr. Jubin?
Hello.
Hello.
Yeah, Dr. Amol, you are online.
So see, we started at the dentate line over here. You can see some hemorrhoids over here, which we had to divide to get into the tunnel. And we have created a tunnel over here in the length. I will, of course, have to widen the tunnel. And we did an underwater approach. Just the irrigation pump is a little bit, the water is over. So that's the reason we're just filling it up again. But now I'll CO2 off. So I'm switching off the CO2 now. And I'm just irrigating over here. Inject here. So the important thing in ESD is to take all the vessels at the periphery of the lesion, because once you divide the vessels at the periphery, you can see that the muscle base over here is quite clean. There are not too many vessels that we have to divide. And typically what happens is when we start doing ESD, we are scared about a perforation or a deep muscle injury, and that is the reason we try and remain too superficial, and that actually causes more bleeding, because superficially there are more vessels. In the deeper layer, there are not too many vessels.
He's using a high cut mode from the vial 3.
Yeah.
So I think this is a specific mode you use during underwater.
Yeah, for underwater, because the coagulation will give you again too much bubbling. So you don't want to use coagulation as far as possible over here, except for the vessels. Inject here. Okay. So remain just on top of the muscle.
You can see that the deep submucosal plane is usually quite loose, so you will see through it. But if you go too superficial, it's very thick tissue with a lot of vessels. So
bleeding is always an enemy of underwater. So make sure that your field is very clean. Because it will stay in the entire submucosa, and then it will make things difficult. The other important thing which you can see over here is I try not to move my knife at all. The knife depth is constant so that I get a continuous and a constant depth of dissection, so that if I pull and push on my knife, then the dissection does not happen in the same plane, and then that can cause problems. You don't get a good view of the submucosa.
You can see how coagulation can create bubbles.
Yes.
And I think that's a very good reason to use more cutting currents in the submucosa, especially if you don't see any big vessels. Then I think the high cut should be able to cut through
Yes.
all those tissues.
So we use coagulation very sparingly. Whenever we encounter a vessel, we will use coagulation only for the vessel, but rest of the times we will use the cut mode, high cut mode. And this is pretty fast also, because it gives you a good PD dissection. So,
Yeah, recently some endoscopists who use it under gel. Do you have experience of under gel ESD?
no, I've never used gel. I don't think we are also.
So, Dr. Amol, Dr. Amol,
yes,
we are coming back to you shortly. Dr. Ajay is ready with the stent.
Okay.
So we are coming back. Dr. Jubin, can we go to Dr. Ajay Kumar where he's ready with the esophageal stenting? Dr.
Okay,
Ajay, you are on.
friends, what we have done is we have introduced a stent 12 centimeter, partially covered, evolution stent, controlled release stent from Cook's. See, the technical point that I want to highlight, that when you are introducing this over the guide wire, and then please make sure in the neck, if the guide wire is not stiff enough, you can cause a problem in the neck. It can curl on its own and cause a major complication. So we did that. We have to be very careful while doing that, whether you use it fluoro or no fluoro, but you need to be aware of that. Now, once we are there, we have placed the stent here. Dr. Sanjay with me has a folks. We are showing you the technique where we are doing the under endoscopic control. So we know the lower end. Now we know the upper end. So we have kept the stent above the upper end. This is Dr. Sanjay is showing you with the scope, which is parallel to the stent. And it will focus on the upper part. Now, this is the upper part of the stent. Our main thing is that this part has to stay above the narrowed segment. Now, this, can you focus here? See, my good fortune is that I have Bhagwan, तो राम भगवान से भी ऊपर है आज के दिन में. So to help me here, and of course we have a wonderful young technician here, Abhishek. So first thing is to remove the lock. Can you focus here? This is the red thing that you remove the lock here. And then there is a release button here that you have to press. And now we use the gun. So, fluoro, please keep on showing that. It will show you the release of the stent, and Dr. Sanjay is keeping a good control that the stent doesn't change its position. See, this is a very good coordination. Now we have reached a point. Can you focus here? There's a point here marked that where you had to remove the stillet. So we removed the stillet, and now we deployed. Now we are beyond retrieval stage, and now we'll deploy the full stent here. And under good guidance of Dr. Sanjay, that now the stent immediately opens up. So first we'll remove the stent assembly. And all that good thing is, normally we do not advise that we should try to negotiate the stent with the scope in the same sitting, because till it is fully expanded, there is always a risk for that it should not migrate along with the scope. But once here, though I have an ultra thin scope, I can take some liberty of just checking it in, but I will not advise for the regular scope to do that. I think we have, because in this patient, I'm very confident about the lower end because we have seen it. We know it is covering that, and we see that this is very well opened. And I think I'm more than happy. What do you say, Dr. Sanjay?
Wonderful, sir. Wonderful demonstration. You have done
check
भगवान
with
को
your-
अभिषेक कर
yes.
दिया आपने, sir. अभिषेक को भगवान.
Thank you, Dr. Ajay. Thank you for the nice demonstration.
Yes.
And I think we shift to Dr. Amol Bapai room. Dr. Amol is waiting there for the ESD.
Thank you very much.
Jubin, can we go to Amol Bapai room? Dr. Amol, you are online.
Okay, so we're proceeding. I think we are close to the end of the tunnel. Now we'll have to go out once and give me the knife and see till why. Otherwise, we don't want to skin the entire rectum. Oh dear.
You're skinning half of it already. You can see he's carefully dissecting underneath the vessel so that you're not really injuring the vessel. So you only will encounter the roots of the vessels. Like probably here is one of the roots of the vessel. So those are the individual ones that you need to coagulate, but there won't be a lot of those as long as you stay deep onto the surface of the muscle.
Nearly back. Inject here. Okay. Yes. Nice. Very.
And so usually for these vessels, you try to isolate the vessel before you coagulate them. If you coagulate them without isolating them, usually you cannot get a good coagulation. So it's almost like a surgical procedure where you isolate the vessel up and down, left and right, and then you use the coagulation to directly target on it and cause it to coagulate.
This is what I did just now.
Yes.
I isolated the vessel and then.
Yes. And then you can use a coagulation. You can see the whitening of the vessel. Once the vessel whitens, that means it has coagulated. Then you can cut. If it's still, you can still see some red or purple there, then maybe not enough.
Yes.
So you need to check. See another large vessel. Yeah. So these are things that we need to really be careful in the rectum, especially in an underwater situation where once it bleeds, the view will become very difficult. So.
Right. So pre-coagulation is the best way to actually prevent bleeding.
Do you have any selection what vessel you use? You will probably use a coag rasper or
well, most of the times what happens is you hardly ever need to use a coag rasper.
Okay.
Because if you've done a good isolation of the vessel, you can now see this is one vessel which I'm going to isolate now.
Yes.
And then we will try and think. So I dissected it on the other side. No.
This normal situations will always need a coag rasper. Let's suppose poem and others.
Yeah.
It's always
one, only one.
So
now you're turning to target with the same dual G?
One.
Yes. Okay. So I think what he's now doing is to use a lower voltage.
So I'm going to use, very low voltage coagulation. Give me the needle.
So this when in the past, I think this was first used by Dr. Toyonaga in Japan. So he called this 110 mode, where he used a very low voltage and a slow cook that will denature the protein and cause a coagulation. You can see they press onto the vessel and press, but because of the very low voltage, it will not cut It will
Yes,
just
it will
coagulate.
only coagulate.
Okay.
So now he's using the
Now I'm
force.
using the.
Now then he will change back
high
to
cut.
cutting. Yeah.
So now, so you can see we've cut through the vessel, but there is no bleeding there. So far at least. Usually it will not occur.
Yeah, so I think it's a common practice to use this mode, try and avoid changing of instruments in cases of larger vessels.
What was the setting right now with which we?
Now it's a force coag 1.0.
Force coag 1.0.
I think Toyonaga used a 0.6.
Yeah, he uses
0.6.
even lower.
Even lower. But he uses a different knife. He used the flush knife. So the tip of the knife is different.
It's a little bit more bulky.
Yeah, it's
and
larger than the
larger
dual.
than the
So the effect could be this, a little bit similar.
needle back and inject. There's a little bit of fibrosis. I think we are across the fold here. So what I remember, Anchi, when we did a retroflexion,
Yes.
that
As a
the lesion was below the fold. So
Yeah.
probably we've crossed the lesion.
Yeah, I think we
That's
can
what I feel.
start do an incision in the
Yeah,
in
we
the
can
oral
do an
side, and then we can
right.
check.
Get the CO2 on.
How within the tunnel one can be sure that one has actually gone beyond that lesion? It is just on the measurement or from
Measurement, and now you will see
Yeah,
the
over now-
staining on one side,
Yeah.
right? So still I'm not seeing very good staining.
And usually, if you have dissected enough, the lesion will become devascularized. So the color on the lesion will change.
Well, we have
Yeah.
reached probably almost here.
It's
That's
almost,
what-
you can see the blue color here, so
Yes.
almost. But anyway, it has no harm. You can still open a little bit.
Yes, we can
and-
open over here so
Yeah,
that then we
then
can.
you will know.
Yeah.
Once we exit the tunnel from inside, then we know we've gone
Give me the needle, I'll probably inject it here with
Thank
the
you,
needle,
chairpersons and
we can
moderators.
do
Uh,
An incision.
May I invite the
And
next set
usually
of
our
chairpersons
proximal
and
incision
moderators
should
for
be
the
much
next
wider.
live transmission.
One. The anal side incision, your entry incision.
Dr.
should
Jyoti
be a very
Ranjan
narrow
Mohapatra,
incision, but your
Dr. Janvi Dhar,
oral incision.
Dr. Rajesh
exit
Patel,
incision should be wider. Because
Dr.
very
Mahesh
often
Gupta,
within the tunnel you might have.
Dr.
You
Umesh
don't,
Goyal,
don't know the
know
direction.
the direction.
Yes.
and the moderators for the session are Dr. Ashok Dalal, Dr. Rajkumar, Dr. Virender Chauhan, Dr. Alok Kumar.
There's a needle.
Already we have the blue dye there, so
Yeah,
already reached to that side.
almost. So we will open up, and then we get back from the tunnel. And
Right.
once we exit, then we know, oh, we're done.
Bas. ज़्यादा भी मत करना, क्योंकि क्या होएगा? Oh, started losing there. There's a needle. Yeah. Okay, that's enough. Needle. Inject.
This again, we are putting this plain saline, no gel effusion.
Yeah.
Yeah.
Oh, that needle puncture.
Hmm.
Oh, I think
Puncture into a
it's one of
vessel.
those vessels.
Yeah.
Nah, that's all. it
Dr.
is.
Amol,
Yes,
we are going to other room. We'll come back to you shortly. Is that okay?
Yes.
that is okay. We are just doing the oral side incision now. So that's why I injected. Unfortunately, I hit a vessel. So,
Any precaution we should not hit? What do you feel? What is the way? Or it is a blind injection, anything can happen.
you can use RDI over here. I probably did not. I may have, but I did not anticipate that vessel.
Okay, so Jubin, I think we can shift to Kenneth Binmuller. He's ready with his case. So we are switching to the EUS coil and glue. Jubin, please shift to the room.
Yes, so this next case is a 53-year-old male who has a child aserotic with portal hypertension. He had intermittent episodes of melena, and this is the endoscopic image. So the plan is to do an EUS coil and glue. Over to you, sir.
No? Oh, okay, great. Okay, fantastic. Great. So I just introduced the echoendoscope, and now I'm using a scope that I don't use in my unit. So things are a little different. This is a Fuji scope. It's the EG58 OUT. Has beautiful optics, I'm noticing. It is a 3.8 channel, so it's a large channel, which we really don't need. So the large channel you'll need, for example, when you place the lambs. It has a very thick sheath. But for this procedure, you don't need a large channel. So I usually just use the standard diagnostic curved linear array echo endoscope. But you'll see then with the endoscopic view, which I assume you have, beautiful optics. And it's always, and I'm just going to repeat this over and over again, endoscopic ultrasound. It starts with the endoscopy, but we can do everything today with one scope. You don't need to put a gastroscope down first. So you see the distal esophagus, and we would just want to make sure that there aren't any large varices here in the esophagus because we're doing a transesophageal, ideally transcrural access to the gastric fundal varices. So we want to know whether there are large varices in the distal esophagus. All right, so now we're just going to carefully advance across the GE junction. With the Fuji scope, you'll notice that you actually see the tip of the transducer ahead of you, which you don't with the Olympus. In the beginning, I was a little puzzled what that was that I was seeing, but that's the tip of the transducer. A beautiful view of the stomach, and you'll see that there actually, if you only looked at this, you would say, there are no gastric varices, looks fine. Little bit of portal hypertensive gastropathy maybe, but otherwise looks fine. So you can do your whole examination with this. Because of time, I'm not going to do a complete endoscopic ultrasound, but I normally always do, starting with the biliary system, pancreatic head, etc. That's important information that you need in a patient with gastric varices. But I'm not going to do this today. I just want to show you very quickly, because of time, just sort of the key points, how to get quick access to visualize gastric fundal varices with endoscopic ultrasound. Now, one of the things you can do with the echo endoscope is go into retroflexion and see the fundus. So I'm going to show you that now. You just have to insufflate a lot of gas, but you can see here that I can visualize, you can see it at the very top next to the scope, there are large gastric fundal varices, right? And you should look to see whether there are any stigmata of recent bleeding. Are there any red whale signs, a white nipple sign, something like that? And it doesn't look like there are. Has this patient bled from varices in the past?
No.
No. So this is prophylactic,
Yeah.
but we have good data to justify prophylactic treatment of large gastric fundal varices. But again, you see a beautiful view endoscopically of these gastric fundal varices. All right, so now we got to suck out the gas because air or gas is our enemy with ultrasound. We then orient the tip of the scope towards the fundus, which is to the left like this. And now you can see I have a water pump attached to the biopsy channel. Now for the echo endoscope, unless you have a forward view echo endoscope, the Olympus one has a water jet channel, but the echo endoscopes do not have a water jet channel. So you need to attach a something that allows you to preserve your biopsy port and do irrigation. In this case, I have only irrigation. But the BioShield, I think it's US Endoscopy, allows you to have a cap. You can insert instruments, and alongside your instrument, you can also infuse water. So let's now fill the fundus with water. Water is our friend, and it's important to get good filling. So now I want you to switch to the ultrasound view, please. So are you seeing the ultrasound?
Yeah, yeah.
Okay, I don't know what the, very good. Okay, so now I'm going to step on the pedal, and this is the most important part. And by the way, I just have to mention, this patient is not intubated. I'm okay with it. I discussed it with the anesthesiologist. They feel very comfortable, but I intubate my patients when I do this. Firstly, because I'm putting a lot of water in the stomach. But second, who knows? Maybe there could be massive bleeding. And then I would want the patient tubed to protect from aspiration of blood and maybe hemodynamic instability and so forth. So think about maybe intubating and doing this under general. but we're doing it under MAC anesthesia today. So now I'm filling up the lumen, and you can see the little fish in the lake now. There's some bubbles here, and I'm pulling back, and there's that big gastric varix. You can see it nice. And what you want is to really see the outline. You need to differentiate varices from collaterals. Varices are intramural. Collaterals are extramural. So we don't want to be putting glue and coils into the collaterals. We're wanting to look ideally for the feeder vessel, but we definitely don't want to be putting them, for example, in a big gastrorenal shunt per se. All right, so this allows you to see the outline of the mucosa, and you see beautifully the varices here. And what may look to you when you look endoscopically as one big varix actually may be a convolute of smaller varices that interconnect. And that's exactly what you see here. This is a whole convolute of varices. And so this is why, even though you could target this with a gastric approach from the cardia, I prefer to pull back into the esophagus and go transesophageal from the backside. And I like to use the cruce muscle as a backboard to prevent any back bleeding. So it just stabilizes everything, and it ensures that I'm not going to get torrential bleeding, which can occur if you go from the gastric side, right? From the mucosal side, because the mucosa is thinned out. You puncture that, it's under high pressure, and it can suddenly just start bleeding torrentially on you. So you need to be prepared for that. Now, how do you find the feeder vessel? Well, there's a little trick. And the trick is to find the cruce muscle, and you see the cruce muscle up here. So this is the left limb of the right cruce muscle. It's a limb, and it's a thick fibromuscular structure. And typically right below that is where the feeder vessel is. And if I try to follow that vessel for you, you should see it feed into these big varices. So here, let's go look again. You see the big varices there, and you see the feeder is back here. Let's turn off the Doppler because it's distracting. And here you see it's going, the feeder's up here. So if you just go right into here like this, you can do it. It's fine. But you're going to have to put a lot of glue in. So I'd like to get it at the root, the feeder root. And so you kind of follow that back. You just pull back. You know you're coming into the esophagus. First of all, you feel it, right? You feel like suddenly it pulls through the GE junction. You feel that. But here you can see the cruce muscle. So now let's get our 19 gauge needle. And this is where you need to have a good assistant.
Dr. Binmoller?
Yes.
We are just coming back till you are ready with the needle.
Okay, good.
That we are going to Dr. Amol Bapairom. He want to show something.
Okay.
Over to Dr. Amol Bapairom.
Yeah.
So which one is feeder and which one is the first one?
Thanks, Rajesh. Okay, so we came out of the tunnel and we did a proximal incision. And you can see over here that as we are dissecting in the submucosa, you can see this opening. So this is where the tunnel is open. This is the exit point of the tunnel. And this is what I wanted to show you. There's also a vessel over here. Give me the needle. Now, the vessel is better seen from this side. So we're going to cook it and divide it from this side and open it a little bit more before we go back into the tunnel, and then you widen the opening from the tunnel side. So that is basically the plan.
I think just now we were discussing at this angle, the knife direction will be towards the muscle.
Towards the muscle.
So it's more dangerous.
Just a little bit opening. So because sometimes what happens is you may not find the opening when you go back into the tunnel. So what I'm going to do is I'm going to inject a little bit over here so that I know when I go inside, and maybe open.
Yeah, I think you can also open here. That's on the surface.
So, Dr. Amol?
Yes.
You want to show something, or we can go to other?
I'll just go into the tunnel
Okay.
and show it from that side.
Okay.
Okay, just give me 1 minute because there is bleeding. Oozing, I will just stop this. And let us go back into the tunnel.
Yeah, nice. Here.
That's the opening over here. Now I will go out from this, right? I will widen it further. I will open it and then I will retroflex through the tunnel, which will give me a good traction. So we will continue. We will, I think, intermittently you can come back over here.
Thank you, Dr. Amol. And Dr. Vinay Dheer is ready with his case. So I request Dr. Jubin to start with Dr. Vinay Dheer case.
Yes, so the next case that we have is a 35-year-old male, chronic calcific pancreatitis post-phrase procedure, and recurrent pain, fever, and jaundice. So he is having cholangitis, and this is an MRCP. Multiple times ERCP has been attempted with a failed cannulation, including by a NKP. So plan is for an EUS-guided antegrade biliary drainage. Over to you, sir.
Hello.
Hello.
Can you see me? Can you hear me? I can't hear anyone. Hello.
We can hear you.
Okay.
Who is there? Hello.
Janvi.
Can you speak a little loud? I can't hear you. Hello.
You are audible, sir. Very well audible.
Okay. So you heard the history. I am already into the stomach, and we have identified a dilated radical. It looks like a segment 2 radical.
Yeah.
Fluoro dikhao. Please show the fluoro.
So the plan is to do a EUS antegrade drainage, right? For this with the covered stent.
See the fluoro image.
Yeah, it's now visible. Fluoro is
So
visible.
this is the segment 2 puncture just below the G junction. Not a segment 3 puncture. And I have Dr. Sridhar with me, who is also an expert in EUS-guided biliary drainage. So he will help me out. So the more critical thing here is to get a good position and hold it. So this looks like a good position. Pakado scope. Now what we will do is, we will take out the needle a little and see what is the trajectory of the needle. Try to correct it to see that it goes in the bile duct and not anywhere else. Minor changes. So here you should not hurry. Aisa kar rahe, aisa. Yeah. This looks good. ये एक single है ना, बस. Now let's see if we go in. Doppler once, we'll do the Doppler. So you see there are vessels close by. So we have to be careful in not puncturing the major vessel. Stop the Doppler. And because we are at the G junction, there are lots of movements. Okay. So we are in. First step is aspirate bile. There is a lot of movement here. We have to be careful.
Yeah.
So we are getting yellow bile.
And a lot of debris inside.
Yes, Sridhar. There is a lot of debris. So whether it is a cholangitis or what it is, we'll see. So the first thing is to use a little contrast and see where we are going. So scope position has to be kept very stable. Fluoro. Are you seeing the fluoro picture?
Yes, sir, it's visible here.
Move the fluoro, please. Show me the other side.
You can show the,
More.
Yeah.
Okay. So we are not seeing the bile duct as yet. Saline. Yeah. Now we are seeing, I think, little saline.
Any preference, sir? Segment 2 or segment 3 that you have?
I prefer segment 3, but if there is no choice, I go for segment 2 also.
Yeah.
So you are seeing the bile duct below. faintly recognized. It is dilated. Intrahepatic biliary radicals are also dilated. Now we are using a O3 Terimo, and we try to go into the bile duct. Because this is segment 2, we expect it to go easily, but you never know. So Bibin with me is passing the wire. Now the main job is being done by Bibin. I am just holding the scope, keeping it steady.
I think Bibin is an expert assistant at these
Yes. Fluoro. फ्लोरो प्लीज, कंटिन्यूअस फ्लोरो, शर्मा मत फ्लोरो करने में। किधर जा रहा है? उल्टी डायरेक्शन में जा रहा है क्या? दिख नहीं रहा है मेरे को। हाँ, आया। वेरी नाइस, वेरी नाइस। नाउ वी हैव टू गो डाउन। वो बाइल डक्ट दिखता है ना? धीरे धीरे, नहीं, अदर डायरेक्शन।
Passing the guide wire is the critical event at least.
Absolutely. थोड़ा withdraw कर।
You need quite an expert assistant usually.
Yeah, now put. So this is the step in antegrade, as Sridhar is rightly saying, where you take maximum time. And this needs expertise. You see how nicely Bibin is trying to go into the bile duct. But I think, have we gone into the right system?
Yeah, it looks like that.
धीरे धीरे withdraw करो. Yeah, here. Yes, this is better. धीरे धीरे. Go down. So you see, we are in the bile duct now. And there should be the stricture also. जा रहा है आगे? Yeah, very nice, very nice. नीचे दिखाओ थोड़ा सा. हाँ. धीरे, आराम से. See if it is progressing. So there is a tight stricture there. नहीं, टिप को निकाल थोड़ा. उधर प्रेशर ज्यादा पड़ रहा है. टिप को निकाल के दूसरे डायरेक्शन में.
Do you like negotiating the wire right away, or do you often change?
If it goes easily, no problems. Otherwise, we use a cystotome. Like in this case, it looks like, इधर दे. It's practically closed. इधर दे. घुमा, दूसरी तरफ. Yeah. Tight है. Okay. Cystotome coil कर ले. We'll use a cystotome here.
Yeah, I often feel that the issue is about pressure transmission across the wire.
Yeah. And you should have all kinds of wires. O32, O25, O18. You should have Terimo, you should have EUS-guided. All kinds of wires should be at your disposal. Nikalu?
So, Dr. Vinay?
Yeah.
Till you are putting the cystotome, can we go to Kenneth Bin Muller room?
Yeah, please.
So, Dr. Jubin, can we go to Professor Kenneth Bin Muller, who is waiting? Dr. Jubin? Yeah. Professor, you are online. Dr. Kenneth, you
Fantastic, great. And I forgot to introduce my assistants, who are very important for the success of the procedure. Radhika is to my left here, and Manush, right?
Manoj. This is Manoj.
Oh, sorry. Manush is, okay, good. So at any rate, I've got great assistants. Now, just to show you once again, so we have here, this is the gastric varices, what you see endoscopically. We follow this like this, and the feeder is up here like this. I can turn it, and back here, these are often large gastrorenal shunts, and we don't want to go, these are collaterals. These are outside of the gastric fundus. You can see the spleen is in the back here, so we don't want to target that. But listen, don't worry. I mean, if you put coils in here, as long as they are appropriately sized, it's not a problem. So I'm going to pull back. I have my assistant who's going to hold my position, and I'm going to target two areas. So here, this is the feeder here. So let me target this space right here. Let's get one coil in there. And then I'm going to push through and put a second coil here. And I just need to wait with respiration for a good moment to thrust forward and target. I've already advanced the sheath out from the elevator. That's already done. And I'm going to look for the echogenic linear line. You can see it right up at the very top here. Here, there's the needle, right? And now I just have to coordinate this with the respiration because I'd like to have the cruce muscle in between. And I want to target more this part here. All right, so this is where your assistant holding is so critical. Now we can measure the distance here from the tip of the needle. Oops, I pressed the wrong button. It's on the other side here. Good. It's the opposite in India. So it's about 2.3 centimeters, right? So I'm going to dial in from here to a little over 2 centimeters. So I know that I don't overshoot, and I'm screwing in tightly, and I'm ready now to puncture. So let's just make sure that the trajectory looks correct. And now I'm in. All right. Okay. Now let's wait a second, because I may be alongside, because sometimes it will push the varix. And I think that's in fact exactly what happened here. So I may have to fine tune here a little bit. Okay, turn this way here. Hold it right there, please. Okay. Okay, see it? Now I got a stab like this. Okay. It's fine. I'm inside. You can start to aspirate and you should get blood return.
Cameraman.
But if you don't,
Focus.
Then we're not in. Then what you can do, then it could be that the tissue clogged. So this is saline that we're injecting. We're going to inject again some saline. We're obviously in, but it could be that some of the tissue plugged up the lumen. Yeah. It's clearly in there. You saw the bubbles, right? Okay, now when you aspirate, you should get blood. See blood return? Now we take this off. Okay, unscrew. Now we're going to attach the loader, the coil loader. You'll flush with water. That's correct. This is saline. We're using saline because we're going to inject 2-octocyanuracrylate afterwards. But first comes our coil. So we've selected a large coil that's 20 millimeters. It's the largest one we have. There it is. It's the Nestor coil from Cook. And they're different coils. The Nestor is fairly floppy, but it has a nice wool strand, synthetic fibers attached to it. The MRI coil is stiffer. So I'll sometimes actually place the MRI first, like a scaffold for the second coil. And I may put multiple coils in here when you have very large varices. So the number of coils I use depends on the size of the varix. So if the varix is over 2 centimeters in size, I'll put 3-4 coils in there. If this varix is 1 to 2 centimeters in size, I put 2 coils. And if the varix is between 0.5 and 1, then I'll just put 1 coil inside. All right, so now as he pushes through, you'll see the coil come out and it's starting to unravel. What's important here is to slowly pull back as it unravels. Are you pushing out? Okay. Usually I see it a little better. There it is. It's starting to unravel there.
Yeah.
Okay. Good. Our first coil is in. Let's put the second coil. Pull this out, and we're going to put a second coil immediately. So you need to put a few coils into these very large varices. So now the loader back on, please. And he flushes first. Now, technically, you aspirate first, confirm, but you see the bubbles, so it's all good.
Yeah.
All right, good. Now put the loader back on. So the flushing is just to make sure that the blood is not clogging the needle, right? The blood will easily clog the needle, so you want to always keep it patent. All right, so now what he's doing is using the stylet to push the coil into the FNA needle, the 19 gauge. And once the coil is inside of the needle, then he removes the loader, right? And then he uses the stylet to push the coil all the way through the length of the FNA needle to deploy it. So it's a little tedious. You need to have an assistant who's tall. I have a short assistant who actually has to step on a stool to have the correct height, because you have to be very high up for this. All right, now you can see the second coil should be coming soon. So I'm just holding my position and we should see that one start to come out. Now, you know, the flow in these varices can be really quite vigorous. The second coil is in. And honestly, I think a third coil would be appropriate. So, but you can see the coils start to fill. The idea is that you really want to have a sufficient scaffold that will hold the glue in place and prevent it from embolizing, right? You want to avoid systemic embolization of the glue. There's very rapid blood flow in these varices, and especially when these patients have large gastrorenal shunts.
Professor?
So we're going to put one more coil in. You come back to me, and then I'll show you the glue injection.
Yes. So, Dr. Jubin, can we go to Dr. Vinay Dheer room where he's ready? Dr. Vinay Dheer.
Am I live?
Yeah, Dr. Vinay, you are live.
Okay, so we are just gone through into the duodenum. It's a very tight stricture. So I'm going to burn it a bit with the cautery.
Yeah.
Very tight. Very difficult. So Sridhar and Bibin combined together and finally managed to get it across. Ready? Okay, नीचे दिखाओ.
You can show down.
Inject, control.
Yeah. So usually we expect the angle to be a little more acute, but it seems more obtuse than acute. So
because of prior surgery, normal anatomy doesn't hold. Fluoro, inject. So we are in the duodenum, as you can see. D3 में वायर डालो, फिर मजा है. D3 में जाएगा?
जाएगा. करंट डालेगा तो ओपन हो जाएगा, I think. So then maybe you can pass the wire better.
हाँ, इधर
जाएगा.
ये देखो. दूसरी तरफ. घुमा. हाँ, दूसरी तरफ. हाँ, बस, फर्स्ट क्लास. हाँ, पर थोड़ा मेरा एंगल बदल जाएगा ना सिस्टोटोम का, फिर तू स्टिफ वायर डाल तो तेरे को आसानी होएगा.
Right. So I think we are pretty deep in the duodenum, so I think maybe we can.
थोड़ा एंगल.
Yeah.
हाँ, अभी ले.
And maybe you can switch to a stiffer wire now.
Yeah. Now we change to a stiffer wire and place a stent.
Yeah. Can you show above and maybe unzoom a little?
Zoom बंद कर दो, हो गया zoom का काम.
Zoom का जरूरत नहीं है अभी. You can unzoom, yes. And can you
ऊपर दिखाओ, ऊपर
दिखाना.
Scope. Many a times the scope moves away when we are doing all those things.
Yeah.
Okay, अभी नीचे दिखाओ फिर से.
Yeah. Okay. Very good.
नीचे थोड़ा पीछे लेता हूँ मैं, ये थोड़ा एंगल ठीक नहीं है. चलो डालो. Are there any questions from the floor? This will take another 5 minutes and we are through then.
Yeah.
Hold it, Kohan. Yes.
Yeah, I think we can. चिपक रहा है. The wire is almost there, I guess. Yeah. You can see the wire on fluoro.
Can you see the wire coiling there?
Yeah.
I am withdrawing my assembly now and we will inject little more to see where is the papilla.
Right.
कोई बात नहीं. So this is still the duodenum.
Yeah, you can pull up, I
It
think.
is still the duodenum. You
Yeah.
can see. So this is an important step. You have to know where. अरे अरे ये क्या कर रहे हैं? भैया गड़बड़ मत कर यार.
Then that would be
Stomach. Or is it duodenum? ऊपर दिखाओ.
it's the LPJ, I think that is.
Yeah, this is anastomosis, surgical anastomosis.
So that's an LPJ.
You
that's
see,
the-
that is where the ERCP was failing.
Yeah.
So this is the anastomosis. So now you have two loops of duodenum and jejunum together.
Yeah.
So this is थोड़ा और withdraw करते हैं. And then you
Yeah, then maybe
inject
we can
little
check,
more. Yeah. And that is why I think the ERCP was consistently failing. Inject.
Yeah.
Yeah, I think this is where it is.
Yeah.
So this is where we'll place the stent.
Right.
I'll
So it
try
looks
to
like a
see-
short stent, a short stricture, sir. Right?
Yeah, 4 centimeters should be more than enough. ये जा नहीं रहा है आगे. क्यों नहीं जा रहा है? थोड़ा वायर निकाल. और
So Dr. Vinay,
yeah,
till you are settling, I'm going to Professor Bin.
yeah, go ahead.
So Dr. Jubin, can we shift to Professor Binmola room?
निकालो.
Professor, you are online now.
Yeah, so we actually could not inject the glue yet because an important step was missed. You have to always flush the needle with the saline before you put the next coil down. So you want to make sure that it's really lubricated, really. So when we were pushing the coil down, we had some difficulty pushing it all the way through. So I've got a new needle now, and I'm just going to now inject the glue. So I have to repuncture again. So we just have to go through the steps one more time. But it's fine. I mean, the coils are in there. They look great. And I just need to get a good position again. There's the cruce muscle. Let's look for the varices. There you see the varices, right? There you see the coils that are inside right here. Right? So we're just going to hold this position. And this is where I'm going to first advance the sheath out. Very important. Okay, the sheath is out. Now I'm going to advance the needle out just to sort of see where it's coming out here. There it is at the top. All right. Then I just have to target now where my coils are. So I want to target that spot. Okay, just hold it like this. So the only disadvantage now is I don't have I have a lumen that's filled with coils, but the good news is it's going to hold my, this should be in. So the most important is to aspirate. Okay, aspirate, please. Aspirate to see if you get any blood return. No, we just put the glue in. So let's see if we get some blood return. If not, I have to redirect. Okay, no blood return. So if you don't have blood return, you don't want to inject the glue. You never want to inject the glue. That's the only drawback of, I think I may be in there. Yeah, you may just, if you flush, you may just get lots of, just aspirate again.
Yes.
You got blood? Good. Now I want you to inject the glue here.
USA.
So you
And,
inject it slowly. So the bubbles should be, you should see the bubbles in there. Their bubbles are there. Okay, and you see it filling the varix too, right? Okay, so slowly, over 45 seconds, slowly let it drip in. And I realize you don't see it so well because there's lots of coils in there, but just slowly push it in. And it will first fill the dead space. It's about a cc that fills mostly the dead space. You just hold your position. He's just very, very slow. The idea is really to drip in the glue so it attaches to the coil.
And the glue we are using is 2-octyl.
This is 2-octyl, so this is different from N-butyl. Now we're going to flush out the glue that's in the dead space into the varix very slowly. And it's going in very slowly. So the idea is we want all of that glue to attach. And when it's fully in, is it in? Okay. It's fully in, right? Yeah. All right. So now what I do is I pull back And I'm going to now advance the sheath out in front of me. You'll see it right there. There's the sheath on EUS. And I'm going to pull the scope out completely. So I'm not going to pull the needle out of my working channel because there's a small risk you could get some glue on the tip, even though there's a balloon on the tip of the transducer. And then you can see here, we have the tip. There's no glue. It looks fine. And then now I just have the assistant wipe that off, and then we can remove the needle.
So
All right. So we
thank you,
remove
Professor.
it now.
Thank you for the nice demonstration. A big round of applause for him. And I request Dr. Jubin to go to Dr. Vinay Dheer. Dr. Vinay Dheer is ready with the case. Dr. Vinay? Dr. Vinay, you are online. Dr. Vinay?
Yeah. Can you hear me?
Yeah, we can hear you.
Okay. Can you see the stent in position? So we have positioned a 4 centimeter fully covered stent across the stricture, and we are just going to deploy it. Okay, let's deploy.
Start deploying.
Slow, slow, slow. 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 Yeah. Deploy. Very tight. Very tight. Okay. So this is deployed. You can see the stricture, short stricture, very tight. It will open up slowly.
Right. Okay. Great.
Okay. So the procedure is done.
So thank you, Dr. Vinay, for the great demonstration. And this was really a challenging. 3-time ERCP was failed. And I told Vinay, because we have no other choice.
Right.
Because the 3-time ERCP failed, needle knife was tried outside. And patient was referred especially from Kanpur for this procedure. And excellent job. And I would like to request now Dr. Jubin to go to Dr. Sandeep Laktakia. He's ready with the GJ case.
Right.
Dr. Jubin?
Yes, sir. So this patient is 77 female who had obstructive jaundice and vomiting since 1 month. A CT showed a carcinoma GB with gastric outlet obstruction. She underwent a PT-BD outside for biliary decompression, and now she's planned for EUS-GJ. So we move on to Sandeep sir in OT1.
Dr. Sandeep?
Yes.
You are online.
Hi. Can you see us and hear us?
Yeah, we can see you.
Okay. So good afternoon, everybody. And thank you, Rajesh, and your entire team at Medanta for hosting us here. And with me is my dear friend Prakash Zakaria. And I am ably supported by Jayan Samanta and Jahangir in this room. We have Srinivas, Bhagwan, and Mohit to help us do the procedure. This, as you heard the story, this patient and Dr. Vartika from the anesthesia team, thank you very much. So this patient is having gastric outlet obstruction. She had a nasojejunal tube for the feeding purpose, and the plan is to do a gastrojejunostomy. We are using a device called as E-pass balloon. If your cameraman can focus here, this is the tube. So we have placed the tube inside, but I just want to show externally, it has 4 channels in the proximal end. This entire tube is about 2 meters long. It's a very floppy tube, but has 4 channels in it. The purpose of 4 channels is the 2 orange ones are balloon. One is for a forward balloon and the second is for the back balloon. These 2 balloons take about 30 to 40 cc of saline and contrast. And the intervening area between the 2 balloons is 20 centimeters long, which is filled with saline and contrast, which we will do right in front of you. Since this balloon is very floppy and likely to coil in the stomach, we use an over tube, which is still hanging here. I've called it here. And it's going all the way through a over tube into the stomach, across the stricture, deep inside the DJ flexure. If I can have the fluoroscopy image now, can we have the fluoro image? You see the balloon there? Janvi, can you see that on the screen? So this is two balloons. There are lead balls, 6 lead balls at the tip. Then there's a forward balloon, which is filled with 30 cc of contrast and saline. And the other balloon is in the third, fourth part of duodenum. This balloon is going over the DJ flexure. The device is going over DJ flexure. This is E-pass balloon, and this is a gift from Takao Utoi to me. So now what we'll do is we'll inject the intervening area between the two balloons with contrast first. Can you have fluoro, please? Fluoro on. So the purpose of the balloon is to trap the fluid, make the target organ fixed. So you can see the contrast filling from the forward balloon and coming backwards. So it's filling with saline. So we will fill this intervening area at least with 100, 200 cc of saline, depending on solution, which will have coloring agent, saline, and some contrast. So what is this? Okay, some more contrast. So 10 cc contrast gone, 10 more cc has gone in. And you see there's no contrast going forward. So that's why we have trapped this loop. It's kind of become little fixed. I know many people can do freehand technique, but that has its challenges, and sometimes the jejunal loop is very mobile and can go away from the stomach, which can lead to perfect. Now we're filling it with methylene blue and saline. So enough of contrast now. Now we will fill it more. So keep telling me how much is gone. So 40 cc is gone after this. Okay. We'll also put the endoscope inside now, EUS scope. So that's a very nice loop that we have, a descending segment, which will be our target from the stomach to create a GJ. Prakash, you would like to add something?
Yeah, so this is a tube which was originally conceived by Dr. Itoi.
Prakash has also made his own balloon. I would like him to answer.
Yeah, the one tube which we have created is this.
Can the cameraman focus on him in a big screen? Yes, please.
This is about 150 centimeters long. It's a polyurethane tube which has got again all the 4 ports, but it has got the additional port of guide wire that has got a hollow metallic stylet. So that makes it very stiff. So you can pass this tube without an over tube. So that is the difference between this tube and the Professor Itoi's tube. So placing the tube across the DJ flexure would be much easier. Okay. And here with the over tube, then you will have to place the Professor Itoi's tube. So again, the rest of everything is the same. The distance between the two balloons in this is around 12 centimeters, but here it's around 20 centimeters.
Fluoro, please, fluoro.
So once the bowel loop is distended, then you can visualize it from the stomach. Yeah. So now you can see the bowel loop slowly. Yeah.
So now I am torquing the scope, and what do you think about this loop? This looks good.
Very good.
Okay, can you make it bigger, please? Image bigger? Yeah. Jahangir, please help me in that. Little more bigger, thank you. Yeah, that's better. Okay, that looks like a very nice
it's a very nice
segment. And this is a good target to puncture. Sometimes we are perpendicular to the bowel. Can you have the stent ready? Lock kar do.
So Sandeep, which stent are you going to use?
So we'll use a hot Axios 20 millimeter diameter balloon stent. Okay. So I'll not lose this. Thank
you. For the beginners, how much amount of runway do you think you need to keep safe for this 20 millimeter Axios?
Yeah.
As much length as possible.
Yeah. At least a minimum of 3.8.
Yes.
Yeah. So that is what is recommended, because once you deploy the distal flange, it will come back. So you that you have to have that space for it.
Fluoro, please, fluoro. Yeah. It moves from.
Yeah, you can see it very well now.
So it's seen on X-ray well, but on EUS I've lost the image. But I'll just fix everything and then get back the same image. Can you have the Doppler there? Okay,
Just,
that's right.
yeah, just
So
hold
we'll
it there.
start
yeah.
with the, bring it closer.
Yeah, you can see the thing has gone into the jejunum, that boiling water sign. So you can see
So
that.
I'll now
stent has
push
gone.
it deeper in because you have good landing space. And Jahangir, if you can use a pointer to point at the tip of the.
That's the tip of the catheter.
We'll remove the safety lock mechanism, deploy the inner flange. Wait for a while, let it expand. It's expanding now. That looks good.
Yeah, it looks very good. Yeah.
Satisfied?
Yeah,
So I'll pull
when-
back now. Pull back and now lock it again and deploy the proximal flange within the channel of the scope.
Right.
Okay, so
Yeah,
that's
that's
done. Once that is done, then we go to the endoscopy big now. Endoscopy big image. So we're beyond the DJ flexion, the very proximal jejunum. And once we have it, we'll distend the lumen of the stomach. Pull back and turn the other way a little bit, right side. And
Yeah.
you see the blue
You can
color,
see
that
the
means
fluid.
that the stent is in position.
Excellent.
I think that looks fine. We'll remove the assembly.
So thank you,
Yeah.
Dr. Sandeep, for the very nice demonstration. And any question for Dr. Sandeep? From the chairperson, from the audience?
That's a nice demonstration, Dr. Sandeep. No questions.
So we can also try to look at the jejunal loop from here. I try not to inflate the
Do you
stent.
dilate it?
I prefer not to let the stent expand on its own. That's sometimes we can lose or dislodge the stent from its original position.
So Dr. Sandeep, if the time permit in the evening session, I will show the free hand technique.
Okay.
This is the
free hand
safer technique and we are
Yeah.
going to demonstrate the free hand technique. So the time permit, then I am going to demonstrate.
Yes.
Now I
Good.
request Dr. Jubin Dev Sharma to shift to Dr. Amol Bapai room where I think he is near completion of
Thank you.
ESD.
Thank you very much.
Thank you. Thank you, Dr. Amol Bapai.
Hi,
Dr.
Rajesh.
Amol, you are online.
Yeah.
Hello.
Rajesh, I think your confidence in me is probably more than what I have, in the sense, or my speed. So
I think one of the finest third space person. So I'm very confident that you are going to perform everything.
yeah. No, so we're going across and we're proceeding. So we are taking the dependent edge now. I'll just show you, I'll just divide this vessel and then probably show you what all you've done so far.
I think it has not been an easy position, and also it's a very vascular lesion. So Dr. Amo is very, very careful and using his technique to coagulate each of those small vessels. So you can see the field is so far very, very clean. So we're very patient in terms of dissection, but still he's making very good progress. And I think your confidence is good. Rajesh. We all have confidence in Amo.
No, we'll of course finish it. No doubt about that. So the plan is, see, basically what we've done is we went through the tunnel and so I just want to enter the tunnel again and show you, because the polyp is now falling a little bit. It's a little bit tricky to get inside, but there I am. So that's the tunnel. We opened the proximal end of the tunnel and we went out. Then we retroflex and I'll also show you the so we opened on this side a little bit and then we opened more on the dependent side. So we have opened on this side and now we are trying to go from the anal side and take a part of the mucosal incision over there. So we have widened the mucosal incision on the anal side and we are dissecting over here. So let me come back completely. Okay, can you see over here that we have dissected the lesion from the anal side also, and as I float the lesion in the fluid in the saline, you can see that the lesion lifts up very well and it floats, and then we can see the muscle layer quite well. So the bigger, I want to finish the dependent side first because then it will make the non-dependent side probably easier, because what is going to happen is if I try the non-dependent side, then the entire lesion will fall downwards, and then we might have to make the patient prone to actually bring out the lesion and do the dissection on the dependent side. So that is something that we don't want to. So when we are dissecting on the anal side, the hemorrhoids actually cause quite a bit of difficulty in identifying and the visualization, because there's a lot of little bit of oozing and it's a very vascular field. So you have to be very careful and make sure you are dividing every small vessel after coagulation and then doing it. So we are making slow progress. Okay, there. See, immediately whenever I try and use, we will inject here.
These all will be part of the same hemorrhoidal cushion.
Yeah, there's a hemorrhoidal cushion. Great. Another important thing is to also keep an eye on the blood pressure of the patient. Because sometimes as the procedure, because of distension, sometimes the patient's blood pressure shoots up and that makes it more vascular. So inject it. Keep injecting, keep injecting, keep injecting. Okay. So I can see that the patient is straining quite a bit, and that means that he is distended. So sometimes for these kind of patients, we might have to, inject. Just take a break, go proximally. I did that a couple of times. So you can see I'm not really concerned about trying to identify the bleeding. I'm first injecting underneath, because that might give a little bit of cushion.
Mechanical sample.
So would you consider using RDI in this situation?
Okay. But the main thing is the vessel is underneath. Unless I actually come in fast with the vessel, RDI is also not going to.
But you do see the site of the bleeding a little bit clearer here. So for the audience, I think RDI is the latest function from the Olympus X1 system. It added on an amber light, which is somewhat different from the usual white light. And the key of amber light is that it's highly absorbed by hemoglobin. So when you shine this amber light onto the surface, the site of the highest hemoglobin concentration will appear darkest color. So it would appear like dark yellow or dark orange. That will help you to identify the site of bleeding. And I guess for us, we don't want to see red. So if it's less red, it may be more calming or soothing. for me, at least.
Okay. So can we have the patient? We'll probably turn the patient, because I think we'll have to turn the patient to the right lateral.
Sure.
Because Otherwise, we may not be able to identify.
The blood pooling is a bit of
yeah,
problem.
the blood pooling is causing this thing. So, can we turn the patient?
We have tried to find RD mode to be really very helpful.
I think if you see a bleeder outside of a lot of bloods, then it will help to identify exactly where. If you see a lot of bloods, then you will find that one point.
पहले टर्न करो नहीं तो स्कोर नहीं आएगा
Shoots the RDI.
नहीं तो मैं निकाल लूँ उसको और बाद में
There are
डाल
actually two modes of RDI, RDI 1 and RDI 2. So RDI 2, I think, has been reported by Mohan's group that during POEM, you can identify the deeper submucosal veins so that you avoid cutting them initially or cutting them when you're doing the
patient is not very distended. I'm just looking at the abdomen.
Yeah.
Because we used underwater most of the time. So
Amol, Dr. Mahapatri here. Do you use coag grasper in these cases?
Well, yeah, meaning if you need to use a coag grasper, definitely we use a coag grasper. But unless I identify the bleeding spot, I'm not going to shift to the coag grasper because
change to RDI mode.
Knife, I can suction by the side of the dual knife. But the coag grasper is a little bit wider instrument, and what happens is your suction is compromised when you put in a coag grasper. So you don't want to shift to a coag grasper too early in this thing. Only once I identify the bleeding spot, then what I will do is I will try to tamponade it with a cap, and then exchange my instrument.
I think the main point is the scope we're using has a 2.8 mm channel. So for the coag grasper, it's somewhat big compared to the water channel. Some experts like to use the therapeutic endoscope, the 290T from the Olympus that has a 3.2 mm channel. If you have such a situation, then you will have an easier suction. So that's one of the drawback of using the coag grasper is the suction limitation. But I think Amol has already identified the bleeding point. So he'll be trying to coagulate it with the knife first and see if he can stop the bleeding. And I think he successfully stopped it.
See, just changing the position made a whole lot of difference.
Yes. Yes.
So that is very important. Don't be any kind of this thing to changing the position. Inject karo. And it also makes the dissection much better, I think. Keep the knife back. You may have to shift to a coag grasper. I don't know. But practically nowadays, with this technique of coagulating with the tip of the knife, the use of the coag grasper has significantly reduced.
Right.
Even in POEM as well as in EUS.
I think the more time I use the coag grasper is maybe in the stomach where the vessels are really big. But I think there are still techniques like what Amol has shown that people have been doing it with gastric ESDs, even with the same coagulation mode, and they don't need to change. So this is a really handy method because changing instruments sometimes takes time. And
it spoils the field. Maybe you get distracted.
Yes.
That is the other point which happens. So now I'm going to inject here. Somebody's calling. Inject here. Inject here. Okay. Inject. Wait a minute.
So we had a discussion just now whether or not we need to add local anesthetic in the anal canal procedures. So Amol mentioned that he will use local anesthetics, but usually after completion of the procedure, because lesion is very near the dentate line, so the patient would have somatic sensation. almost like a hemorrhoidectomy procedure. So he would add the LA just to avoid
Dr. Amol?
pain.
Yes.
Can we go to Dr. Nilay room? Is it okay?
Yes, no problem.
So Dr. Jubin,
Right.
can we go to Dr. Nilay where he's doing the
Yes.
pancreatico-gastrostomy?
Yes, sir. Very briefly, this is a chronic calcific pancreatitis post LPJ, and now with the current pain abdomen, you can see the MR images. The plan is to do an EUS pancreatico-gastrostomy.
There?
Sir, you are live.
Okay. So basically this patient has had Price procedure, LPJ, and also jejunostomy. So, and there is an impacted stone at head and genu junction. If you see, the marker is at PD, and if you go below down, you see a white structure. That's an impacted stone. ERC obviously is not possible unless you do it enteroscopy wise, and before that you have to do ESWL. So right now our plan is to drain the dilated duct which is there in body and tail, and we would try to puncture at the genu and try to pass the stone if we can. In that case, if it can do it, then we'll place a stent between the stomach and jejunum. Otherwise, we'll place stent between the stomach and the PD. So, yeah. Marker le le. So my first thing is to puncture the duct. This is fluoro. Contrast. Fluoro.
इसका फोन बज रहा है तो
Fluoro. No, we are yes. So you can see the duct there. You can see the contrast going into jejunum also, and the duct is dilated, mildly dilated, not very much dilated, in body and tail. Can you see there?
We can see Dr. Nilay. We can see Dr. Nilay.
You can also see in EUS air bubbles.
मॉनिटर इधर घुमा सकते हैं एक्सरे का मॉनिटर थोड़ा साइड में कर हाँ
And Shehzad is helping me out, and Sanjay is holding the scope for me. थोड़ा बाहर निकालो, मुझे लगता है एक मिनट दूर वायर तो जाओ ना ना वायर देखा तो नहीं क्या जो वायर से बस हाँ आई हाँ हाँ मन लगे थोड़ी हाँ नहीं I think it's in the pancreas, but actually हमारे थोड़ा pull करवानी जरूरत थोड़ी पाँच नहीं No, we are not in the duct actually. Okay, keep the wire with you. एक मिनट वायर तेरे पास रख. Let me now see. Fluoro. See. Yeah. So we have gone into jejunal loop, as you can see. Actually, needle had come out a bit. So what I did was I punctured it again. Okay, now what I'm trying to do is holding my scope steady and trying to take out the needle. Okay. Just a minute. Yeah. So you can see PD is hardly visible. Okay, so I'm keeping the scope steady. I can still see the wire. That is most important. If you change the axis, cystotom will not go. H2, yeah. Yeah, we are too much into the Jeju now. Cautery. There is no cautery.
Cautery is there?
It's there. It's too far off. I can't move. Yeah. So we are using auto cut.
Cautery on.
Okay. Keep it on, please. Keep it on.
Angle change Pug. Foot switch. 1 minute.
It's not doing. Cautery is not working properly.
Green ayo, bas હવે કપાત.
I think we have gone in. Yeah. So now we'll change to a bigger wire. We have moved a little bit over here, but that's fine. I can still see the cautery track.
Dr. Nile?
Yeah.
You have 5 more minutes to go because after that 5 minutes for Amol and we are done.
Okay. हाँ 4-5 લૂપ હતા હું એલિવેટર થોડું ખોલું છું. Okay, so I'm taking out now cystotome. इधर मेरे को बूथ चाहिए.
भाई बूथ जो है
ओ
कैप स्कोप कैप.
इसमें 5 फ्रेंच चाहिए. बहुत छोटा है.
5 फ्रेंच.
No, I moved from here.
Yeah.
But then give me a longer one, the longest one.
લાંબો યસ 10 વાળો. અરે ફ્લુરો માં જોઈને જ નાખ્યું.
ये moved away.
યસ પોઝિશન આઈને જોઈ પડી.
અહીંયા બૂચ લઈ લેજે. બૂચ લઈ લે. નહીં don't do.
પકડી રાખો.
કે હું પછી કરું છું.
સારી રીતે જોઈ લે.
અહીંયા આપણે દૂર જતા રહ્યા છે.
તે દૂર છે પણ બહુ દૂર નથી. આ દેખાય સામે વાયર દેખાય છે. વાયર તો દેખાય. You can still see the wire. એ રહ્યો જો વાયર.
ના નથી એ વાયર.
આ બાજુ. અરે રીતે સેજ અલાઈન જોયું છે મેં તો પોઝિશન આવી જશે.
Dr. Nile?
Yeah.
Once you will place the stand, we'll come back to you. Is that okay?
Okay, it's fine.
Sure. Dr. Jubin, can we go to Dr. Amol Bapai room, please? Yeah, we will wait. Jubin, we can go to Nilay rooms. Dr. Jubin? We stay back. Dr. Nilay, you are online.
Okay, okay, no problem. So as you can see in EUS picture, we have moved a bit, but on IITV it looks okay. So we will place stent initially on IITV and then on endoscopy. Wire tight ragye, wire tight ragye.
Nilay, are you putting a double pictal stent?
I'm sorry?
A double pictal stent?
No, we don't have double pictal 5 French stent. So we are going to put a single pictal stent, the straight part in the jejunum. Okay. So now I'm trying to put the stent over the wire. Let's see. Okay, हाँ रेडियो पर मार्क नहीं है बाप रे
कलर में ले ले कलर में ले ले
एंडो
हाँ कलर में ले वो छोड़ो छोड़ो
अरे
थोड़ो
पुश करो
हाँ थोड़ो पुश कर थोड़ो पुश
फ्लूरो
आमा जोता जोता अब आमा जोड़
अरे बाप रे बाप
वांधो नहीं આવે શાંતિથી
फ्लूरो
સેને
એવું લાગે છે
આમાં જોતા જોતા કરી દે થઈ જશે
નહીં
આવી ગયું
એટલે
સામે આવી
પુશ કરીશ ને
સામે આવી
દેખાશે
ગયું. હા સામે આવી યસ યસ તમે સ્કોપ થોડી વિડ્રો કરો
હા એ જ કરું છું એ જ કરું છું let me first see
આ બાજુ
it's here
હા હા
Yeah.
પકડી લો
યસ
યસ
let me go away
yeah.
and let me see where it is. There is a lot of blood.
હા
Fluoro?
એ રહ્યો નીચે
Okay,
નીચે.
okay, okay, got it.
Yes.
So what I can do is I can just leave the stent. हाँ
ના ના થોડું
नहीं नहीं હવે push नहीं था હવે तू छोड़ दे.
થઈ જશે
We are in jejunum. We are in jejunum. We are in jejunum because we don't see anything. हाँ हाँ बाहर निकाल. Done.
Wonderful.
It's over.
Thank you, Dr. Nilay, for the nice demonstration. And we switch over to Amol Bapai room now.
So this is the stent. You can see.
Yeah, we can see, Dr. Nilay, we can see. Thank you. Thank you for the nice case. Over to Dr. Amol Bapai room.
Okay, thank you, Rajesh. So we are progressing and I'm doing the lateral dissection for the one side and we are almost coming to the end of that. We turned the patient right lateral. You saw that, I think, when we were there, you all were here last time. And we are continuing in the right lateral position. Okay, inject here. a little bit. So, step by step, we are dissecting the submucosa. We're changing settings intermittently. Because here the underwater will not help me much because I've turned the patient's position, so this is not dependent anymore, this side. So the water does not stay here very well. Needle back and inject.
Seems there's more fibrosis over
Yeah,
there.
there is a little bit of fibrosis here. So we are taking a little bit longer to cut across. That is what is happening. But that also happens because the fold is coming there. So see, this is the dissection from the anal side. We have dissected. I'm just want to show you in case Rajesh shuts off the camera. I want to that is this thing. And the retroflex, maybe we will just suction and show you. You can see over there, this side we've dissected.
Right.
Practically.
Yes.
Quite a bit. This is the only attachment which is remaining. And the tunnel is again over here. So we've dissected from this side as well. So we have to connect this part with this part that we have dissected. We might take an incision over here and complete the mucosal incision from here and then go from Inside, give me the needle. Needle.
From Boston? Gold knife from Microtech? No. You. Flex knife from hybrid Irving? Hybrid, yes. The hybrid, but not the flex. But not the flex.
I can.
Hi. What kind of cap are you using?
I'm using a regular standard cap. I'm not using the conical cap. Needle out.
But we've been doing a lot of underwater just now.
Yeah, so I did a lot of it underwater. Needle back.
But I use a knife that allows me to inject through the knife. I use a knife that allows me to inject through the knife.
Same here. I
And
use the dual knife J.
yeah, but the dual knife J, your injection is actually not through the knife itself, it's through the catheter alongside. So I prefer the injection to go through the knife itself. And then with the water jet channel, I basically infuse the water. So we have two terms. One is flush, which is to keep the lumen distended with water. So that's how we expand the space, the third space. And then the injection is what keeps everything, the tissue, the submucosal tissue blue, so you know where to cut. And then I have my assistant do all the work. So I can focus on just cutting, and the assistant is injecting and flushing for me.
That's a good idea because I always have two pumps when I'm doing ESDs.
Yeah, so you need two pumps. You need one pump is for the flushing, and the other pump is for the injection. So you have two pumps. Yeah.
I definitely prefer the hand injection most of the times. I think our techs do that, and because we use the dual knife, they at least need to get the knife back and forth.
Yeah.
When you're injecting, so that necessarily needs some active assistance from the tech. In any case,
But my nurses wants me to use the pump.
Yeah, so the injection I do all through the pump because it's continuous. Because the problem with some of these knives, like the gold knife from Microtech, it's thinner than the pro knife from Boston. It's a little bit thinner, but I like it because it cuts so well. So it actually has an alloy coating. It's called gold, but it's not gold, of course, right? Otherwise, I'd be saving all of them. But it's a special alloy that conducts better cutting current. So I do like it. But you have to continuously infuse through that knife. Otherwise, it gets clogged up easily.
Dr. Amol?
Yes.
I think we have to break for the lunch in the hall.
Yeah.
And after this, so thank you, Chairperson.
Thank you, Rajesh, for this opportunity. We'll continue with this case. Hopefully, we'll be able to show you the final specimen at some time during the session, after session.
Thank you,
Thank you so much.
The other thing is when I'm underwater, do you have the near focus on here or no?
No.
I think they have it.
They have it on here.
Yeah,
I also use the near focus.
I use no focus the whole time. You can see so beautifully every little vessel.
I also like the
So
near.
this is a cap that I'd like you to try. And it's a little different. It's called visor. But it does have a taper at the tip like this, except it's only half the circumference. So you have a better view. And it also helps get rid of the bubbles. Because one of the problems when you're working underwater is a lot of bubbles fall.
Yeah.
So you can try it on your scope afterwards to see. It also creates, I think, very nice traction. So
which side do you put that conical?
Opposite from where your instrument. So it would be for Olympus. It would be from maybe 11 to 5 or 12 to 6, like that.
I see.
Well, it's just that the bubbles can get out. The problem with using the OG ST hood is that the bubbles get trapped inside there and it's so hard to get the bubbles out. And I love the ST hood, but the problem is it's very, tunnel vision, very narrow.
It's very narrow.
So this is sort of a compromise where you have
some tapering here to hold the tissue opposite away, so you have some traction effect, right? And you still have good visualization on the other side. And then you don't have to push your knife out so far. Yeah. Because you know, with the SD hood, you got to push your knife in far outside.
And that you lose control a little bit.
Well, it's not available yet.
Can I have a sample to bring
Naina,
Really?
we have another one. We are going to be a lot.
I think we all need to compete to get this. This is really, really nice.
Okay.
Oh, it's quite soft.
So what I do is I like to just go up and down.
Yeah, same here.
I just kind of like slice up and then slice down. And the whole time the nurses are giving water in, you know, the flushing to expand the space enough, so I see. And they're constantly injecting the blue, so I know, I almost don't need to see where to cut. As long as it's blue, I can cut. If it's blue, cut.
One small request. Can I
Hello?
get the patient to the next, this case to the next one?
You can do that.
Non-camera room, because we have to go for the next
Sure,
session.
no problem. Give me,
You can take 5 minutes break.
yeah, that's okay. Give me just maybe 3 to 4 minutes. Let me get this edge out of the way.
We have time.
Yeah. My
We're
friend.
not online. Are we still online? No.
No.
They're having lunch.
Yeah.
The pancreatic is and
or or any of these traction things, you know, I know patients do that, so that's why I do it underwater, because you get the buoyancy. Yeah, the buoyancy is pretty. This automatically they move above you. Yeah.
Yeah, I mean, sometimes for this kind of big pieces, some traction sometimes, needle back. How often do you use
I want to personally welcome you to Endocon 24, where Dr. Rajesh Puri has actually put together a very extensive and exciting program for scientific discussion on interventions, insights, and innovations.
My dear friends, it's my pleasure to invite you to Endocon 2024.
Yeah, very often the muscle. With the slip line, it picks up everything. It picks up everything. It picks up everything. नहीं होगा वहाँ से बहुत एंगल
I want to personally welcome you
दूसरा साइड बाकी
to Endocon 24, where Dr. Rajesh Puri has actually put together a very extensive and exciting program for scientific discussion on interventions, insights, and innovations.
My dear friends, it's my pleasure to invite you to Endocon 2024.
तो ऐसे ही करना पड़ेगा
I want to personally welcome you to Endocon 24, where Dr. Rajesh Puri has actually put together a very extensive and exciting program for scientific discussion on interventions, insights, and innovations.
My dear friends, it's my pleasure to invite you to Endocon 2024.
जमाना नंबर सर क्लोज एक दो ऐसे ही वैसे नहीं इंजॉय करेंगे ना जैसे ही करेंगे तो इतना करते yeah but
I want to personally welcome you
नहीं अरे लंबा है
to
it is wide
Endocon 24,
इधर किया हमने
where
इधर किया
Dr. Rajesh Puri has actually put together a very extensive and exciting program for scientific discussion on interventions, insights, and innovations.
My dear friends, it's my pleasure to invite you to Endocon 2024.
संभाल ना Right.
I want to personally welcome you to Endocon 24, where Dr. Rajesh Puri has actually put together a very extensive and exciting program for scientific discussion on interventions, insights, and innovations.
My dear friends, it's my pleasure to invite you to Endocon 2024.
देखा नहीं आता हाँ फिर बहुत
I want to personally welcome you to Endocon 24.
Only thing is the anal incision becomes a
where Dr. Rajesh Puri has actually put together a very extensive and exciting program for scientific discussion on interventions, insights, and innovations.
My dear friends, it's my pleasure to invite you to Endocon 2024.
Back inject.
Hello.
Okay. Maybe. है ना यार
I want to personally welcome you to Endocon 24, where Dr. Rajesh Puri has actually put together a very extensive and exciting program for scientific discussion on interventions, insights, and innovations.
My dear friends, it's my pleasure to invite you to Endocon 2024.
This is the gravity side in the original.
एसोफ्लिप का बात कर रहा है नहीं एक और attract device. So it's basically and the speed is much faster than almost the section speed of 61.4 millimeters. So there are 4 or 5 loops and the central loop.
शिफ्ट कर देते हैं अभी भी है 10 मिनट का लगेगा यही पोजीशन तो क्लीन कर लो अगर
I want to personally welcome you to Endocon 24, where Dr. Rajesh Puri has actually put together a very extensive and exciting program for scientific discussion on interventions, insights, and innovations.
My dear friends, it's my pleasure to invite you to Endocon 2024.
I want to personally welcome you to Endocon 24, where Dr. Rajesh Puri has actually put together a very extensive and exciting program for scientific discussion on interventions, insights, and innovations.
My dear friends, it's my pleasure to invite you to Endocon 2024.
I want to personally welcome you to Endocon 24, where Dr. Rajesh Puri has actually put together a very extensive and exciting program for scientific discussion on interventions, insights, and innovations.
My dear friends, it's my pleasure to invite you to Endocon 2024.
I want to personally welcome you to Endocon 24, where Dr. Rajesh Puri has actually put together a very extensive and exciting program for scientific discussion on interventions, insights, and innovations.
My dear friends, it's my pleasure to invite you to Endocon 2024.
I want to personally welcome you to Endocon 24, where Dr. Rajesh Puri has actually put together a very extensive and exciting program for scientific discussion on interventions, insights, and innovations.
My dear friends, it's my pleasure to invite you to Endocon 2024.
I want to personally welcome you to Endocon 24, where Dr. Rajesh Puri has actually put together a very extensive and exciting program for scientific discussion on interventions, insights, and innovations.
My dear friends, it's my pleasure to invite you to Endocon 2024.
I want to personally welcome you to Endocon 24, where Dr. Rajesh Puri has actually put together a very extensive and exciting program for scientific discussion on interventions,
Saban? Dr. Saban? Dr.
We will now
Saban?
begin
Yes,
the
sir,
live
you are
transmission
audible.
from
Dr.
Medanta.
Savan is just about to call the chairperson.
I'll invite the moderators to please come on the stage, and Suraj Kumar, Dr. Piyush Ranjan, Dr. Nadeem Parvez, and I invite the chairpersons, Dr. Charanpreet Grewal, Dr. Vijayan Chandel, Dr. Harsh Tewatia, Dr. Rakesh Adi, and Dr. Pallavi Garg to please come on the stage.
People in the hall?
Yes, sir, you are audible. Please go ahead.
So we are starting the second session of live demonstration, and we are starting with the first case with the chronic pancreatitis. And I request Dr. Jubin Dev Sharma to start with the proceeding. Thank you.
So the first case for the afternoon session is a 36 female, a diagnosed case of chronic pancreatitis. And she had recurrent episodes of pain requiring significant analgesics. This is the MR. There is a suspicion of a divisum. There is a dilated MPD with stone. The plan is pancreatic endotherapy either by ERCP or by EUS. So we go to OT1 with Dr. Rajiv Atam.
Dr. Rajiv, you are online.
Hi, everybody. So we have this lady with chronic pancreatitis. She's had 2 attempts of ERCP previously. They were unsuccessful. On the MR, I can't say for sure that she does not have divisum. So I'm starting with regular ERCP. We have the scope now lined up, and we just gained access to the pancreatic duct. I'm using a sphinctertome and a 025 VisiGlide wire. Can you see fluoro? Give me some more contrast. Okay, good. So we have a pancreatogram. Let's try push the wire in. Yeah, floor is on. Mag up one more. Megan. Okay, try the wire now. Good, good, good. Keep going, keep going, keep going, keep going. Okay, let me get in.
On, please.
Yeah, floor is on. There you go. Okay, good. Let's straighten. Hold on, let me straighten this. So I'm just straightening my stome in. Give me some contrast now. So we have deep access to the pancreatic duct. Pull back the wire. Maybe we're a side branch. Yeah, let's see. Or maybe it's a loop. Yeah, it's an answer loop. Okay, go for it. Beautiful, beautiful. Okay, now, so we got deep into it, and now I'm gonna take off the answer loop by pulling back at the sphincter tome. So now we are straight deep in. I'm just gonna get a nice pancreatogram by going deep into it. Can you look at the tail, please? Move to the tail. That's good. Okay, so we are deep into the duct. You can see changes of chronic pancreatitis. Give me some more contrast here. Beautiful. Stop here. And I'll take a shot here. So you can see irregular duct, dilated in body and tail with a lot of dilated side branches. I don't see any filling defects. Let's do a 5 French 11 centimeter. 512 is fine. Okay. Yeah, yeah. No, I want to go deep in. So 512 or 5'9" either is fine. Yeah. Do you have 5'11"?
5'9".
Okay. Any questions from the panel? Let's exchange. Shifter, right?
So
Exchanging.
why choosing a 5 French stent? Why not 7 French stent here?
You see.
Is it audible?
Got it?
Why a 5 French stents rather than 7 French?
Yeah. Biliary or pancreatic? Okay. I like to start with the biliary pancreaticotomy first. Can I have a second wire? Keep exchanging. Yeah. No, I'll do a biliary syncrotomy and then do a pancreatic stent. I don't want to cover both together. Okay. So let's just exchange.
Is it audible?
Any question? I can't hear you, sir.
Is it audible now?
Yes. Can you get the volume up?
Okay.
Yes, we can hear you now.
Okay. So the duct seems to be quite dilated.
Yes.
And instead of using 5 French, can you straight away put a 7 French?
Yeah, you could go 7 French too, easily. The only thing is in the there's an answer loop in the head. So I wanted to be a little safer with that. So a 5 would go easily. 7 should be fine too. We could do either one.
Here we didn't see any stones in the main pancreatic duct. So, I mean,
we didn't see stones, but I see, if you look at the endoscopy image, you'll see some debris coming out.
Yeah.
White colored. Can you show the endoscopy? There's something right there at the papilla right now. You see that? Some more coming out?
Yes. Duct in the head doesn't seem to be so prominent. So is it a partial pancreas divisum?
Yeah. No, I think it's just chronic pancreatitis with dilated ducts. It's not a divisum. The question for the audience is, would you want to do a biliary syncrotomy before you do a pancreatic syncrotomy, or just do a single one?
Pancreatic sphincterotomy should be good enough.
Or neither?
I think in this case where there is no biliary stricture involvement, I think just a pancreatic sphincterotomy is enough.
Say it again, sir.
Can you please tell your reasoning why you want to do a biliary sphincterotomy first and then a...
So one, you get better landmarks. You know, you can exactly see which direction you're cutting. 1. 2, many times these people also have a distal biliary stricture. I don't know, on the MRCP, the lower end of the duct was not very clear to me. So I don't know if she has distal biliary stricture. So it's mostly a personal preference. I like to have my landmarks very clear before I do a pancreatic sphincterotomy to see which direction I'm cutting. I want to open up the biliary sphincter and then follow that towards the pancreatic sphincterotomy towards the biliary sphincterotomy then.
In many of these patients with chronic pancreatitis, if you do a cholangiogram, you find this smooth tapering at the lower end. If the LFTs are normal, so do we intend to place a stent in those?
If the LFTs are normal, then I'm not intending to place it. So we could do both ways. Again, my personal preference has been to use to first cut the biliary sphincter and then do the pancreatic sphincterotomy, because that way I get much clearer, better landmarks. But again, we could do either way. Okay, let's try that. They have normal liver function? Normal. LFTs are. So I'm told the LFTs are normal, so we don't really need to go after the biliary. Yeah. But you can still see the white debris, coming out. Yeah. We didn't get a cholangia. We went straight for the pancreatic. Yeah. We didn't see any filling defects. We just saw just irregular duct and dilated side branches. You the way? Yeah. Yeah. Can you pull me in? Pull in. So the consensus here is to go straight for pancreatic sphincterotomy. And we'll go for that. And we could go for a 7 French stent. Let's just get a little bit more contrast in. I just want to.
In terms of technique, how do you differ between your biliary sphincterotomy and your pancreatic sphincterotomy? Do you have any difference in your technique? About the same.
Not much. Again, you're cutting towards the biliary sphincter and up higher. That's why I like you to start with a biliary sphincterotomy first, and then once my landmarks are clear, I can then go towards the biliary sphincter. Give me a little bit of contrast here. Yeah, floor is on. Okay. Okay, good. So no radio-opaque filling defects. The duct is just irregular, a lot of side branches. Like, okay. Are we ready for cut? And the precaution that we have to take is that we're only cutting the sphincter and we're not cutting the pancreatic duct at all, because we don't want to cause any thermal injury to the pancreas. So a very small amount of wire in.
So in this situation, what will be your landmark for stopping the cut?
So the landmark is as long as you're in the ampulla. You should not be, the wire should just be touching the ampullary orifice, not going deep in. So basically, you just want to cut open the pancreatic orifice rather than cutting the pancreatic duct. I think that should be big enough for this. Okay, let's exchange. What's that?
Would you roll it before
You mean with injection? Oh, you want the sweet balloon? Yeah, we could do that, but I don't really see any radiopaque filling defects here. Yeah. Okay. You would sweep it if you saw some radiopaque filling defects, but here, whatever it is, very soft. Yeah, very soft debris that should fall out with the stent itself. So the cut is very superficial. It's only into the ampulla, not beyond it. So, and it's a very conservative, small sphincterotomy, which is all we need at this time.
Yeah.
There is a question from the audience.
We're exchanging, right? So get me a 711 or you have a 79?
Can you get the mic on?
There we go.
Pigtail. You don't pigtails? Okay. You don't have a 711?
712, I think.
712 should be fine. Yeah.
Can I make a question, comment? First of all, beautiful job, Rajiv, as always. Is there an advantage to, if you're trying to let debris pass, smaller stent's better. Bigger stent blocks the duct and stones and debris don't pass so well around it. Is there any merit to that? Or putting multiple small stents instead of one big one?
Well, you could do multiple stents if you were to treat a stricture, I would actually prefer like an 8.5 soft French, a soft plastic stent here. Well, we don't have that. We have hard plastic stents. Like a Jolin would have been a perfect stent for this. They would allow the debris to pass. But we have straight stents. We don't really have pigtail stents available.
And, you know, at least our preference is to use single pigtails once they're longer than 2 or 3 centimeters because of risk of inward migration with straight stents.
Yeah.
Do they ratchet inside the duct sometimes? What do you use at home?
Yeah, we use pigtail stents almost for all pancreatic cases, except for Jolins, which are, you know, without any pigtails or any flaps. For chronic pancs, especially dilated ducts with debris, I prefer Jolin. Soft stents, great internal diameter lumen, so it drains very well.
How to decide the French of the stent, whether you want to use 5, 7 or 10? So how do you decide that?
It all depends on the size of the duct. So here, the duct was pretty dilated in the body and tail, in the head. Okay, release, yeah. So it's out a little bit, but that should be fine.
Are you concerned that will bump into the opposite wall and occlude?
Yeah, it may be a bit long. Let me just see if I can reposition it.
Yeah.
But
yeah. Certainly.
I think it should be fine. It should be fine. It's it has 2 internal flaps, not a single one, but 2 internal flaps. It's draining beautiful.
Yeah.
We could see some debris come out. I don't think it's gonna bump into the opposite wall. It's only maybe a centimeter out of ampulla, so it should be fine.
So thank you, Dr. Atam, for the very nice case demonstration. And I request Dr. Jubin to go to the laser lithotripsy shown by Professor D.N. Reddy, sir. So I request Jubin to go to the second room, please.
Yes, so for the next case, it's a 43-year-old female who had pain abdomen, and MR showed a dilated cystic duct with a calculus impacted suspicion of a mirizy. The stent has been removed, and the plan is to do a laser and a clearance of the duct. So over in the OT2, sir.
Thank you very much. I think as we start, I'd like to introduce the people in the room here. We have supervising me, Mohan Prasad, who's also. Yeah, so Piyush is there. Piyush, can you hear us?
Yes, sir, we can hear you.
Okay. So I have Mohan Prasad, who has a huge experience with cholangioscopy. And again, we also have Sanjay Rajput from Ahmedabad. Both of them are very experienced in this field. So I'm becoming more confident now. To assist me, we have Mr. Srinivas Reddy from AAG Hospital and Shahzad from Bombay. So you can see a big team here who can do a complex surgery if you want. But this is a patient, as you see in the MRCP here, has got a stone which is impacted, probably Mirzi syndrome. So this is an ideal situation for a cholangioscopy and a laser lithotripsy, and not mechanical, because you won't be able to grasp the stone. Second, the lower end of the CBD actually is little small here, narrow. So that's the reason why we have to fragment it very well. Okay, Piyush, so we'll start. Before I start, I'm using a SPY DS scope from Boston Scientific. And you can see something here, if the camera can focus, that the laser fiber is already preloaded. And this is the point that we discussed. I think Mohan raised it up during our earlier course, that the problem is, if you don't have this, if you try and remove the guide wire and put a laser probe further, usually it doesn't go in, it gets stuck. The problem of preloading is that you'll have some difficulty in the lower end going in. But I would recommend preloading, because although it's easier to put it on a guide wire, if we don't preload it, we'll have problems in the sense that the laser fiber usually doesn't go in with the present 1.2 channel. So the cholangioscope is now going in. It's a single operator cholangioscope, of course. Until it goes to the elevator, I'm going to use it as a double operator. Now, once it reaches there, we'll ask Mr. Srinivas to actually tie the handle to the scope here. So in the audience, Piyush, can you find out how many are actually doing cholangioscopy? Raise of hands.
So
we know do it fast or slow.
Quite a lot of them, sir. Nearly 20% of the people present here.
20% is not a lot, no?
Not lot. I think
Okay.
80% have to learn.
Yeah. So which means that we go up to the papilla here. I'm just checking the papilla, and then you can see the technique. So I'm just fixing the knob, up and down knob here. I go very close to the papilla. The technique I'll just show you how to go without a guide wire. Push the scope in a little, and then you can use the elevation of the cholangioscope itself. Fix it a little here, and then I'll push it down, turn my knob to the right, and push my big scope down. Then I'll be in the axis of the CBD. Now, can you also fluoroscopically show me where we are?
I think that was a nice step to learn. Any
Yeah.
rigid accessory should be introduced through the short route.
Yeah.
And then, it dip down.
So you see the little narrowing in the lower end here, that's why there's some difficulty, but I'll try and negotiate that. Whereas with a guide wire, this would have been much more easier. But I'll suck out all the secretions here, then repeat the same process.
So, yeah, we have to enter the cystic duct. So you think that preloading it is a better idea, or going with a wire so that we
Wire is always better, because wire makes it very easy. Problem I found is once you go up to the stone, then when you put a laser fiber there, it becomes very difficult, because the laser fiber is causing at the end of the scope, it doesn't come out because of the bend there. So that's the reason why I'm using this technique. Although going on a wide is also an option, but that makes it very easy to actually enter into the bile. Like you won't see the struggle which you're seeing here. Now I've gone in, I think I'll just watch the fluoroscopy. Fluoroscopy. Huh? And also we are watching on the cholangioscope, the appearances there. Again, same. So lower end is narrowed here in this patient. We had this difficulty earlier also, I believe, when we were putting in a stent earlier. So again, I curve it up there, go, and then, huh? Oh, okay, the narrowing, a little narrowing there, and then.
So this is what happens when multiple times the stones migrate down, they produce trauma to the distal end and the ampulla, producing
So there's narrowing there in the lower end.
narrowing them. Maybe you want to balloon dilate and get in?
That is one option, or you can go on a guide wire easily.
Yeah, over the guide wire, then you'll have to take out, and then again, getting the laser fiber out becomes a challenge. You need to get into the duodenum and then pass the laser fiber.
8 mm? Yeah. So you see there's a narrowing there in that area. So what I'll do is I'll dilate it a little and then go in. It's a very important principle again that you might have to sometimes. So we take out, make it free, and then we'll quickly put a guide wire and go in. Shehzad also suggesting the same thing. He's also very experienced in this, that we'll use a Titan balloon, 10 mm or 8 mm, dilate it, and then we can go very easily. As guide wire fine pump something.
What's up?
Okay. So again, okay. See how easily the sphincterotome goes in. Na? Fluoroscopy, please. Okay. I'm not injecting any contrast here because, okay. Then we'll put the.
Nagi, this is luxury Nagi for you.
Why?
Because you're Sajid and Srinivas.
Yeah, both the two best technicians
and Sanjay
in the world.
Supervising.
Yeah.
Sanjay Rajput.
So we have a fantastic team here. So if something goes wrong, it's my fault.
Wow.
Okay.
Nothing will go wrong ever. When you are doing something.
Okay. We'll dilate. So I think this is Piyush, this is for the audience, an important message that there's sometimes difficulty when you're having going in. Always do a gentle dilatation of the lower end, because sphincterotomy is usually done very superficially. The lower part of the bile duct is not cut. So it's very tight inside.
Why not injecting here, sir? Why not obtaining a cholangiogram first?
Yeah, we'll just do a balloon and show them, and then you can go off. And then
we'll enter. Cholangiogram first, sir.
Which one?
Why not doing
cholangiogram? I'm not doing because cholangiogram spoils the image on the cholangioscope. When you subsequently go in with the scope, you will find that it's very muddy and all inside. That's the reason why specifically I'm not. The MRCP is very good. It's showing the anatomy which in the lower end is narrowed. So that's a very good anatomical view we have got. So I'm very confident. So now I am just put this Titan balloon to dilate the lower end, and after we dilate the lower end, we'll go in with the spike cholangioscope. Rajesh wants to shift quickly to another room. I think just a few seconds you can do that.
Can we do it without fluoroscopy also?
Yeah, I don't. The question that Sanjay is asking is, do we require fluoroscopy always? No. In fact, now we have published a recent data suggesting that in certain situations, for example, in pregnancy, you can actually do it without fluoroscopy. See, again, even the Titan balloon, there's some difficulty going in, but some difficulty. We'll dilate it now. Some people routinely dilate for all the cases of cholangioscopy. You do that, yeah. So both Sanjay and Mohan are saying that they were. So that saves the cholangioscope. Okay. So we are dilating it. If you want to go to the next room, and then by the time again we'll start assembling the cholangioscope. All the balloons are similar. Whatever is available we took. So it's a Titan balloon. The question was whether Titan was a hurricane. Both are similar. So Rajesh wants to shift and then.
So thank you, sir. We'll come back to you within 5 minutes. And
okay.
I request Dr. Jubin to go to Dr. Pratik room.
Yeah.
Dr. Jubin, please.
Yes, sir. So the next case we have is a 68-year-old male. He complained of persistent reflux-like symptoms and heartburn. This is the endoscopy. Initially, he had a severe esophagitis. The plan is to do a skinning endoscopy with DLI and to see whether we have any areas which need attention. So over to Dr. Pratik, sir.
Online. Dr. Pratik, you are online.
Okay, hi, good afternoon, everyone. So you've heard the history from the physician about this patient. So I'm assisted here by Dr. Shanky Kaul here, and the patient is well sedated. So we are going to be demonstrating, landmarks and how to look at patients with Barrett's esophagus. Now, one of the things that you may say is that it's uncommon in India, but the ISG had data on the prevalence of Barrett's, and it's close to about 6% in patients with reflux disease. So we'll start off with, I'm using the Fujifilm Elexo system. And so this is looking at the landmarks first using high definition white light endoscopy. So you can see that we've used some washes and included simethicone in it to get rid of the bubbles. So the first pinch that you will see, this is the diaphragmatic pinch. So we already know that this patient has a hiatus hernia. And so this diaphragmatic pinch is at about 35 centimeters. And as I come back, so this is part of the hiatus. And now these are the top of the gastric fold.
Dr. Pratik, can you clarify where is the
gastric folds are at probably 32 centimeters. So the patient has a 3 centimeter hernia.
Sir, can you point out where is the diaphragmatic pinch exactly?
Yeah, okay. So this the pinch that you see right here. So you can see that there is a little bit of a compression of the gastric proximal part of the gastric mucosa. This is the diaphragmatic pinch. So this is right here at this junction. I'm freezing it for you. So that's the diaphragmatic pinch. And this is within the hernia sac. And now the second pinch that you see, so if you will see this circular area here, these are the top of the gastric folds or the gastroesophageal junction. So these are two very important landmarks. So we already know that this patient has a 3 centimeter hernia. And now as I'm coming back, you will see salmon colored mucosa on white light endoscopy. So this is part of Barrett's esophagus. And you will first measure it up to the circumferential extent, which is right here, up to about 29 centimeters. So this patient has a 4 centimeter circumferential extent. And as we come back, you're looking now at the most proximal extent, which is the maximal extent is right here, is at 25 centimeters. So this patient has Barrett's from 25 to 32, which is the maximal extent. The other thing which this system you can do is you can switch to LCI. So this is linked color imaging. What this does is that it gives you a fine texture of the mucosa. And this is good for looking at areas as an overall view, as a red flag technique. So you do a gradual pullback with this. You can see that the Barrett's will appear more red than what it is. And what you're looking with LCI in this technique is anything which stands out as irregular or abnormal, and everything appears quite flat with this technique so far. And you can see that this is a good way of differentiating the squamous mucosa from the columnar mucosa. This also has a CAD system, or a computer-aided diagnosis system, built in, which is mainly for squamous cell cancer, not for Barrett's esophagus. So unfortunately, we cannot demonstrate that. The second opportunity you have is to switch to BLI, and this helps to look at the surface pit patterns, and then you can also zoom into the mucosa. That is what I'm doing right now. And as I zoom into the mucosa, this is where the cap helps you stabilize the mucosa a little bit. So I'm just getting closer to the mucosa and looking at the pit patterns now that I can see. So these pit patterns that you see are quite regularly arranged, and this is what you would like to see with somebody who has non-dysplastic Barrett's esophagus. And you can see that you can go up on your magnification on the button here. And this is just a freeze frame picture. If you look at the areas there, the blood vessels are nicely arranged on that, and the pit pattern is quite regular throughout. Even under magnification, you can do a gradual pullback, and as I'm coming back, so it just shows you nicely that you're getting good images. And even with advanced imaging, with a normal vascular pattern and a normal pit pattern, surface mucosal pattern, you are quite confident here that this patient probably has non-dysplastic Barrett's esophagus. So these are some good tools that you can use in your practice in patients with Barrett's esophagus. Now you can go to other areas. We did that clock position, and you can do a similar pullback. And the cap here really helps you stabilize the mucosa and start looking at these.
Dr. Pratik?
Yes.
Can you please share your wisdom on defining the G junction? Do you always rely on the top of the gastric folds, or do you sometimes use the palisade vessels?
Yeah, so that's a good question, is that in patients who have a hernia, have reflux, very frequently the palisade vessels are not very clearly visible. And this is a good example of this. This is the pinch of the G junction, which is being seen right here. And you will see that the palisade vessels are not very clearly visible in this situation. In the Japanese population, where they don't have large hernias, and in the absence of Barrett's esophagus, the palisade vessels sometimes help you, whereas here it's a little bit difficult to look at those areas. So the other thing that this has available to you, which you can do, is if your CAD is on and you're switching to LCI, for example, it can sometimes help you with the landmarks. So if you freeze here, and can you see the right lower part where the G junction now has a green ring? Can you see that?
Yeah.
In the right lower quadrant of the picture, you will see that there is a green area right at the G junction. So this actually marks the gastroesophageal junction for you through this AI system. And similarly, if you're looking at the pylorus and you freeze the image at the pylorus, it should be able to recognize the pylorus also for you. So that is, you can see the green mark on the right lower quadrant. If you can see it, it shows you that the pylorus is also now marked for you. So this is also a quality measure now, which can be built into your upper endoscopies, that you actually get to see the major landmarks, and that you're not doing a very quick examination and avoiding those landmarks in there. So those are some of the advantages for future AI systems in which they will force us to look at the different landmarks and make sure that we are doing a high quality upper endoscopy.
So thank you, Dr. Pratik, and can we shift to the other room? Dr. Pratik?
Okay, yes, sure, thank you.
Is that okay, or you want to say something more?
No, absolutely. If there are any questions, I'm happy to take it. Otherwise, we will go ahead and do our biopsies now in this patient and do 4-quadrant biopsies every 2 centimeters.
Any questions from the audience or from the chairperson?
Dr. Pratik, wonderful demonstration. Like in a long segment barrettes like this, any particular reason that you like to focus more?
Yeah, so that's a good question. I mean, there is some evidence which shows that neoplasias in patients with Barrett's esophagus occur in the distal 2 centimeters of the Barrett segment, so somewhere in this neighborhood. So that's one area that you definitely have to clearly focus on and make sure that those are the areas that you are clearly examining with different techniques. So that's one area. And then the second thing also is that the 12 o'clock to the 6 o'clock quadrant, so the right quadrant of the esophagus, that is also where neoplasias preferentially exist. So those are areas that you carefully examine, but of course, it means that the other 50% occur in the rest of the esophagus. So I would say you focus on those areas, but you just have to do a very good, careful examination of the entire segment.
So thank you, Dr. Pratik, and we switch over to Professor D.N. Reddy, sir, who is ready with the laser lithotripsy. Dr. Jubin, can we shift to Dr. Reddy, sir? Dr. Reddy, you are online.
So we can't hear you, sir.
That is stuck there, the varices syndrome between cystic duct. Can you see the stone, Piyush?
Yeah, yes, sir.
You can see the stone. Come water, please. We'll irrigate some water, and then I'm getting my laser probe out. And then we see the laser probe is directly on the stone there. And then we'll start. I'm using 10 what? 10 Hz and 12 joules. And now I'll start.
Show the settings of the laser.
Oh, it's completely.
Wow.
See that?
Amazing
Yeah.
force with which it is broken.
Yeah, now we'll put some more. See, already it's gone into different parts. So it's important that you keep shifting it to different parts of the stone, like a painting. See that how we are doing now? I'm going to different parts. I'm coming back now. Oh, completely getting fragmented.
Sir, this is Dr. Harsh. I would like to know what's the position of the holmium laser. Do you keep it away from the surface of the stone, or?
Yeah, you have to keep it just away from the surface of the 1 or 2 millimeters away, and then you get very good fragment. See that already I almost completely fragmented. Can you see that?
What is the better option, sir? Keep on fragmenting, keep on digging at the same place, or doing it at different
at different places. I actually keep moving now, as you can see. I'm moving. This part is completely thing. So then I go to the other part of the stone, you know. And then you keep doing it in different areas, so that the only thing is, even if you hit the wall here, there's no problem, because this is very safe in terms of laser. But if you're using EHL, I'd recommend you to be very careful. See, now already we cleared this area completely. Now I'm going to go a little onto the left here and then fragment this part also.
Sir, we have 2 choices, EHL versus laser. So, according to you, which one is more safer?
Yeah, I think laser for me is better, because people think it's expensive, they don't go for laser. But laser is better because long run it's cheaper, because you don't have to change the laser fiber. EHL, you have to keep changing the fiber all the time. With laser, you don't do that.
So with the settings, would you increase also if there's inadequate stone pulverization, or keep the same settings?
Yeah, no, you can increase it. But here you can see fragmentation is very good. Almost we are finishing now. Can you appreciate the fragmentation? Keep water also.
So Nagi, for the benefit of audience, I have a question to you.
Yeah.
Like you started in this case from the inferior margin of the stone and you started moving up. Is that preferable, or you hit the center of the stone?
No, I would prefer to move the probe from one part of the stone, another part. In central, see what happens if I keep it constantly like this, you produce a cavitation effect. Okay. But if you go to periphery and then come back center and all, you're going to pulverize the stone like this. See, now I think you're almost done. Okay. Some water. And then also we might have to sometimes suck out.
And also, so
Can
we
you
want.
appreciate the fragmentation there?
Yes, yes.
Yes. And when do you, what is the stopping rule?
Once, actually, if I see the other side now, I know that I've gone through and see, you can see now I'm seeing the other part of the mucosa beyond the stone. That means the impacted stone, I'm able to now see beyond this. At this point, I'd stop. So now you see, Mohan, I'm now going a little on the top part now, so that I fragment this part also. This is a little complex stone compared to regular CBD stone because it's a Mirizi syndrome. It's stuck in the cystic duct here, and that's the reason why it's complex. And that's the reason why the movements are not so much as you'd expect. If you have a regular CBD stone, you can actually see that now. Can you see beyond? More?
Yeah.
Yeah. So this means that we have fragmented it sufficiently to get, and then I go a little more to this side.
Ready, sir? For pancreatic stones, if you don't have ESWL, can we use laser or EHL in pancreatic
you can use
stones?
laser. For pancreas also, laser is safer than EHL, but I strongly recommend that ESWL is still the best method,
Perfect.
EHL, I think in the pancreatic duct might produce more trauma, can produce.
Yeah, so you can see now I'm going above more. Can you have this thing?
Dr. Reddy sir, in pre-lithotripsy, this laser lithotripsy era, what would you have done in such a case?
Pre-lithotripsy era?
In pre-lithotripsy, I am talking about maybe 15 years before.
Yeah.
In such a case, what would you have done?
So in this case, surgery, of course. In that situation. Now, rarely these cases go for surgery because of our experience with this. But when we didn't have this, we of course used to go for surgery. So you can see now almost, so Mohan, I think we are completely fragmented. A little bit is there.
So, Dr. Reddy, sir?
Yeah.
Till you are completing, can we shift to other room?
Yeah, definitely. I'll finish
I
up now.
request Dr. Jubin to shift to Professor Binmuller, who is ready with the rectal sigmoid leiomyoma full thickness resection. Dr. Jubin?
Yes, sir. So the case we have next is a 36 female who had come with bleeding PR multiple times, and there is a ulcerated submucosal mass in the upper rectum, and the biopsy showed a leiomyoma. And these are the EUS images of the same area. The plan is for an endoscopic resection. So over to you, sir, in OT4.
So the slogan for this meeting are the 3 I's. It is intervention, insight, innovation, and maybe I can add a 4th I, individualize. You need to individualize what we do for each patient, for each case. Each patient is unique. So this patient has a leiomyoma. We already know that from the biopsy, so that's important. We know that this is not really a precancerous lesion. But as you can see on the endoscopic view, it's fairly sizable. I'm going to pull back here. I'm going into the sigmoid now. And there's the lesion. And you can see that on the surface, apparently there was some ulceration, so these can bleed. So the risk to the patient is bleeding, but obviously there's also some lumen obstruction. So I think treatment is warranted. This is theoretically something that does not need to be removed because it's not pre-malignant, but I think we can make an argument for removing it in this patient based on the larger size and the fact that there was previous ulceration. So we're always weighing risk and benefit in everything that we do in medicine, and it's important that we always do this when we consider the different options for endoscopic treatment. Of course, everyone is infatuated with ESD and resections, third space, but I'm not sure that ESD is really the best option for this patient for something that's in fact not even pre-malignant. So what I'd like to show you today in the spirit of innovation, the I, is a different way that you can remove this.
using a double channel scope, deploying 2 instruments through each of the channels. And for 2 instruments, I need 2 assistants. So I have Manowich, is that right? Manowich? Okay. And Ashwani to my right, very important because you can see they both have a device in each of their hands. And I've inserted these through the left and the right working channels. I'm going to have one assistant just hold my scope as well. So I need even a third person to just make sure that my scope doesn't slip back. It's okay right now. But here now through the left channel, this is the Ovesco 3-prong grasper. You could use anything, but you need something that is not just going to capture the mucosa, because this is a subepithelial lesion. So if you use a forceps or so, then it's going to just tent the mucosa away. You're not going to get the underlying tumor, the leiomyoma. In the right channel now, and again in the spirit of innovation, is something I devised. So it's a loop, but the limitation of the conventional loop that we all have used, which is the Olympus loop, is that it's very, very floppy. It's probably not that much of an issue for this case today, but it's an opportunity for me to show you how one can make a loop stiffer. The loop is the same, but it's mounted on a snare. So by mounting it on the snare keeps the loop stiff and rigid when we deploy it. So essentially, it's like putting a snare around the lesion. So our first step is going to be to advance the snare with the loop mounted on it out of the catheter. So you see the catheter, you can see the tip. And what Ashwani is doing now is he's simply pulling this sheath backwards, which advances now the snare forward. So keep pulling it back. Ashwani, keep pulling. So you can see this loop is mounted on a snare. So now I'm going to push and I need someone to hold my scope. I'm going to push the 3-prong grasper through the loop, right? Like this. And I'm going to now pull the loop back like this. And I'm going to get a little bit more distance away, maybe rotate a little bit to get into a better position. Now you want to make sure that your loop is recessed back far enough. Let's do this again because I just slipped out, but I'm going to push it forward like this, get a little bit further out so I can pull the loop backwards. All right, like this. So as mentioned, I don't think the stiffness is that critical in a case like this, but it is a case where you have a lesion that is very much flatter, has a broader base, and then you really need a loop that pushes flush up against the bowel wall. So now I'm going to move my 3-prong grasper over a little bit, and as soon as I have a good view, it's just a very difficult position because we're in the sigmoid. Now remember, even if this were a GIST lesion, our options to remove something originating from the muscularis propria are very limited. We can do a stir, we can do ESD, but you have a high risk of perforation. So you need to be prepared to close a perforation. We want to avoid that. Go ahead and deploy the 3-prong grasper. So now Manowich is just push it out. You see one of the prongs kind of came out a little bit, and that's okay. Now I'm going to push this second one forward. This is the loop, and I'm going to pull this in forcefully. So I'm getting the loop all the way out like this, putting it flush up against, and I'm pulling back like this. And you can pull back pretty forcefully so that I'm really pulling, if you will, the attachment to the MP. I'm involuting the wall. It's blind, but now I'm going to have, you're going to now close by advancing this forward like this. All right. And when it's tight, so advance it all the way forward. Is it tight? You feel it tight? It's just a chance for me to, okay, is it tight now? Do you feel that it's advanced all the way? All right, now you're going to close the loop here. So this is the thumb ring. You're going to pull the thumb ring. Yeah, close all the way. Close it all the way until you don't feel it go forward anymore. So all the way. All right. And when it's nice and tight, you're going to pull this back again. All right. Yeah. And this is then going to, when you pull that back and now you push the thumb ring forward. All right. That releases then, and you can release the Ovesco clamp now, please. Yep. Just pull it back. Yeah. It just will come out. I'm just using this Ovesco 3-prong grasper for retraction. It's a retractor. Did you close it? Okay, there, you need to close it. There you go. Okay. So now when you advance, yeah, release now the loop, please. All right. So he's just pushing forward to release the loop. Okay. And let's see if it released. Just have to, it's a little bit more constrained, the space here. Okay. Close now the snare, please. The other way, push this one forward, the snare. Yeah. So you have to realize the snare in a constrained space makes it a little bit more confusing, perhaps. Now the snare is out and the loop is out. I'm just going to push this all the way.
So would elevation prior to
Here's the end. All right. So now look at this. It's already started to turn violaceous. And I'm going to put a second loop below the first loop.
Dr. Mueller, I have a quick question. So you have described a technique called Arlep technique for a similar lesion like this in the stomach.
So Professor Binmoller, before
Yes.
you go to the next step, we are going to Professor Dr. D.N. Reddy, sir. He has completed the bile duct.
Yeah.
I request Dr. Dubin
No,
to shift to Dr. D.N. Reddy, sir.
No knife. The graph.
Dr. Reddy, sir, you are online.
Yeah, thank you. So you see, we had a very nice fragmentation. We couldn't show you the final fragmentation pipe because of the time, but you can see fragmentation was done very well. If you can concentrate the fluoro on the top, you can see that's where the large stone was. Fluoro can go a little to the top. You can see that completely cleared. There was a large stone there. Can you see that now, Piyush?
Yes.
Completely cleared. So we had to do what is called an occlusion cholangiogram just to demonstrate that everything is clear. As you can see here, nicely we are pulling back the balloon. See that now? Are you convinced, Piyush? You're not telling us anything from there.
This is the bile duct only. Cystic duct is not seen, sir, here.
Bile duct is completely free now. So what I'm going to do is I'm going to show you the last trick here, how to remove the balloon from the bile duct. Don't pull it out. There are two ways of doing it. Getting it up close up to the papillary orifice here, and then you can rotate the big knob down like this so that the scope is away from the ampulla. See this? This is the one way of removing. You can do this and the balloon comes out. The second way of doing this is to fix the balloon with your finger and then push the scope down and turn to the right. So these are the two techniques, and you can see now the balloon has come out of the narrowed area very nicely, and you can see all the fragmentations here. Okay?
So you're going to put in a stent, no?
Yeah, we'll decide whatever the operating team wants. But
there is a slight narrowing there.
narrowing is there, but that's okay, I think. But so I think, can you see the thing now? Fragments are there and the whole bile duct is completely clear. Okay?
Yeah. Good job.
Thank you, Dr. Reddy, sir. Thank you. And we go back to Dr. Kenneth Binmoller, where he is near the finishing. Dr. Jubin, can we shift to Kenneth Binmoller?
So he wanted.
Okay, so this is just, I just want to show you here how well this worked, right? There's the slip knot, yes, and that slip knot really holds its position very nicely at the attachment. And when you use the standard loop, which I'm going to show you right now, the problem, can I have that loop, please? So this is now the standard Olympus loop. This is also 30 millimeters in diameter. So
sir, the first
as the other one. So you see here, I'm going to advance this out. Open the loop, please. So this is the Olympus loop. The problem, though, is it's very floppy. Is it already open? So you see how it's already flopping down? And one of the problems that we encounter, open it all the way, please. Open the loop, please, all the way. Is that when you start to close the loop, the tip flips up. And then it's not actually going to stay flush up against the wall. All right, so this is a grasper. And what I'm going to do now is just grasp the tip of this. So open the grasper, please. Close the grasper. Good. And I'm just going to pull this into this loop here, right? So I'm going to loop the loop. So if you can hold the scope like this.
Dr. Mueller?
You can see how vascular this is. So what I'm doing now is I am pulling. And this is the problem with this loop. See how floppy it is? So it's kind of hard for me. I'm trying to get it to go to the base like this. Hold it right here. Going to pull this back a little bit more. See how this is giving me traction, right? Now I'm going to close this loop below. So the blue loop is closing below the green loop. Okay? So now start to close the Olympus loop, the blue loop, and just start closing it. Now what often happens is it flips up and it doesn't close well. See, it didn't work very well. So that's the problem, is that it flips and then it just doesn't give a good, stay flush up against the wall. Just go ahead and deploy it. Did you deploy?
Can you hear us?
Are you deploying? So you should see the cable advance forward when there's the cable coming, right?
Dr. Rajesh,
okay. Push it all the way forward and then pull.
Not audible.
Yeah. So you see what happened here is it didn't work the way I wanted it to, which is that blue loop needed to be over the lesion. And it's basically just looping the base. So that's not accomplishing anything. All right. So release it, please. So I'm going to do it one more time. It's not a problem. Did you release the Olympus loop? I'm having trouble pulling it off. Yeah, this is the other problem that we sometimes encounter with this loop is it's hard. There it comes. Okay.
Rajesh, are we audible Are we audible?
I'm going to put one more on there. And so now the debate is, or the discussion could be, do we need to actually resect this, or can we just let it slough off? Right? So this is called loop and let go because we know it's a leiomyoma. Now, if it were a GIST lesion, what I do is I incise it and in a cruciate manner, make 2 incisions, and then I just let it enucleate. Because now you opened up the mucosa and like a flower, and then you let the lesion just spontaneously enucleate on its own. And I do get biopsies with a large jumbo biopsy forceps so that we can calculate the mitotic index if it's a GIST. But what you've done is you've inverted the wall so that you're getting a full thickness ligation. So it's just maybe in some ways a more clever way of treating this without any risk of perforation.
Thank you, Professor Binmoller.
Are we audible?
Yeah, can we go to the room? Professor Binmoller?
Yes, of course.
I think you have done your job completely.
Thank you. Thank you. I'm going to put one more fun and then we're done.
Sir, I think audience has one question.
Yeah.
I see. This is.
Please go ahead.
Release this, please. Yeah, thank you.
Dr. Moyle, can you hear us?
Give me a new loop.
Yes, Chairperson, we can hear you. Please go ahead. Ask your question, please.
So like this is a procedure which you have described called as RLA procedure. The previous cases were in the stomach, but this is for the first time we are seeing a case in the rectal area. So this case like this can be done even in rectum.
Yes. So actually, this is so the reason why I think in the rectum it's all the question of anatomy. So in the rectum, especially if you're below the peritoneal reflection, then I think actually to do full thickness resection is very safe. And I do that commonly where I've already looked at the perirectal fat and it really has no consequence because you're not in the peritoneum. In the stomach, you're very safe because you have a very thick wall. But in the sigmoid and the colon, it's very different. And the wall is very thin. So it's really hard to do a stir procedure in the colon. So then you're really looking at just doing ESD otherwise. This would be for if you wanted to resect the lesion completely in the index session. And you have to basically expect that you'll have perforation and you're going to need to close that hole very fast. And that can have disastrous consequences in the colon.
Thank you, Professor Binmoller. We go to Professor Nihos, and he's going to show the FDRD. Over to Jubin for history presentation.
Yes, so this patient is a 48 male and epigastric discomfort for 1 month. The endoscopy showed multiple lesions in the duodenum, but there is one single large lesion which needs a resection. So he's planned for an EFTR of the large lesions, and the other lesions will be resected at a later date. Over to Dr. Newhouse in OT1.
I thank the moderators and chairpersons of the session. So for the next set of moderators and chairpersons, I would like to invite Dr. Amit Tarwani, Dr. G.S. Sidhu, Dr. Ashish Joshi, Dr. Alok Mantri, and Dr. Saroj Dubey. As chairpersons, Dr. Manish Jain, Dr. Munish Sachdeva, Dr. J.S. Sidhu, Dr. Amitabh Jarat, and Dr. Ram Chandra Soni. So I request the moderators and chairpersons to please come on stage.
I think we already.
Okay, we are already online.
Yes.
Just to save time, I would like to show you the lesions. So I'm very lucky that I will be assisted by Dr. Mali and Bhagwan. So I've excellent, we are excellent team. And I'm using an Olympus diagnostic scope, the EZ 1500. And I pass the pylorus. And here we see obviously the two lesions in the anterior wall of the duodenal bulb. And the second one seems to be more suspicious here for NET. But this one is, of course, could be the same histopathology. So there are several options. Experts can do ESD of both lesions, but this is very challenging because EUS showed there may also involve the muscularis propria and there's a high risk of perforation.
Right.
So you must be a real master in ESD. Second option is band ligation, what you use for esophageal varices. You place a band and cut above or below the band. This would be an option, but also a risk that you entrap the muscle layer and you may cause perforation. And the third option, and this is what we will use, is full thickness resection. But we cannot entrap both lesions either with band ligation or with FTR. So what we already discussed is that we try to resect this most suspicious lesion. And then when the clip falls off in 3 months, you can also remove it. Then the second one can be removed in the same session. So you see the endoscope is equipped with a cap, it's an ESD cap, but just protruding 2 millimeters from the tip. This is to stabilize the position for marking. And the system from Ovesco comes with this marking probe, which is important. So I use forced coac 15 watts because as you will see when I show you the system, it may be quite difficult to identify the lesion without appropriate marking. So here, yeah, we may have to cut through it, but as we can have seen, the proliferation index is just below 1%. So these are not malignant lesions. Okay, this should be fine. Maybe another one here. Okay, now we mark the lesion. And now we will switch the scope. I remove the scope, I decompress the stomach. And I would like to show you the system because we already prepared a therapeutic scope with a device. And just for your understanding, it's easier if I demonstrate it here. Okay, are you ready? So firstly, I would ask you to focus on the tip of the scope. This is the FTR cap, which has been already mounted on the tip of the scope. And this is equipped with a clip on the outside.
and
Maximize the picture, please.
Pardon me?
Maximize the picture, please. It's showing small.
Picture. Yeah.
Can you increase? Now it's better. You see, the clip is here on the outside of the cap, and it comes also with an integrated snare at the distal outlet. So the snare runs finally alongside the system, and the cap is attached with a thread running through the system and to this wheel at the proximal end. So, and the principle is that I insert a special forceps grasper through the instrumentation channel. I try to grasp the lesion then with the forceps. I pull the lesion into the cap, and then I rotate the wheel, causing then tension on the thread, and the tension thread will then release the clip, and immediately after firing the clip, it's like a bear trap. We close, the second assistant will close the snare, and then we cut above the clip. So that means first close, then cut, instead of first cut and then close. So the challenge is, and as you can see, the catheter runs below the sheath here, so that we don't entrap any tissue between the catheter, the snare catheter, and the endoscope. The challenge is the same in the colorectum, to get the lesion in a good position, especially also in the colon, in diverticulosis, so it can be sometimes difficult. So please connect the endoscope now to the processor. And as you will see, the view will be limited because not on the
Yeah, the endoscopy picture. We are not getting the endoscopy image.
The endoscope will be ready in a second.
Can we put the endoscopic image? Professor Neos is seeing, but yes, yeah, endoscope image.
So you see the cap, you see the clip on the outside, you see the thread running through the working channel at 7 o'clock. And as I said, when I tension the thread, then the clip will be released, and you see the whitish ring just above the clip. And this is very important. And once the whitish clip disappears, means that the clip has been released. So now I carefully insert the scope, and as you can imagine, we have to be careful here.
Yeah, for the audience, Professor Neos is doing the procedure under conscious sedation, deep sedation under propofol, because some of the people do prefer general anesthesia. So this patient is not intubated, and Professor Neos has not used any cricopharyngeal or pyloric dilatation. So do you routinely do not perform any dilatation, or what is your?
Yeah, the good option is what we also use in the colorectum. There is a special cap, which has the same size as the therapeutic cap.
Right.
And this can be used before to check if you can pass here the pylorus or the sigmoid before using the much more expensive therapeutic device. And so we are already obviously at the pylorus.
Right.
And now I go a little bit forward and back.
Right.
And we can already identify the lesion. Can you see it here?
Yes.
So as you can see, it's very important to see. Can you see the markers?
Yes.
I have no comment from the audience. Are you still alive?
Amitabh, you are there, so are you able to see the marks?
Yeah, we can see. Yeah, able to see it. Yeah.
Okay, now next step is that I insert the grasper through the working channel to pull the lesion inside. Close. So this comes also with the system. So the marking device, the grasper, and the cap, because it's a specially designed grasper. They have also, this is not with the system, you can also use the anchoring device. So, but usually, so now we above the lesion. Now I ask you to open the faucet, the grasper, open.
Oh, open this.
Okay. So, and I try to get the center inside. I push. I push against the wall, close.
Close.
Okay. Now I pull the scope back a little bit to have some free room in between, because otherwise you have the wall just at the distal outlet. So, and then I suck very little, so it's mainly pulling. So, and we watch if we have all markers inside. A very rigid tissue. I'd like to get even more. So I give a little bit more space, pulling the scope carefully back a little bit, rotate a little bit.
So the whole purpose of these marking is to make sure that once we retrieve the specimen, we are very sure that the entire tissue has been removed in toto.
Yes, exactly. I think we open the button. We get it a little bit more in the middle. Open the grasper. I would like to get it more in the middle. This is a very important. Let go for a second. So we have to re-identify.
So this is the most pivotal step in the whole process. So catching at the right point so that we can suck the whole tissue,
exactly,
which we want to remove, into the OTSC cap.
As you can see, it's very important to have a good position of the markers.
Right.
Here. Not to mix up the first and the second.
Yes.
Gap in between.
This is in fact a technically challenging case because we have two lesions which are so adjacent. There's a few
Yeah, and this makes probably it's also the reason that it's difficult to get it completely inside. Huh?
Yes, right.
Because we entrap part of the
the proximal lesion as well.
Target area.
Yes.
Open.
Open.
Open. Even if we get the first piece, is also. So I push, close. Yes, close.
So I give space, as I said, in between.
Mhm.
And then, okay, I think this is now a good position.
Right.
Yes. So I pull it as much as possible. And now, are you ready? So I'm now rotating the wheel. I close the snare. Snare closed immediately. Okay. Hopefully this is not too late. Done? Okay. So then we remove the specimen. So we just cut above what I said, above the snare. Okay. Get it out of the, oh yeah, we've got a nice piece open. Maybe you can come, open. Yeah, okay. Yeah, we got a nice piece with a nodule here
Right.
inside. And now we switch again to the other scope to see what we have achieved. Maybe you can move to another room if you wish, and when we show you the final result. Or are you any questions in terms of the technique? Do we still have the scope that we use? Yeah.
Yes.
Perfect.
Amitabh, and
So what is really important is...
any question from the audience?
Any questions? Yeah, question from Dr. Rajiv.
Yeah, Professor Newhouse.
Yes.
What is the maximum size of lesion which we take with EFTR? And when the lesion is just beyond the pylorus, what are the tips and tricks?
Yeah, so the maximum, the maximum is, I would say 2 centimeters, but it depends on the surrounding tissue. It is, for example, more difficult in the rectum because the rectum is attached to the mucosa to the mesorectum. It's more difficult to live. Lesions at the appendix are very easy to manage at the appendix orifice. And here in the duodenum, here is so challenging that we had the second lesion so close.
Okay.
Otherwise, up to 2 centimeters. This is the maximum, 2 centimeters.
Professor Newhouse, if it's a very juxtapyloric lesion, it's just within half a centimeter of the
Then it doesn't work because when the clip is finally
deployed,
deployed at the pylorus, this doesn't
might compromise the pyloric orifice. Beautiful.
So
There's another question.
Yeah, my question is this snare which is running outside the scope interferes with a suction and is always bubbling when you suck that.
No, this doesn't occur. So I think we have a good result. Maybe we have even the second lesion partially inside, and you see the muscle layer. Can you see the whitish muscle layer between 3 and 4 o'clock?
Right.
So we achieved the full thickness resection, and I think we already the second part is probably not completely was not in the snare because of its stiffness, but it has been resected.
Okay.
So that means when the clip falls off, the lesion will also
fall off.
disappear. And as we said, the histopathology was we will also see it here. If it's G1 well differentiated, proliferation index less than 1%, then it's fine. Even if we don't achieve a zero resection of the second lesion.
Okay.
So I would recommend the patient can start drinking. There's no risk of perforation.
Right.
Immediately, you can discharge him tomorrow. And I would recommend to follow this patient in about 3-4 months.
Right.
And then when the clip is will, I think, will be fallen off in about 60% of the cases. Otherwise, we have techniques to remove the clip, and then we will see. I think we removed everything.
Everything. So, Professor, what from 5 to 11 o'clock, the whitest tissue, what that would be?
This is a muscle layer.
Muscle layer. Okay.
And this snare which is running outside the scope, does it interfere with your suction, and it's not airtight and it just keeps bubbling when you suck whenever we had used it?
Yeah, that's true.
So how do you, I mean, so use more traction than suction?
Yeah, more traction. Because you might entrap, especially in the colon, you might entrap small bowel. And we published on a case, a patient in whom we did a FTR in the cecum, and the patient came with diarrhea after 3 months. And finally, we established an anastomosis between the small bowel and the cecum, so small bowel syndrome.
So this is the lesion which we can.
Yeah. This is the lesion. So I think we
Focus.
get a good histopathology. So I think we made the best of it.
Thank you, Professor. And we are going to another room done by Dr. Nalini Guda. Dr.
Two birds
Jubin,
with one
please
shot.
present the history. Dr. Jubin.
Yes, so for the next case, we have a 40-year-old male who came with obstructive jaundice of around 10 days duration. The bilirubin was around 12.4. The imaging is this. The MRCP showed a long segment stricture in CBD CHT with separation of segment 4. We did an EUS and there was a soft tissue mass in the remnant GB area, which on FNA showed a malignancy. So plan is for an ERCP and biliary sims in the right system. We go to Dr. Guda in OT3.
Hello, good afternoon, everyone. So I just passed the scope down. I'm using a Fuji ED580 XT scope as a 4.2 millimeters channel. Normally, I'm not used to doing this, but it looks like I had no problem getting down here. And I'm examining the ampulla here. You see the major papilla. It looks intact. But when I turn the scope here, you can see that there is a fistulous tract that is formed. And when I suction intermittently, I can suction bile out. And I'm not sure that fistula was formed because of the malignancy and obstruction or if there was a stone. So I'll quickly try to cannulate through the major papilla and see if I can get the wire up there. Otherwise, we'll go through the fistula and try that. So what I'm going to try is to show cannulation. I know this morning and yesterday we were working on it. Helping me is Srinivas from AIG. So I'm glad and honored to have him. So I usually use a papillotome to cannulate because there are data to suggest that papillotomes achieve better cannulation rates. As you can see, I'm struggling a little with this scope to get into the position because of the tumor and the anatomy. And I'm trying to get the cannula to orient between that 10 and 11 o'clock position where the bile duct is. So we will reach there and Srinivas is going to bow up slowly and looks like we are engaged. I'm going to use the big wheel away from me so I'm not. So we will try to advance the wire here. So there's a lot of pressure on the ampulla when I do that. So
Dr. Guda?
Yes.
Yeah, we are going through the normal orifice. If we go through we are going through the normal orifice.
Yes.
If we go through the fistula, don't we avoid the risk of pancreatitis in this case?
I'm sorry, I could not hear you well. You were asking if I am going through the ampullary orifice or not, because I'm not sure that fistula is coming off of the main bile duct or if it's coming from the cystic duct. So if I can get in quickly and see, I'll do it. Maybe the distal duct is obstructed with a stone or something. That's why it's not going in. Looks like, I feel like I might have gotten in. So you see that the wire is getting pushed out, though the tome seems to have engaged. So I think we are trying to go into the PD. Pull back, please. Fluoro? Oh, sorry, I have it. It's coming out through that fistula. So we'll try to go through the fistula and see, because that's what's happening. So we'll try to engage it and see where this wire goes. Wire. Fluoro. See, it is in the CBD, so there might be something that's causing a blockage there. Do you agree with me? So I'm trying not to inject contrast, so we'll try to go there. And when I looked at the MRCP images, it looked like that the left lobe was completely atrophic. I know you guys just heard Dr. Freeman, so either you have a complete drainage or an incomplete drainage. We would like to do a complete drainage. But the left lobe seems to be involved with the tumor and is completely atrophic. So the drainage we probably have to do in the right lobe. And typically, I don't like to inject contrast unless I get a guide wire access to that segment, because you inject contrast and you're unable to drain, then you unnecessarily subject the patient to the risk of cholangitis, and probably then would need further interventions like percutaneous drainage. Do you guys agree with me?
Yeah.
So. Straighten the wire. Try the wire. So that loop is useful when you get the loop. So I know we can push through that loop. There the wire is going in now. So I'm going to pull my wire over this. Now I am comfortable injecting because I know I can drain that segment. So inject contrast, please. Fluoro, there. So stop injecting. So you can see that it is opacifying, at least on the right anterior side. I don't see the right posterior. Do you see, Raj?
It's all basically right anterior here, but it's pretty.
So I can only see a right. So what I'm going to do is leave the wire there, pull the catheter back, and maybe inject a tad bit to see where the contrast is going. So we will try to magnify this. Leave the wire in place. I'm going to come back slowly. Inject a inject a little bit, Srinivas. Very little contrast, fluoro. So I'm going to come back, leave the wire there, and you can see the tight stricture there. So this wire is enough. So I'm going to again look at it carefully, and all I can see is the right anterior side that is opacified. I do not see the right posterior duct as well. Of course, the left did not opacify at all. So
I think you have some right posterior. See that on the.
So yeah, I see a little bit of contrast there.
Yeah.
Maybe I'll leave this wire in and see if I can get another wire through that to the right posterior. So I have access before I inject. So I will exchange, Srinivas. Exchange. So I'm going to leave that wire in. I'll cut, we can cut it a little bit. So subsequently, when I put a stent, it's not a problem. So we don't need a big sphincterotomy here, just enough to relieve pressure when we put large stents, because there are data to suggest that if you put large stents, when you do not do a sphincterotomy, there's a risk of pancreatitis. Is that your practice normally?
Yeah.
Oh, I'm sorry. This is a fistula. I forgot about it. So I just opened it up. So I'm glad you're. So let's exchange, please. It was a little tight. We opened it up, so it's good. Yeah, now there is drainage. So
balloon. Let's just clean it one time.
Yeah. So the question here is that, is this apparently this is gallbladder cancer. When I look at it, you see some frond-like structure here. It's rare, but sometimes you can see IPMN involving the bile duct. I've had only 1 or 2 cases so far. Have you had any experience with it?
I've had one case and it looks just exactly like this, you see.
You can see like the fronts there. It looks just like the IPMN of the pancreas. So we are not planned to do a cholangioscopy here, but what we will do is I'll put a balloon, as Rajiv suggested, clean the duct and make sure there's no debris, and then we will try to cannulate alongside this wire and see if I can manipulate a wire into the right posterior duct. Then we can try to inject and then subsequently assess. Yeah, ballooning. So you see that the contrast is not draining because it's above the stricture, but I'm happy because I do have access. I have a wire, we can drain that contrast.
Nalini, which is the wire that you're using?
This is a EUS-guided wire that I have. It's a so this is a point Terumo wire. Sorry, it's a 21 wire that we have.
So do you want to replace it with the EUS-guided or some other wire?
So this is what Srinivas gave me. I really don't have much preference in this situation. As long as it's a hydrophilic wire that has a floppy tip, it can bend, so I'm okay with it. Some people prefers angle tip wires. I generally use straight wires unless I have a situation like maybe here where I have to get it. So I'm going to use a stone extraction balloon here. We are going to use a...
If you have to put a metallic stent, you will need a stiffer wire, I suppose.
As long as you drive it, I'm comfortable with a 21 wire on, and I can do it. It's not a problem. 18 might be a little tricky, but so the way I was trained, I rarely ever use a 35 wire unless it's a tight stricture and I have to pull a stent across it. But for most of the times, one wire I use is either a 21 or really a 25 wire, and I get most of my work done with one wire. So I'm going to go in. This is a G-lock. It's a shorter wire we have, but the G-lock is working well, and I'm able to pull myself in. So the balloon is going in. As you can see, there seems to be like a stone or something. It's right there. And maybe that is the reason why the normal papilla was blocked and we have a fistulous communication there. So now I am past that. You can see a little bit of a tightness when I'm passing the balloon, but it's not so bad. So if I could pull the balloon over my wire, then I could easily pull my metal stent. I don't think I would have any problem. You agree with that? So I'm going to come back, clean it, and see there are 2 stones. I don't want to pull both of them from the top. I come down and then I'll take out one of the stones before I go to the second stone. Exchange? Yeah. I'll pull. I don't want to put the balloon up in the stricture, but I'm going to put it up here. But again, I don't want to jam both the stones, so I'll blow the balloon up between the 2 stones, so I take out one at a time. So the wire is intact. So now I think I'm between the 2 stones. Balloon up, please. It's a 15 millimeter balloon. Balloon up. I think it is up now. So let me see if it'll come out. The tight stone. It's very tight. I don't want to pull it and...
I would just maybe go through the papilla. You can cut the whole thing up.
Yeah, so I might try to get through the papilla with the other wire and then cut the whole thing open so the stone will come out. So because I can see it here. So let me try that first because here I'm not sure how much I can extend. Looks like we have some room to extend there if I need to. But I will try to go from the major papilla and try to open that up so the stone will come out easy. So I'm going to deflate the balloon, leave the existing wire there. So because I don't want to lose my access. Once you have access, it's critical to maintain it, especially in a situation like this. So wire is intact. Ready? So the wire is locked, it's intact, and I'm going to pull this out. So the wire is not moving. I'm just doing pulse fluoro. It stays in position. So we are exchanging it. And we are out now. So I'm going to lock my wire on my fingers. I don't use any fancy locks. Fingers work well as locks. So I'm going to push the scope in, get into a position here, try to get into the major papilla and see if I can do a sphincterotomy, get the stones out, and then we will try to get another wire. So I'm using, what kind of wire do we have? The Terumo wire. I think that's the theme of the day here. So again, I think I'm oriented pretty well here. I'm going to try to get under and lift it up. It looks like we should be in. Yep. Fluoro.
Yeah.
Try the wire, please. Take that loop.
PD, no, you're
Keep
good.
Take,
You're good.
take, nice. PD, pull back.
You can leave a PD stent, actually.
So this is what we were talking about. You know, that's the guide wire cannulation to the PD. If I do that repeatedly, then I might have to stand, bow up a little bit, please. Though it looks like it's only a millimeter apart, that's what happens. Now try the wire. Looks like we're lined up pretty good. There you go. Keep going, keep going, keep going, keep going. Well, yes. So now we're into a different.
It's a very
there's
good
a loop
demonstration,
there.
Dr. Buddha.
I'm sorry.
It's a very good demonstration. After entering into PD, you are able to cannulate the CBD, but there is no need
Straighten
of.
your wire, please. Yes, because I have a target to hit, so it was easy. Straighten your wire, please. Now try. Take that loop. Take that loop. Remember, this patient has got a hilar tumor. It's a very tight stricture there, so hopefully we'll get this wire.
We can still cut from here.
Yeah, I can cut still. So try the wire. I'm going to try to push it. Straight now, try it. So it is taking the loop. Alternately, I can open the sphincter. I can do a sphincterotomy here because we know we are in the bile duct. Inject a little bit contrast, please. Okay, so I'm going to leave the wire loop there, inject a little bit. I just want to make sure we're in the bile duct before I cut. So yeah, that's good. So you can see that we are in the bile duct. There are some stones there. Stop injecting. The contrast is not going anywhere. So I bow up slowly. So I'm going to open this up. So it's easy to get the stones out now. Bow up a little bit. It's going a little bit away. I will adjust it. But we should be able to open that. You know, if you had a rotatable papillotome, it would have been easy, Rajiv. But this is non-rotatable. So I'm going to try to use my hand and scope to rotate it into that angle. Looks like I'm in that direction now.
Very good direction, yeah.
Go up a little bit, please.
So you have a lot of safety room there.
Yeah. So here I'm just gently rotating my hand and trying to cut it.
There you go.
So we are almost there to meet the fistulotomy. So fluoro.
Easy.
Yeah, fluoro. Oh, I have the fluoro. Sorry, I'm not used to this. So we are right there. So I'm going to open this up a little bit.
Push the scope in maybe, if that helps. There you go.
So I'm just using my hands to change that angle. We are.
Very good job.
And the thing is that this is a coated wire, so I'm happy even if the wire is cutting. If you're doing like a uncoated wire, then you worry about transmission of.
You already connected the two. You're good.
So I just did. So you can see that we made the papillotomy connect to the fistula. So now we have a bigger orifice, and hopefully we can
cut even more, right?
Bow up a little bit. There you go. So again, I'm going to change my angle with my hand. So if the cameraman can show, I got my left hand across my chest, so it changes the angle. Now you see how it's going up nicely. So it's a big sphincterotomy we have. So I'm going to go in, bow up again. So look at the contrast again. We'll make sure that the contrast is not leaked. This morning, those of you who have heard Dr. Freeman's lecture, you want to make sure that there's no extravasation of contrast anywhere. So now you see I have even a better angle to cut even more, but do you think we should cut?
I would cut more. You have a lot of space and those are big stones, so you could cut it right.
So the reason why I'm extending the cut so much is so I don't have to struggle taking out those stones. So now you see it's getting nice and big. So you have a little more room, but I think that should be adequate to get the stones out. So I'm going to exchange because I don't need this wire anymore, and I'm going to go back over the wire that I have with a balloon and take the stones out.
Sir, while you just change the wire, we will go to another room. We'll come back to you in 5 minutes, sir. Is it fine?
Sure.
Okay. So for the next case, this is a 52-year-old female who is morbidly obese, and the BMI is 41. She also has dyslipidemia. The plan is to do an endoscopic sleeve gastroplasty. We go to OT4 for ESG. Sir, you're online.
Yeah. Hello, good evening, everyone. So we have a case of obese class 2, a female of 40-50 years has stolen history. So with me, I have Dr. Saurabh, who is an eminent expert in the ESG. So what we're going to demonstrate is endoscopic sleeve gastroplasty, and the device which I'm using is the Apollo overstitch. So people who haven't heard of this or who have got limited knowledge in this, so this is a Apollo overstitch is a device which is dedicated, made from Apollo endosurgery, and it has got a couple of components in this. What you need to use is a double channel scope, which is mandatory to use this device. And this double channel scope has got a 3.8 working channel and a 2.7 smaller working channel. And you have, as you see on the screen, the scope is like this, and this is the handle which is mounted on the scope of the shaft of the scope. And you have a closing and opening handle as you see it on the screen. And you see a needle driver on the endoscopy screen, which is evidently shown on that. So you mount the suture onto that needle driver and then start suturing. So the first component is the handle on which is mounted on the double channel scope. And the second is anchor exchange, which will go through the bigger channel, and through the smaller channel, you will have the helix, which is used to grab the tissue. And then you have a suture, which is a 2.0 polypropylene made suture, and also a cinch, which is used to tie the suture once you have done the pattern. So what we have to understand initially is the anatomy of the stomach as we see. So we start at the incisura, that is the anterior wall, and then make a U pattern suture. So the first suture will be on the anterior wall. The second will be on the greater curvature. The third will be on the posterior wall. And fourth will be a centimeter below the posterior wall in the same plane, then the greater curvature, and then the anterior wall. So this is how the suturing pattern starts. So I'll start the suturing pattern, and first we should understand the anatomy of the stomach and then see where to start. So as you see on the screen here, I am at the pre-pyloric area at the antrum, and once I come at the incisura, I'll position myself there and then start. So as we have seen, the suture is mounted on into the anchor exchange, and I'm going to put the suture in the bigger channel, that is a 3.7 working channel diameter, and then push the suture anchor exchange down as it comes out of the endoscope. So you have two towers. The longer tower is the one on which the needle driver is mounted, and through the shorter tower, the anchor exchange will come out. So let me just pull the anchor exchange out. So as you see, yeah, you see the suture with the anchor exchange loaded. I'll just take it inside, and you watch my hand movements as well as the scope, endoscopy picture. So this is how the anchor exchange, the needle driver is closed. And now I'll push the anchor exchange so that it gets engaged onto the needle driver. And then I'll push this blue knob partially to open. As you see, the suture is loaded. Can you appreciate that? So once it is loaded, now my next aim is to go at the incisura to take the first bite. This is the helix which has got, can you open the helix? Yeah. So as you see, they have got concentric rings here, close. So this helix is supposed to go in through the smaller channel. And as you go there, let the helix come out. So once the helix comes out, I'll again emphasize that the first bite will be on the anterior wall, second on the greater curvature, third on the posterior wall, then 1 centimeter down on the posterior wall, greater curvature and anterior wall. So there will be total 6 bites. Yeah,
And so
Saurabh,
can I just ask, you're obviously not doing any marking to guide where you're doing the suture placement, but would you recommend that if someone's learning, or have you done the marking?
Exactly. For the beginner, it's always good to do the marking, but I mean, it's all again individual subjective comfort. But what I would see is once you put the markings, then after doing 2 or 3 suture patterns, they'll, disappear or vanish.
They'll be obscured. Yes.
So as you see here, the helix has been rotated. There is no hard and fast rule of how many times you have to rotate, but as long as you get a good grip of the tissue, that is main important. And as you see, the helix is rotated, and I am pulling, the hand movements are very keen. I am pulling the helix inside and holding the helix with my left hand, left fingers, and closing the needle anchor exchange. And now I'll leave the helix and push the anchor exchange down and pull back so that the needle gets transferred. Now I open the handle, then unheal the helix back as anti-clockwise rotations, and I'll push gently the anchor exchange so that the scope is detached from the mucosa. And as you see here, the first bite, a full thickness bite, you can appreciate on the screen.
So that's the importance of this procedure, is what was demonstrated beautifully with that first bite is we've got to bring the stomach wall to the instrument.
Exactly.
We don't push the instrument to the stomach wall.
True.
Because then we're impacting on the ability to get that full thickness.
So the second bite will be on the greater curvature. As you see, I'll repeat the same movements and then try to grab the tissue on the greater curvature. Yes. Okay. So the same movements. Push, pull back, open, unheal the helix. Okay.
And there's different patterns of suturing. You've mentioned you're doing the U pattern.
Yeah.
Have you found that there's any difference in the different patterns?
There are different patterns, but by and large, some people do the M pattern. So it's all again very subjective, but standard, as a matter of standard across the world, there is kind of a consensus on that you can use, ideal one is the U pattern, which is what I am doing now. But there have been studies on different patterns, but by and large, as of now, at least it's a consensus statement that U is the best one.
Rakesh sir, just for 5 minutes, can I just shift to other room while we continue? Sure. Okay. So the next case is a 75-year-old female who has a CA head of pancreas. Previously, we've done the biliary stenting, but now she has come with a gastric outlet obstruction. The plan is to do a EUS GJ, a freehand GJ. So over to OT1 with Dr. Rajesh Puri, sir. Sir.
Am I audible in the hall?
Yeah, Dr. Puri, you're audible.
So what I did was, this patient has a CA pancreas with a metal stent in situ. And the patient has a gastric outlet obstruction
You have seen in the morning, Dr. Sandeep was demonstrating the EPAS balloon guided EUS-GJ, which is safer, but we are going to demonstrate you the freehand technique. And what I did was, with an upper GI endoscope, I put the wire deep into the proximal jejunum or D4. And over the wire, I put a 7 French nasobiliary drain. And you can see the nasobiliary drain, the place where it has coiled, most likely near to the stomach. And I have Professor Ben Muller, who has invented the lamps, who is going to help me while doing the case.
My pleasure. So the most important right now is to make sure that you can get good filling of the small intestine. A 7 French will do, but personally, I like to use an 8.5 French just because you can fill more vigorously. So you have to have your nasal biliary catheter hooked up to a pump, a water pump. So here's our water pump. We're going to hook it up.
Going to attach the water pump on the nasobiliary drain. I'm just taking the help of fluoroscopy to ensure that my tube should not coil.
So as soon as you're in the upper part of the stomach, that's where your gastroenterostomy will be. So you don't want to push down too far because sometimes you dislodge then the nasobiliary. I like to call it an oroenteric catheter because that's what it actually is. It's not neither nasal nor is it biliary. So it's oral enteric.
Is this okay? I suppose.
So what I like to do first is just use some fluoro to get myself into a good position. So, okay.
We are deep to the, we are below the
block. All right. And
what we are going to do is, we will put some water. Can we give the glucagon? Glucagon given.
So I will typically give half the dose when I'm looking for the loop to go for. And then right before I do my entry, my puncture, then I'll give the other half.
I think we are very deep. We can pull it. Don't you think so?
Yes.
Yeah, very deep.
Yeah. Usually I like to see the catheter in there, but I think you can see it. There looks like there's a shadow there in that loop of bowel.
I think that is a catheter.
Yes, it looks like it. So you can definitely pull back some if you're, if you want to get the pigtail across from you.
Can you show the fluoro? I'm pulling this. We are very deep in.
That's because the oral enteric catheter is looped in the stomach. You see, there's a cord, there's a loop there, but you just need to be careful that you're going to straighten out the loop in the stomach, and then it's going to start pulling back.
The water.
Okay.
Yeah. Can you see here the catheter?
Very nicely.
This is the catheter.
You see the tram track.
Yes. Tram track sign.
Okay, so now let's start to fill.
Yeah, filling some.
More.
Yeah.
Can we pull further more? I think we should pull further more. Don't you think so?
Oh yeah, you have to fill it more than this. You want to have a diameter of at least 3 centimeters if possible.
Can you show the fluoro, please? Can you show the fluoro? This is also a good loop.
Yeah, I think the only limitation right now is just with the 7 French, it just takes longer to fill this up.
Can we fill more?
So this is where, if you want, you can pull back your catheter because.
Can you see now? We have very good position. Descending loop.
If you're coming from the left side, it's good, but if you're coming.
No, I'm coming from the left side.
You are. Excellent. Then that's perfect. Very good.
Can you show the fluoro, please? Put the water. Yes.
That's nice.
Yeah. Can you give me the stent? Yes. Put more water. This is the loop which I need to punch. This is the loop which I need.
Yeah, it's ideal if it's in the trajectory of
Can you
the
give me
long
more
axis.
Yes, injecting. Give me the more water. Injecting. Fluoro. I'm pulling my device furthermore. So before doing this, you have to lubricate with the water.
Yeah,
to
so
make
it goes
possible
smoothly.
respiratory.
So you like to come out from the left side, I see. Okay.
I have been taught by Peter Willman.
Ah, yes, of course. He does it from the left. Good. Well, that's important to know.
Put more water. I think this is a very good lift.
It's excellent.
Can we put the Doppler? Put the Doppler.
Dr. Rajesh sir,
Yes.
what is the advantage of glucagon over buscopan, number one, and number two, what should be
The
the
patient is elderly and who has a coronary artery disease. That was the reason. Otherwise, we use the Buscopan.
and what should be the ideal size of that loop in which you are planning to do?
More than 4 centimeters.
Perfect.
Show the fluoro, please.
Yeah, looks good. I think now you just need to find a good point. Maybe advance the sheath forward a little bit so we can see where it's coming out. Okay, there it is at the top. So as long as you're in that trajectory, the distance between the loop and the wall should be, no more than 1 centimeter. This is a 20 millimeter, right? That's perfect now. I think you're ready to go. And so you've got auto cut, right? Pure cutting current, high wattage.
I've unlocked this.
Okay.
Gonna put the water in the injector. It's okay.
And very slowly go through. Okay. It's good, but sometimes when you go fast like that, you can tempt it away. But I think you're going to be fine. So what can happen is that when you go fast, then it slides by. This one is in the lumen. I think you're fine. But what can happen is you push the small bowel away if you thrust it too fast.
I've locked this. I'm going to unlock this.
And I would just really just focus on the EUS because you want to see that distal flange open up.
Yeah.
So you have to wait till you hear a click, and you should be seeing the distal flange. There was a click? No. All right. Well, the fluoro's not going to tell you anything right now. So now you have to find the plane because there's a possibility you did slide by the small bowel. But so move around a little bit to see if you can see.
But this flange has not opened up. You see the problem with the flange.
Oh. Pull back on the black a little bit. I don't know.
Stent has not opened.
Did it go to the midpoint here where it, yes, it did. Okay. And let me just sort of see. I'm pulling back a little bit.
No, the reason is that we are in
You're
the
right.
demand, but this has not opened up. There is some problem in the stent.
It could be. I'm not sure what to say. I think what you do now is you put the guide wire in. Just as a safety, I would put a guide wire through here.
Guide wire brings the loop away.
Well, or you can pull out and go in again with a new one.
Can we have a new stent?
And then we'll check and see what went wrong because now you don't want to deploy the proximal flange.
Because you see the proximal flange, we have opened it and it has not yet opened.
Yeah, the distal flange, I don't see it. You're right.
Because we can move here. Can you see here?
Yeah, I agree. I agree.
Can you observe this? We are in the loop.
Yeah.
It's not opening up.
And then sometimes it takes a little bit of time for it to, but I'm not sure why it didn't deploy. Yeah, you can't even deploy the proximal flange here. Oh, wait a second, one second. Hold that position where you can see it longitudinal for me. I think I can salvage it.
That's probably true. Can you
Yeah,
see it?
okay, yeah. Very slowly, let me see what happened. There is something wrong with this, because there's a lot of resistance here.
Fluoroscopy image,
Yeah.
please.
Some problem with the stent. I
Yeah,
think.
there is a problem with the stent. There's a lot of resistance, so something is,
Can we recheck? Can we change the device?
yeah, we have to change. I don't know why. There's a lot of resistance.
So we need, should I remove it?
Okay, so just unscrew it and pull it out and we'll go back in. It's all right. It's just there's just a tiny hole that'll close. Okay, pull out and then quickly put a new one down. And then we'll send this to Boston and see what the problem is.
Some problem in the.
Yeah, new one?
Yeah.
And here you want to be quick, just because you could get some leakage coming now from the hole in the small bowel.
Can you put the water?
Yes, please.
Okay. Yeah. Can you put the water, please? I think this is okay.
Yeah, it's good. It's
Put the doctor,
nicely generous. Looks great.
Can you see the water here?
Yeah.
Remove.
Okay, take off the Doppler.
Okay.
Yeah, looks great. Okay, don't tend too much, just slightly against it. Yeah, there you go. All right, and just slowly advance. Okay, there, you're definitely in. So let's see how it goes this time.
I'm going to lock it.
Yes.
From this.
Okay.
Can you show the fluoro, please?
Okay, and push the black down just a little bit more. Okay, and pull back a little bit. I don't know why. Just careful. It hasn't deployed yet, the distal flange.
Let's wait.
Do you have to wait sometimes for the distal flange to open up? I don't know why, but you can see the distal flange hasn't opened.
Can you put the water? Can we go?
So sometimes if you just jiggle a little bit with the black.
What has happened? We have released proximally. It has opened into the lumen. We are in the lumen. Not in the lumen, we are in the wall. That's why it's not going. Yeah, we have to push it a little more.
Yeah. It's gonna open in the interposed
No, but
space.
we are in the peritoneum now.
Yes, you are.
We are in the peritoneum.
Okay, so now what I would do is I would put a guide wire through there. Yeah.
We have released little proximally.
Because a little bit of this is inside of the lumen of the small bowel.
Just show the fluoro. This is the challenging situation.
It's all going to be fine. We just need to get now a second.
No, we are not.
So it looks like the lambs is outside the wall. All right, so unfortunately we can't.
We are outside.
Yeah. Okay, so here's what you can do. You can resheath this. Okay, you can resheath this. And there's a latch here.
Patient does develop a side.
Well, of course, there's like a, I'm trying to resheath it. Yeah.
That into it. Can you do it?
I don't know why the latch isn't. No, I do it. Yeah. Can you do it? Okay. There's a latch there. You got to push it in, and then this thing will go forward, and then that
will close the distal flange. Normally it advances forward. There it goes. Okay, wait. Now, is it issue? Yeah.
Dr. Puri sir, I'll just take you away. I'll go into ESC.
Oh, it didn't resheath. Okay.
We can switch
So
to
this is the way to
ESD OT4. Rakesh sir, you're back.
So we'll pull out the whole system.
I thank the moderators and chairpersons for this session.
Okay, am I on?
Yes, now.
Next
Okay.
moderator.
So we have done 2 suture rounds and the third one is on. So came at the right point. As I have shown you in the last 2 bites, how to take the suture.
For the next session, I call the moderators, Dr. Avnish Seth, Dr. Bir Singh Sherawat, Dr. N.P. Dinamitra, Dr. Rajiv Grover. And to chair the session, I call Dr. Ashok Jajaria, Dr. Alok Mishra, Dr. S. Rangta, Dr. Lohit Chavan, and Dr. Tanvi Sawan. I request the moderators and chairpersons to please come up.
Okay. So, as I told you, we have taken 2 suture rounds, and the third one I have started on the anterior wall and then came back to the anterior wall of the 6th bite. Now it's very important to show you how we cinch this suture. As you see on the screen, my hands and the scope. So the cinch is being put on the bigger channel of the scope, and the suture already is there in that. So what I'm going to do, you watch my hand movements. You can see the cinch on the endoscopy screen with a wide tip. So what I'm going to do is I'll push this gently onto the mucosa, and you see my hand movements. I'm giving traction on the suture so that I'll get the maximum traction, and simultaneously I'll push this cinch so that I'll get some more room to give traction. I would say this as a transmural because you can see I'm holding the scope in the air, and this is the traction what you have to give on the suture. And then once you get the maximum traction, you push the cinch down. You should make sure that you have around 1 to 2 centimeters of those concentric rings on the cinch visible on the endoscopy screen. And now once you have the traction open, so you can see Srinivasa's hand movements. He's released the lock, and then with both the hands, he's going to tightly press it. And as you see, the cinch is done. So can you appreciate on? So this is where we started. We had 3 rounds of sutures. We have opposed the anterior wall to posterior wall. I'll show you the anatomy as you come up to the GE junction. So there's a long way to go.
Long stomach.
Yeah, it's a long stomach. She's around 41 BMI, obviously expected to have a long stomach. Though she's not, I think she's around 5'7", 5'8". Okay, can I have this? So we'll be happy to answer any questions if you have from the floor.
So
me and Saurabh are here. Yes,
so the other thing is it's very important, and you've got obviously that experience. But when you're pulling the suture, it's very important that you visualize the stomach bunching together.
Exactly.
But if you pull too tightly, what can happen is the suture can disengage from the anchor.
Yes,
and
exactly.
it can break the suture.
Yeah.
Or
so that's something which you cannot afford.
And you can't afford that because it's ruined all your work.
Yeah.
And so you have to pull it tightly.
Ruined all your
enough.
work and money.
Exactly. Well, the company will be happy. But,
yeah, that's true. Okay, so now I'll again show you the steps. So these steps are basically like a dancing steps. You need to have a complete control on the scope and the procedure what you're doing, because the job of the tech will be only to heal and unheal the helix. Okay, so as you see here, the helix is getting winded up, the mucosa is getting swindled, and as you see now, I'll show you the movements. Push in the anchor, pull back, open the handle, unheal the helix, and push the anchor exchange away so you get the first bite. Can you appreciate it there?
So tell us what kind of trouble you might get into and how would you get yourself out of that trouble?
Yeah, very important points. So each step in this is so important that if you miss one of those, then you end up in a catastrophe. So one is, of course, with the helix, not many, but with the anchor exchange, this pushing in the blue knob and then pulling it back. So that's where you should be very cautious, because if you push this blue knob deep inside up to the brim, then you might drop the suture. So you have to make it half the way. So you should have a good tactile sensation and a little bit more sensitiveness when you're doing this. Another important thing, as you see on the screen, the distal end of the anchor has got a small pointer. Can I appreciate that? So if by chance, in a hurry, you try to close this needle driver, so you will be losing that anchor exchange because that gets into a bend. Yeah. So you always should make sure that your anchor exchange tip is not visible on the scope, and then only you close the needle driver, push the anchor exchange onto the needle driver, and then gently pull back so that now it is loaded, right?
And the other thing you've nicely shown is that whenever you've got your sutures, you're keeping the leading suture and the trailing suture both on the same side of the towers.
Yes.
And that way you can avoid the suture being crossed over.
Crisscrossing, yeah.
Because crisscrossing of the suture will result in less tight gastroplasty and may impact on the result.
Yeah, they'll dehisce soon.
Rakesh, when you make view of the suture from anterior wall to greater posterior wall, when you come back, what should be the distance? Because every suture is very costly. Number one. Number two, the last suture should be how much centimeter away from G junction?
So the last suture will be 7 to 8 centimeters away from the G junction, because we are not touching the fundus, or you can around 10 centimeters, you can say 8 to 10 centimeters max, not more than that. Because that's again a key, very important point. The fundus is going to be an artificial gastroparesis, a reservoir of food, which will create a kind of artificial gastroparesis.
And what should be the distance between the two arms of the U? Because that will save the suture. 1 centimeter, 2 centimeter. When you go from anterior to posterior wall, then posterior to back.
Yeah. So there is no hard and fast exact diameter of how much to leave. It all depends on the anatomy, what you're dealing with. If you have a small stomach where your anterior and posterior walls are not far apart, then you can take probably 1 or 1.5 centimeter in between. But if they are big enough, then probably you have to take, as I told you, not even 6 bites. You can also take sometimes 8 bites. What I mean to say is you have to take 4 bites from anterior to posterior and 4 back. You got my point?
Perfect, perfect.
Yeah. So I think the most important thing is to make sure the bites are close together.
Exactly.
So in the initial Apollo experience, the group was doing an eye pattern of suturing where they did 1 bite on the anterior wall, 1 bite greater curve, 1 bite posterior wall. And so they would just do 3 bites in a single row. And they found that the tension in that suture was too high. So the suture would cheese wire through the wall.
Yeah.
So if you put the bites much closer together, so no more than 1 centimeter apart with the bites, then you will have distribution of the tension equally throughout those multiple bites, and you're less likely to dehisce and to break the suture.
So when you're doing a procedure intra-op and then post-op, you have done a fantastic job. But once you go back and then, you redo and check endoscopy, which we usually don't do, then they'll be surprised and also a little bit of getting depressed that the sutures have, taken a day. So the suturing pattern is very important, and the number of sutures also. So I principally advocate at least 6 to 7 minimum sutures to get a nice long-term sustainable outcome in terms of weight loss.
And the fundus, the question that was raised in the audience is also that there's been studies looking at closing the fundus or not closing the fundus, and there's been no difference in the weight loss results, but a significantly increased risk of complications if you suture the fundus. So the consensus is not to touch the fundus because it doesn't benefit the results and increases the complication rates.
Yeah. I agree with that. Yeah, that's right. So you see again, now I've come back to the anterior wall and I'm cinching it. Okay, cinch. Thank you. So let me just show you that.
The other important thing you're demonstrating nicely is when you are taking the bites, you're always making sure you decompress the stomach a little bit.
Exactly. That's very important.
If the stomach is very tensely distended with air or with CO2, then you're less likely to be able to have the compliant tissue to pull between the 2 towers. So you need to keep the stomach, even though it might impact your visibility, you want to keep it a little bit collapsed.
It's always good to have a low flow CO2 rather than a medium or a high flow. In fact, sometimes I would completely switch off the CO2, decompress the stomach and then go. One, as you said, the stomach, if it is highly inflated, then the bites are not good. And also you end up taking more on the anterior wall, more on the posterior wall, and that will not give. See, the main aim of this procedure is to make an accordion stomach, a tubular stomach. It's not the area, but the shape of the stomach should be around 70% volume reduction to the normal volume what it is.
And some other technical aspects, the patients are always under a general anesthesia.
Yeah.
They all get endotracheal intubation. We generally, for ESG, will use the overtube,
yeah,
which we've used here as well.
So I see it's a very superficial bite, which I'm not happy. So what I'm going to do is the next bite, I'll take it near to that so that I'll get a good amount of tissue on the anterior wall itself. So that's again something important for the robustness of the suture. Okay. Yeah.
Rakesh sir, I'll just go for a minute to one more room and we'll come back.
Okay.
Yeah.
So this is running a marathon. Don't worry. Whenever you have time, you come and show us and then we'll entertain.
Yes, sir.
Okay.
So we go to OT3 with Dr. Guda, who's ready with the stent in that case.
We are trying hard to see, looks like the stricture is very tight. I'm having trouble even advancing a balloon over it. I was able to get a second wire, but I don't think we are able to get the wire into the right posterior. So both those wires are going into the same segment. I'm a little concerned if I put a metal stent, whether he will drain completely or not. So I hate to commit him to a metal stent if I'm unable to completely drain him. So I was discussing with my colleagues here and we were thinking that maybe we should just put a plastic stent trial, see if the bilirubin normalizes. If the bilirubin normalizes, then we know that the drainage is adequate and then we can commit to a metal stent, because if I commit him to a metal stent now, then if he is incomplete drainage, then he would need a PTC, which probably is not good for his quality of life. So is everybody comfortable with that idea?
Dr. Huda.
Yes.
Plan for the biliary dilatation of that stricture?
I'm sorry?
Have you planned for a dilatation of the stricture by 7 or 10
We'll balloon dilate it, but the stricture is fairly long. If you can see the screen where the top of my balloon is, that radiopaque marker, that's all the tight area that I'm having trouble to pull despite a stiff wire that I changed to. So if I have to balloon dilate it, it will be a long segment that I need to dilate. And we've been trying hard. So the one thing that we do not have here and might have helped, I'm not saying it definitely will, would be a swing tip catheter where you can actually, if you can see my finger, it swings this way or that way. So if you have a situation like this where you have a stricture at the hilum, then you could bend the cannula to go in one direction or the other. So while you guys were watching the other procedure, I tried to do that same thing with the papillotome by bending it, but unfortunately it was not giving us the angle with which I wanted to go. Rajiv Atam also had tried to be my assistant and get the wire. We changed it to a stiff wire. We changed it to an angle tip wire to get in. And despite me changing the position of the scope and trying to line up straight, we were having a tough time getting a second wire through the stricture. Now you see that I have, you can try, we've been trying a lot. So I have Ora here who wants to give it a try last one time before we so there it is very tight. You want to go to the right posterior. So yeah, but it comes off here. It's the stricture there. And yeah. So now I think the wire went into a different segment, but it's the same segment.
Same segment.
Yeah, no, it has to go to the right.
Which one, sir? Which one do you want?
That right there, right there. No. So you see where the wire is bending, that's where the stricture is, and it's bouncing off despite trying to change the angle. It bends and it's so the other thing I tried while we were off camera was to try to insufflate the balloon there. Where the wire is getting stuck and bending is where the orifice, the duct is opening. So we are trying to rotate the C-arm into the right posterior or oblique views Despite that, you see how the wire bends there, and ideally, if the wire gets into that segment, then I think I'll be comfortable trying to go in and put in a stent. You can. So he's going to gently inject a little contrast. I don't like a lot of contrast because if I cannot drain, then it's not good. So we will drain a little bit of, we will inject a little bit of contrast. Hang on, fluoro. So there is a contrast, stop fluoro. So now you see the stricture, it's very clear. It's a long stricture, so I could dilate it, but I'm not sure if it's going to make a big difference. Do you think dilation is going to make a difference, Rajiv? Yeah.
Try from the 7 biliary dilator, then get.
So if I can get a Oasis because of the inner cannula, I think I should be able to get a 10 French stent in. So I'm going to clear the duct and then put in stents, and we'll see how he does, because, you know, I think I've almost given radiation therapy for him by doing fluoro. So, but Vora here wants us to give it one more try. So he's got the magic hand. He's trying his Midas touch. So there is the segment where it needs to get into. But it bends, it bounces off the wall. That's where we are having trouble. And here is where I think having a swing tip might have helped us. Again, I'm not saying definitely. Those of you who are older enough in the audience, you know, you could try the Haber ramp catheter, but I was not successful much with it. But swing tip definitely would have helped in this situation. So again, this is the same situation we are having where the wire buckles and would not go through the stricture. So the stricture is pretty tight and rigid. So Rajiv, you have any other ideas or suggestions?
Can we take this mail lab?
Yeah, that will not help.
But we'll take a spintorum and bend the spintorum and then we can go in.
Okay, let's exchange. Hang on. We'll take out the stones while we are there. Hang on. So we were waiting for you to see that there were 2 large stones. So put the balloon up, please. Put the balloon up. So hopefully the stone, there's 1 stone, balloon down. So the question was, should I remove these stones? And the reason why I thought we should remove these stones is, you know, the stone has been there, and when we went in, it looked a little bit purulent drainage for me. So the stone could act as a nidus for infection. So though you might drain, then subsequently, if the patient is having fevers, auric stone hai, balloon up. So we're going to pull the stones out. So I'd like to keep the duct clear. That way there is no concern for any source of infection. These stones have been sitting there causing ductal blockage. So balloon down. So now I think we cleared the duct distally. I'm going to make one more sweep before I change it. I'm a little paranoid about leaving anything there.
You want bigger fluoro picture?
I'm sorry?
Bigger fluoro picture? Yeah.
Fluoro? आपही के पास fluoro है.
Dr. Guda sir, I'll just take you 1 minute away. I'll come back.
Sure.
So we go to OT1 to Dr. Puri back again, please.
Balloon down it.
So what we did was, we over the wire, we put the wire through the lamps into the peritoneum, and over the wire we have applied the Ovesco clip. And you can see on fluoroscopy, there is a can you see the Ovesco clip on fluoroscopy? Am I audible in the hall?
Yes, Dr. Rajesh, you're audible.
So what we did a Ovesco closure of the stomach wall. Keep it traction. And now we are again putting the nasobiliary drain to do the EUS-guided GJ, followed by the drainage of the peritoneal fluid. I think this much is sufficient.
Yes, it's good.
Yeah, withdraw the wire. So I'm going to show, we have again putting the nasocystic drain, nasobiliary drain. And I will show you over the wire that this is very important. You never withdraw the scope, put a wire into the peritoneal cavity
and make sure that your Ovesco clip should close the stomach hole. So can you see here, Ovesco clip?
Yes.
And this is the site of puncture, because if you don't close it, the stomach content keep on leaking. Can you show the fluoro, please? So I will suck the air, remove the air from the stomach, and I will take the new device. The first device was malfunction, and the second device, I think, technically I should have gone 1 centimeter more. So that should not have created a problem. So let's do a EUS-guided gastroenterostomy again. And let's see, we will be able to successfully do it or not. Fluoro?
We will.
Yeah.
Third time's the charm.
Yeah. So this is very important, but I kept the wire in the peritoneal cavity. I closed the defect in the stomach. That's most important. And if I will be able to be successfully done the EUS-GJ, then the third point remains the small intestinal rent, and the small bowel has a thick muscle layer. I think that might close of itself, or I'm going to take a thin scope and reach to the part of the proximal jejunum. Because of the gastric outlet, sometimes it is difficult. Otherwise, I will put a percutaneous drain into the peritoneal cavity to ensure that there should not be any peritonitis. My only problem is when we are going to put the water, it is keep on leaking into the peritoneal cavity.
Some of it will.
Yeah, that's biggest problem. We have given the antibiotic Metrogel and the shoulder ko on karo, light on karo. So I will take my scope into the stomach. Fluoro, there's a little bit of fluoro, just to make sure that my nasobiliary drain should not get coiled. Little bit of the jelly. Yeah. Can you show me the endoscopic view? Yeah, I'm in the stomach. CO2 is on. Okay. Suction is not there. Can we give the suction? Now, what I'm going to do is I will again going to focus the GJ site. Can you show the EUS view? Yeah. And on the opposite direction? Opposite direction? Yes. So this was the loop which we were supposed to puncture. Is that right?
Yeah, it looks good. Now this time you have some ascites, right?
I
You
will
have some
keep the.
fluid.
This is
So
loaded.
you have to this time go very slow.
Yeah.
When you puncture through. Because it's going to be, now the small bowel is floating inside the fluid. So there's a tendency to push it away when you go in.
Yeah, slow
So you have to
means
go
what do you mean
very
by
slow.
what do you mean by slow?
Stricture bigger one.
It means you need to give a lot of energy. Just keep it on the spot and just very slowly advance forward. And you're going to need better filling, and you need to give glucagon now. There's too much
Can we give the
contractility.
glucagon? Can we give one more glucagon? Can we give glucagon, please? Once you give the glucagon, wait for a minute.
Literally no mechanical force.
So this is important. Yeah, just wait. Don't fill the water.
Yeah, wait until the peristalsis calms down.
So one of the most important thing, never lose your calm while doing the procedure. And that is, I think, key to success. Is that right?
That is absolutely correct.
And
yes.
if you get worried, then you will.
We're in the country of Om, so just go back to your roots.
Glucagon given? Is given? You are giving or given? Giving. I think, can you show the nasocystic drain? We are too deep. Can you make this small fluoro? Small fluoro? We are too deep.
I don't know why, but I see nasal cystic everywhere.
Yeah.
Where's the looping? It got looped.
Is this okay now?
Yeah.
Is this okay?
Yeah, it's better.
But I think we should pull it, don't you think?
Yeah,
Yeah,
I
we
think
need
it's
to
way
pull it.
down too far.
Yeah. Show me the
The
fluoro.
only
please.
problem with that is just that
Show me
to
the
get
fluoro.
filling of this part takes longer then. You're waiting for the retrograde filling. So you want the pigtail pretty much in front of the scope.
Not tip. Yeah, can you see now? Let the lumen to be filled. Can we withdraw more? Just wait. Can we make the image bigger a little?
Yeah, it's the anatomy is a little, I mean, I like it to be in the proximal stomach.
Yeah, can you show the fluoro, please?
Dr. Puri sir, I'll just take you away from here to Dr. Gouda once.
Yeah. Can
Yeah.
you pull the NBD?
So Dr. Gouda, you are back online.
Sure, exactly where.
I think you're back on.
We're back on. So I just got the guide catheter in. We tried again quickly to see if we can get the other segment, and we are running into the same issue. We tried multiple wires. I changed it to a 35 wire, and we decided to put a plastic stent to see if this patient's LFTs would normalize before I committed him to a metal stent, as we talked about. So I chose to put a 10 French 12 centimeter. The guide catheter went in, and I think that is the key. If you're putting a 10 French stent, to make sure your guide catheter is in, and make sure that there is slow traction on the guide catheter. And I'm gently pushing the scope out and using the big wheel towards me to make sure that the stent gets in. Slowly pull me in. Slowly pull me in. Now you see how the stent is being manipulated to go in. Its key is not to push too much stent out. Then you can buckle and not get the stent in. Now I feel like we are past the stricture, and you can see the stent is going a little bit easier than when I initially started. So pull the guide cath. Now we are almost there. So yeah, so now we are going to deploy by pulling the guide catheter and the wire, and you can see that we have traversed the stricture, and we will hopefully that the bile will drain, and we'll see how he does. And those are the stones that I removed. They were pretty large stones, 2 of them. And as I said, the reason I wanted to get those stones out was otherwise this will create a nidus for infection and cause future problems. So I think we'll watch. I think the contrast is not draining readily because he's lying prone. But you can see that most of the segments are draining. So we'll take a final fluoro image and see how the drainage is.
Dr. Gupta, have you placed the 10 French DPT stent? Could you have placed the Cook 6 French delivery?
I'm sorry?
Could you have placed the 6 French delivery system biliary SAMs of the Cook?
6 French. I'm sorry, I cannot hear you well.
Delivery system, the biliary SAMs of Cook of size 8 centimeter.
So the metallic stent, the reason I did not put it in is because I wasn't sure that the segment that where we injected the contrast will completely drain the right lobe of the liver. And when I'm not sure, I think it's easier to put a plastic stent because it's cheaper. I can pull it out. I'm not committing the patient to a SEMS. Once you put a SEMS, to go back and re-intervene would be a problem. And to the extent possible, I don't like to send them for a percutaneous drainage. That's why we just put a plastic stent in.
Thank you so much, sir, for that nice presentation. I'll go back to Dr. Puri now. I think they're ready with their lamps. Dr. Puri, sir, we are back online in OT1.
Huh? Yeah, I know. It's the left side coming in. Yeah, but you need.
I think I'm not too low, so left here.
All right, that's not bad.
Yes, I think that will work. Now, just this time, go really slow. Slow. Don't push. Just pushing is minimal. Let the diathermy penetrate through.
More water. It's okay. This is the major system, right?
Yeah, I think it's okay. You're getting, the main thing is you're getting filling.
Okay,
Okay.
absolutely.
It changes every second. So you gotta at some point just say, do it. Okay. Slow.
Should I go?
Yeah. Keep your foot on that pedal. Keep filling while he goes in. And don't push too hard. Just let it slow. Yes, keep pushing slowly. Yeah, I think you're in. Push slowly. Further. Further. Go all the way down. Further. Further. Stop. When you start seeing you're pushing the bowel away, that's when you stop. Okay, lock it. Okay. And then slowly pull the distal flange back and watch. Slowly. You'll be able to see it. There it's coming. Beautiful. Now, slowly, wait till it clicks. Now with the black hub, pull back, retract, snug up. Okay, perfect. Stop. Now deploy the proximal flange.
Yes.
Good, yes. Deploy the proximal flange until it fully pulls back. Okay, stop. Now switch to the endoscopic view large. All right, now very slowly turn your body to the right and give gas, and you have to slowly pull away as you're pushing down with the black hub. Black is released, right? So push down with the black hub. Now start pushing. There it is. Push down, there it is. And you've got some methylene blue in there, right? Dye. So you see it's already blue coming.
Okay.
Yes. Beautiful, you succeeded. Excellent.
Now the another job is the most important. Yeah. Want to donate it? No, I will. Yeah, I want to dilate it. I will dilate with the upper GI scope.
There's no need to dilate. Leave it. The last thing you need is for her to have pain and some bleeding.
I'm thankful to Professor Bitmola.
I knew it'd be fine.
Just to summarize, I put a nasobiliary drain and I puncture it. The first stent was malfunction.
Yes.
That's true.
We'll find out what happened.
The
Yes.
second stent, I was not deep in.
Yes, that's
And
correct.
when I released the proximal, it opened between the small bowel and the peritoneum.
Yes.
And we reconstructed. The most important thing, I kept the wire in because the most important aspect, you should need to close the stomach rent. And that is one of the major cause of mortality in these patients.
Yes.
And over the wire, I applied the Ovesco clip.
Yes.
And once my stomach rent is closed, I did a repeat EUS-GJ.
Yes.
Now the third worry which is remaining is patient has a small bowel rent or not.
Yes, it does probably, but it's going to close. Don't worry
If
about
that rent is there, but I would like to check
Okay.
with a thin scope. Can we have pediatric scope?
Because canal was going very tightly.
But
I
at
think
least
you
show me
can
the.
safely leave it. It's going to close. It will close.
Thank
The main
you.
thing is now you've got your GJ and it's.
Can you
it's
show the
over.
upper GI scope?
Thank you so much, sir. I'll just quickly go to ESD and come back.
Upper GI scope.
So we can go to OT4. Rakesh, sir, you're back online.
Yeah, welcome back. So actually,
Dr. Gilbert in the front.
the truth is it's not such a long procedure. We have been told by Zubin and Rajesh to go slow. So that's the reason why I am on the last lap of my marathon. So I have done around seven, right? Yeah, 7 sutures. The 8th one is on. So as you see here, the last one on the anterior wall, I am finishing it. And then let me complete that. Can I have one more? Yeah, okay. Okay, so I am taking the helix out, dropping the suture, and then going to cinch. And then I'll show you the anatomy, how it was and how it looks now. You can already see on the screen, it's a narrow accordion stomach, which you can appreciate on the screen. So let me just finish the cinching and then go down into the antrum of stomach and show you how it looks. So any questions from the audience? Either you're completely off doubts or you don't have understood what's happening because a lady, when maybe
Normally, we used to have 4 to 5 sutures. In this case,
no, as I told you, there is no hard and fast number. This lady has got a very big stomach. In fact, this is my 8th suture which I am using.
Okay.
And it's important to note that one of the primary mechanism is not volume reduction. The primary mechanism is disruption of motility.
Yeah.
And so you don't see that you have to tightly close the lumen altogether.
Exactly.
Because the mechanism is more so delaying of gastric emptying.
Yeah.
Do you find reflux is a big problem in these
Not,
patients?
not at all, not at all, zero. Because we are not touching the fundus and we are away from the gastric GE junction. So I'll just show you what has been done. So this is the antrum and this is where we started the incisura. One second. Yeah, okay. So this is the suture pattern as you see here. So let me just decompress. Okay, so I'll come back to the GE junction and show you. So this is the GE junction, the Z line, and I am at 45. So I did the suturing at 47, 48. So this is the last suture. And from here, if you calculate the GE junction, it's around 7 to 8 centimeters. So that's where the procedure ends. And one important point, actually, yesterday when they were putting the balloon, they were asking what's the antiemetic you use. In fact, I would recommend, and which is a proof that there is an antiemetic which the chemotherapy they use in oncology called aprepitant. It's a capsule which if you can give it 1 or 2 hours before the procedure, it's a jelly capsule. You just squeezed on the tongue, 125 mg. It's available in India. And then 80 mg every day for the next 3 days. It's a very good antiemetic. And intra-op, we give dexamethasone 8 mg as an anti-inflammatory and anti-emetic. And after that, we'll be putting on a PPI for a month or so and sucralfate syrup. So these are the medications which we use pre-op and post-op and intra-op.
And obviously the diet progression is going to be liquids only for the first 2 weeks.
Yeah.
And then progress to pureed diet.
Exactly.
And then
so that's very important.
Solid diet.
The diet protocol is as key as the procedure is. And of course, the success of the story depends on a holistic approach where you have a nutritionist, psychologist who are constantly behind the patients, motivating them. And of course, the patient who has got the willpower and they are not real binge eaters. And my proposal, as I was talking to Saurabh, would be that we can treat patients with morbid obesity also in the future, where you have a combination of these GLP-1 analogs with one of these endobariatric procedures, which will be a game changer in the next 10 years.
A big round of applause for Dr. Rakesh for beautiful demonstration of ESG. Thank you.
Thank you. Thank you very much for supporting.
You could have done 2 by that time, right?
Yeah.
You could have done 2 ESGs in that time.
Can we change the room, please? Dr. Zubin?
Yeah, Dr. Ashar Mishra. So till we are preparing for the next case, just give us 5 minutes and we can discuss. And I can say, Doctor, any question regarding my case? Dr. Binmoller, you want to discuss your new devices? Can we discuss for 10 minutes, Dr. Binmoller, new devices?
Yes, yes.
Yeah, Dr. Puri, this is Dr. Baiju Senadipan.
Yeah, hi, Dr. Baiju.
Yeah. In this case, last case, if you do a paracentesis and if that is methylene blue stain, we can very well be sure that it is intestinal perforation there.
Yeah, so I will just tell you what happened was, the first case was the stent proximal side has not opened up. In the second, the proximal opened between the small bowel or between the peritoneum and the stomach. We reloaded it and we know that there was a rent either in the stomach is in the stomach and maybe in the jejunum. So what is most important is to close the rent of the stomach. As it is a 10 French assembly which goes, many of the time you may not be able to find. So what we did through the lamps, we put a wire into the peritoneum. Over the wire, I go with the Ovesco clip and I applied the Ovesco clip to ensure that the stomach rent should be closed. Now I close the stomach rent and I again put the nasobiliary drain and I did the EUS-guided GJ in this patient. Now the last part which is remaining is this peritoneal cavity has fluid and may have a rent in the small bowel. To close the rent in the small bowel, either you take a upper GI or pediatric colonoscope into the bowel and apply the clip, but as there's a gastric outlet obstruction, I cannot take my scope. So the plan is to give antibiotics, to put a drain percutaneously and wash the patient. There's a 70 to 80% chance that this patient should be all right. We will not give anything by mouth for 3 days. And I think after 3 days, I might take the upper GI scope through the GJ stent and try to see that is it possible to close the rent if there, otherwise patient might require surgery. But at this time, the salvage was either I should put the patient directly on the surgery, that would have been a more morbid procedure. She is around 80-year-old female. So what I did is stomach rent is closed, I did the GJ. The only point remain is a small bowel rent. Either it is going to close of its own, or this patient might require a surgical intervention.
Most likely,
Rajesh,
will close on its own.
Rajesh,
Yes.
This is TSC.
Yes, sir.
I must congratulate you. You remain very cool despite some mishap. That's how you, I think that's a message to the youngsters here. My question is, suppose you were not able to perform the third time, what would have been your take? Should we immediately go for laparotomy and do that, or you are able to do it because you are an expert? Suppose you are not able to do that. And second question is, what is the reaction of methylene blue in the peritoneal cavity? And these are all patients of malignancy, old age, and you have to be very, very careful in doing the procedure as you said. But if you are not able to do it in the third time, and what one should have done such patients? Even during laparotomy, I was told by the surgeon, very difficult to find out the jejunal opening to close it. And I don't know whether it will be gastroscope or pediatric colonoscope.
Is not going through the gastric outlet, and I agree. I don't know the viewpoint of Professor Binmoller. If I was not able to do the GJ, then I would have subjected this patient for a surgical intervention as early as possible before the peritonitis set in.
Well,
and you can very well do a laparoscopy in this and do a GJ then.
So I think that is a call of a surgeon.
So I think your options, if you close the hole to the stomach, that is the only danger. You need to close the hole. So that's why you need to get a guide wire into the peritoneal cavity so that you know exactly where the hole is, because it can be very difficult to identify the hole. It persists, but it may be hard to see. So having a guide wire so that you know exactly where the hole is, that's critical. Once you have closed the hole, you can take a deep breath and you don't need to do anything. One option would have been just to monitor this patient and bring her back for a second attempt at the GE, gastroenterostomy, at a later time. But because that hole in the small bowel, it will close on its own. So this is, there are the different types of maladeployments. And this is the type 3, but it's a type 3A. There's two types, the type 3A and type 3B. And the type 3A is the one where you have just a hole, but you pulled out the lambs. The only type that you have to send to surgery to the laparoscopic surgeon is the type 3B. That's where the lambs is in the small bowel, the distal flange, and the proximal flange is in the peritoneum. Well, then everything is spilling out of the small bowel and the hole can't close. All right. That's the only time you need to call the surgeon. So don't
don't think about surgery or any of this unless it's really needed.
To summarize,
Yeah.
if you have taken out the lambs out, and if the lambs is out, then there is a possibility you may be able to tackle with endoscopy and the conservative management. And if the lambs is in the small intestine and the peritoneum, then you are not left with the type 3 and patient has to go for a laparotomy immediately.
Yes.
But in this case also, we should be very much careful. If we signs a signs of peritonism, we should subject for a surgery a little early rather than
Yes and
keeping.
no. I would say first call the interventional radiologist. And there's a fluid collection in there, right? So there was obviously some leak that occurred, but it's sterile water. I don't know the answer to the methylene blue, but I don't think that, there's an issue with methylene blue. I suspect surgeons wash out with methylene blue. Remember the peritoneal cavity, when laparoscopic surgeons operate, they're irrigating with fluid in the peritoneal cavity. So there's nothing inherently bad about fluid in the peritoneal cavity, but if it gets infected, then it's an issue. So this patient stays on antibiotics and, I think the patient would do just fine. I wouldn't do anything unless the patient spikes the temperature and is showing signs of peritonitis. Then I would drain this percutaneously next.
Professor, could be apprehension. I would like to put the drain now.
You want to put?
One question is that after you punctured the jejunal loop, is it better to push in the wire and then deploy the stent, or the way we did?
No, it's always be out. Where was the mistake? I will tell you. If you push a wire, the loop is going to push along with the wire, and the distance between the jejunal loop and your stomach will increase. The best part is your puncture should be gentle because the cautery is going to puncture rather than your force of the hand.
Correct.
And I think that my feeling was I was inside, but I was not, because I have made the thrust, and thrust made two things: puncture into the bowel as well as pushing the bowel away.
That's correct.
And when I release it, it has released into the peritoneum rather than the small bowel.
Right. Even though you pushed all the way down, you were pushing the small bowel away from the stomach wall. And that's the reason why the distal flange ended up deploying between the small bowel and the stomach wall. And then for a little bit of time, it was still a little bit inside, but I think then it slipped out.
So, sir, thank you so much for that discussion on possibilities of complications of LAMS. So we will just move on to our last case. This is a 79-year-old male, a known hypertensive who has a ulceroproliferative growth in the rectum, and the plan is for a colonic SEMS. So we move on to the room OT3 for colonic SEMS. Sir, you are live.
And characterize the. It's a BLI. Is that 4? 2. This one. Yeah. That's LCR. Again, you press it again, and it'll go to BLI. There we go. And so now on the bottom right screen.
Sir, you are live in OT3. Dr. Vipul, sir, you are live.
I think we're live now.
Hang on. Okay, now, just come back and put the, and BLI, CAD's off now. Turn the CAD back on.
I think we're on air now. Are we on air? Yeah? All right. Can you hear us in the audience?
So you are live?
Yes, you are audible, sir.
All right, great. So I want to thank Rajesh and the organizing team for getting us to do this case. So we're going to be doing a colonic stent, and I've got Dr. Saurabh Gupta next to me. So I believe this is a adenocarcinoma of the sigmoid colon. I was told on a PET CT this is about 11 centimeters, and I suppose just before we start, in terms of indications for a colonic stent, I personally would not do it for any benign condition. Saurabh, you want to make any comments on that?
Yeah, so I think we heard the talk earlier on about enteral stenting, and the colonic indications are obviously in the palliative setting, also as a bridge to surgery in the acutely obstructed patients. They're probably the two big indications for the colonic stenting. And I understand in this case it's an inoperable long tumor
Correct.
Therefore, we're going to do it for palliation in this case.
I think ideally I would have liked to see more definitive images. I saw a PET CT which showed this maybe 11 centimeter, which sounds really long. And I think the other important criteria is how low it is. So this seems to be about 10 or 15 centimeters away from the anal verge, which is pretty good because you don't want it to be deploying your stent too close and preferentially not across any flexures such as a splenic flexure or anything else. So hopefully this will be much more straight, sort of more in the sigmoid colon.
So the risk obviously of colonic stenting will increase with the length of the stricture because, and in fact, we don't have stents that are in Australia that are long enough generally to account for this. If it's 11 centimeters, you'd want at least a couple of centimeters on either side, or at least 1.5 centimeters on either side of the stricture to allow the flanges to open properly.
Yeah.
And so, yeah,
I think we'll have to, and we'll assess that length once we do that. I usually like to use either a balloon, occlusion balloon, or a sphincter term to then inject some contrast once I've got a wire through to assess the length of the stricture. So
we're using the Fujifilm scope here, and it's got the ability with the cat eye to both sort of detect lesions and characterize lesions, but in this case, we're not going to. It's been assessed and biopsied. It's clearly an adenocarcinoma, and obviously the longer you the longer the procedure takes with a colonic stent, the increased risk of insufflating the more proximal colon and therefore risk of complications. So obviously for any enteral stenting, for any therapeutic endoscopy, we use the CO2 insufflator. We don't use any air insufflation anymore. And we try to make the procedure a quicker procedure to minimize the risk of complications in the right colon.
And I'm using a colonoscope here. Sometimes I'll actually use a therapeutic gastroscope. I think particularly for the lower stricture, it keeps the scope, I think, a bit more stable. I've got another scope outside the rectum, which sometimes can make it a little bit challenging in terms of, holding the scope position when we're trying to put the wires through or put the stents through. Any questions from the panel or the audience?
So there's different types of stents available, and we'll talk more about that when we get the access. But generally, the steps are wire access. We need the fluoroscopy in position. Can we get the X-ray into position?
Will you do the wire for me? Just hang on a second. Let me center it a bit.
Fluoroscopy here.
Can we get the fluoro in position? Okay. Now try the wire. Going through?
That looks like the wire's gone nicely through, but if you can traverse the stricture,
close the door and get some fluoro.
Then we don't need
all right.
fluorinated.
So I'm told the machine's a bit hot right now, so we can't get fluoro.
We can't place
I can't place a stent without fluoroscopy. So they'll have to figure out
what position of the patient you take, supine?
So left lateral?
Left lateral or supine?
Lateral. No, not supine. I think placing stent supine is always harder. I find that just manipulating the scope and the stents and everything else, they're much easier to do in the left lateral position, standard colonoscopy position.
Do you find the supine position better for distal lesions like close to the rectum? For better visualization in the fluoro?
Okay, we're just trying to sort out the fluoroscopy. Just give us a second. Sorry, what was the question again?
If you have a distal lesion close to the anal verge, would you prefer a supine position to visualize it?
Yeah,
better?
I think if it's closer to the anal verge, it's different. But I think anything that's above 5 or 6 centimeters above the anal verge, I prefer the left lateral standard colonoscopy position. It's interesting. I've actually got which is interesting. I was told that they couldn't get the scope through, but I've gently manipulated the scope past the actual stricture. Yeah, so I'm actually through.
Yeah.
So we probably don't need fluoroscopy now because I'm actually past and through the stricture. So, because I'm told the fluoroscopy machine has heated up and it's going to take about 30 minutes for the fluoroscopy machine to come back on track. But because I've managed to get past the stricture, I think I can deploy this, I think under endoscopic visualization. What do you think, Saurabh?
So this is the ideal situation. If you can get through the stricture, then you know, you don't
Professor, there is no stricture. If you place a stent, can migrate, no?
There is a stricture. It was still a fairly tight stricture. It was gentle manipulation across it. But I take your point. I think the stricture should be tight enough for the stent to stay. But
it is negotiable now. You can pass the endoscope. Suppose you deploy a stent, it can get migrated.
And in this case, the migration will be 100%.
Yeah.
Spontaneous expulsion will be there.
Maybe we can wait and watch for some more time. I know the patient is moribund.
It's a good point. I think it's a fair point. You make a fair point.
Because you are able to pass across the growth.
I agree. I agree with what you're saying.
Also,
in my usual clinical practice, my general rule of thumb, whether I'm putting any luminal stent, whether I'm putting an esophageal stent or a colonic stent, if I can get my scope through, I would think very hard and long before deploying a stent for that exactly the same reason. And clinically, it's probably not going to, that means they're not fully obstructed. If I can get my, this is a standard colonoscope. If I can get that through, that means they're not fully obstructed. So I think that's a fair point.
Look at the
stricture again. Well, let's reassess that.
I think the best thing to do is reassess.
So while we figure out the fluoro and the stricture, just quickly go on to one more case since we have around 10 minutes. So this one is a periampullary malignancy, and the plan is to do an ERCP and place a biliary SEMS. We go to OT1. Mohan, sir, you are live.
Good evening.
Good evening, Dr. Mohan. You are on, sir.
Yeah, so let's start. The patient is being sedated, and we have a 76-year-old male, CA pancreas, inoperable. Plan is to do palliation, and we'll see there is already a plastic stent. So I'm using TJF Q190 scope, and as you can see, you must have seen, for the beginners, I will say that this is the way I do side wing endoscopy, where as soon as I enter the G junction, I make my palm up position. You can see my palm is up position, and then I insert the scope towards the ampulla, towards the gastric antrum, and then I keep pushing and straightening my scope till I reach to the pylorus there. And then once you are in D1, you just rotate your body and a small knob to the right, keep pushing. And then you withdraw the scope and you will be, and you can see there is already a plastic stent there. It's a 10 French stent. So idea is to grab it by the snare so that it aligns well with the therapeutic scope as compared to the red tooth forceps. And I will put Bhagwan will open the snare. And we catch it and we'll bring it out through the channel. I think it's quite a stiff since it is longly placed, so I'll not damage the channels of the scope. I'll bring whole scope out in a minute. And then we are ready to go again.
Dr. Mohan, we want to focus on your hands, the maneuver which you want to show.
Okay.
So your hand picture could be a bigger one.
You can see my hand. I'm using this big knob down so that I convert the side wing endoscopy into a forward viewing endoscopy. You can see, I can see the esophageal lumen. I'm not completely blind.
Perfect.
As soon as I reach to the G junction, I make palm up position. You can see palm up position. Perfect. It opens the stomach into transverse fashion. On the right side is the antrum, and on the left side, as a beginner, we keep on going into the left side to the fundus. But as you see, it opens up, and then I push, and simultaneously my hand is up. Push, hand up, push, hand up, and then you will reach to the antrum onto the right side.
Perfect.
You can see this is the gastric antrum, and that is the pylorus sunset sign. You push and do slightly down, and body turned right, and small knob turns right, and then you can pull it here.
Oh, yeah.
So this is infiltrative lesion, may require further antral stent versus GJ, but our job is to do biliary stent today. So I know where the stent was. I pull back and see here, and Bhagwan will help me in inserting the wire. You can see the wire straight away went in.
Fluoro picture.
Yeah, inject please. So he's injecting and I'm withdrawing, and you can see the stricture is it's very small stricture. You can see only a very small stricture down.
You want bigger fluoro picture?
Can you see the fluoro picture big, please? Yeah. Can you inject? Yeah, inject please, thoda sa. You can see I'm at the stricture now.
Very small stricture, distance.
A very small stricture. Yeah, we will change the longer vial. We use Teremo. And I keep my body slightly turned to the right torque. You can see my wrist. Wrist is slightly right. That helps me not to slip.
Yes.
Okay. Slightly right. And then once the wire is deep inside, I pull back with 1-to-1. I use elevator to lock and pull like this. Once your elevator is locking mechanism is there, your wire is secured, and you can do quick exchange. So we are using a very shortest possible stent. This is 76-year-old male with inoperable tumor. Palliation is required. So we are using uncovered stent made in India from Java company. Yeah, so it's from Medora. Good. Okay. And now I will push. We are seeing the both fluoro and endoscopy picture, and the stent goes in. I move the big knob away so that I have a good knowledge about the lower CBD, lower end of the stent, sorry.
Can we have the endo picture, please?
Now you see the yellow mark there, and I will keep the yellow mark within the slightly in the scope so that I have a good margin. Now Bhagwan will deploy. And I keep pulling, just yellow mark to be. Yes, please go ahead. I have to slowly. Yes, slow. Please go ahead. Please go ahead. Yes. So I'm keeping a traction so that the yellow mark is in my visibility, and Bhagwan is deploying. And you can see now nicely deployed. I suck out all the fluid, contrast, so that I make sure that there is no cholangitis. So it's an easy, quick procedure.
Perfect, Dr. Mohan. Very well demonstration of the biliary stenting. Thank you.
Yeah.
Thank you so much, sir. We'll quickly just go to the colonic case and we see what has been the final decision on the assessment of the stricture.
Yeah.
So OT3, Dr. Vipul, sir, we are back with you and you can discuss.
Yeah, hi.
your plan.
All right. So welcome back. And during this time, while the fluoro machine was cooling off, we've had a bit more time to think about this, and we've assessed the stricture. It's about 5 centimeters long. And a standard colonoscope, I didn't have too much trouble getting past it. So at this point, he's not critically obstructed. So I think it would be fair to say that he doesn't need a stent right now. He probably will end up with a stent, depending on what treatment he's going to get for this, whether he's going to be getting, any form of chemotherapy and what that's going to be doing to his stricture. But I think it would be reasonable not to place a colonic stent today, because it's actually relatively open right now. So would you agree and say what?
Well, look, yeah, like we said, the indications are for an acute obstruction or bridge to surgery. So I think he's got neither here.
Yeah.
So I think you obviously risk of migration is high, the risk of bleeding from the stent into the tumor is high. So there's more to be lost than gained by putting a stent in here, I think.
All right. So I think that's a good demonstration of when not to do a thing, even if you're in a live endoscopy course where you expect it to do this stuff. So I think in the interest of the patient and everything else, we're going to pull out and not put in a colonic stent today. All right. So thank you.
Thank you, Dr. Vipul.
Thank you.
Thank you.
Happy for me to come out?
Yeah.
Was this patient given any preparation for colonoscopy?
Dr. Rajesh, your own.
So patient was not given any preparation for colonoscopy. A CT scan shows around 8 to 10 centimeter long stricture. Patient came in obstipation, and he came 3 days before, and the plan was to do a stenting in the conference. So we have not done any colonic preparation. I was not there, but what I have heard, there was a fecal impaction, and that was a cause of his obstruction rather than a tumor ingrowth which lead to the obstruction. Otherwise, we would not have kept that case because patient was in obstruction. So with this, I think we will finish the live case from endoscopy suite, and we can start the lectures there. Thank you. Thank you.
Thank you, Dr. Rajesh. Thank you, please.
Thank you.
I thank the chairpersons and moderators. We will now move on to our next session titled Road Less Travel, the panel discussion on advanced endoscopic training in India, the launch of SGI flagship SITAR program. I invite the panelists on stage, Dr. Prateek Sharma, Dr. Usha Datta, Dr. T.S. Chandrasekhar, Dr. Matthew Philip, Dr. Nitin Jagtap, Dr. Radhika Chavan, Dr. Gaurav Chawla, and Dr. Jamil Shah. To moderate the session, I call upon Dr. Mahesh Goyal.
Good evening, everybody. While the extreme panelists are settling down, let me start the discussion. Let me first thank Dr. Rajesh Puri and the team of Endocon 2024 for leaving almost 1 hour for discussing this very important but usually not discussed topic, which is road less traveled advanced endoscopy training in India. So we have, as you can see, I can see 6 of them. Actually, there are supposed to be 8 of them. So I think some people are missing. Dr. Usha Datta, she was here, and Radhika Chauhan. So we have, as you can see, 8 panelists. They've been very carefully chosen by Rajesh. Some of them are young, budding, if I can use that word, endoscopists and gastroenterologists, and some of them are not so young. So the idea is basically to look at what are the expectations for the advanced endoscopic training and what is the reality. Let me at the outset tell you that Rajesh has told me that let this be a very open discussion, no diplomacy. Let's look at the hard facts and let's be harsh if need be on what is the present scenario and what we expect in the next 1 year or so. So this is my panel. as you can see, we have representation from USA, Dr. Prateek Sharma, who is the President-elect of ASGE, Dr. T.S. Chandrasekhar, Dr. Usha Datta, Dr. Matthew Philip, who is the Secretary General of Indian Society of Gastroenterology, Dr. Nitin Jagtap, Dr. Chawla, Dr. Jimil Shah, Dr. Radhika Chauhan, and subsequently we'll be joined by Dr. Rajesh Puri, who is the Secretary General. And as I said, I want all of you to join. We have plenty of time to discuss this issue. And I'm surprised that we are starting actually 5 minutes earlier than we were supposed to be. So I think, let me tell you that we all know that India have great institutes, both on the government sector as well as corporate sectors. We have world-renowned endoscopists, and we have passionate leadership. So what's the missing link? I think we have not been able to amalgamate the three to result in a very robust advanced endoscopy training. So the agenda for this next 1 hour is to talk about unmet needs, what's the present scenario both in India and what we can learn from international scenario, what are the present hurdles when we talk about advanced endoscopy training, what's the way forward, where do we look at the role to be played by the society, and once a society is Society of GI Endoscopy of India, what can be the role for various medical boards, NMC, DNB board, and what should be the tools and techniques for advanced endoscopy training. Let me start with the first question to Dr. Nitin Jagtap. And this is what I thought were the unmet needs. When we have a fellow who is doing his 3 years course, either as DM or DRNB, super specialty in gastroenterology, I usually find that they are not trained in some of these modalities, which includes ERCP, cholangioscopy, EUS, diagnostic and therapeutic, third space endoscopy, resections, advanced imaging, bariatric and metabolic endoscopy, and they are not usually trained to do a structured research and publication in the field of endoscopy. Nitin, do you agree with this, or you have some difference of opinion, or you think that this is the real scenario?
So as of now, I believe in throughout the country, there is no training for all these procedure during DM or DNB course. And when I was doing, I also didn't get ERCP or any advanced procedure during that period. I believe there is a need.
So is there anybody from the hall who has a different opinion? Please feel free. We have enough time and don't feel shy to blame us for whatever the scenario is today. So do you all agree that during the usual fellowship program, these 5 or 6 modalities are not being trained in a structured way? Coming to a conference like this, watching a few procedures is not the end of it. We need to have structured training, and this is what I thought was a list for us to go on looking for the future. Any other comment from anybody else? Matthew?
It's not being trained, but that 3 years is the appropriate time to train all these advanced procedure, having a significant chances of adverse events. That's the question. Should we start training at that 3 years of course is the question.
Nitin, it's a wonderful thing that you have told, and Mahesh, it's very good that you brought in. I feel that training in endoscopy in India, there are 2-3 problems. One is that there is a difference between institutes, and for gastroenterology in total, difference between, there is no uniformity. That is one thing which we lack. Second is, we should, now that time has changed, what training was given 25-30 years when I was doing DM, same training is happening now. It has changed. So in my unit, I have changed training 3rd years for ERCP and EUS. I think that much I can do, but ERCP and EUS, but the other things I don't think it is easy to be trained in the fellowship. You should have 1 more year additional fellowship.
Gaurav, let's not be repetitive. If you have something more to say, most welcome.
I want to highlight.
We should not aim at getting trained in all the procedure in first 3 years. The first 3 years dedicated for learning basic skills and the clinical training, and you have exposed to the luminal and liver and so many things. So this time is insufficient. After that, one need not try to learn every procedure under the sun in gastroenterology. They can choose the area of interest. So accordingly, and you want to train everybody in third space and advanced imaging, EUS, the time is not there. So I think we need to understand the concept of what best training, what he wants to learn.
Okay, Gaurav, let's be very brief.
It's the same thing what Dr. Chandrasekhar was just emphasizing, that he should be, candidate should be clear what he wants. If he wants to go to hepatology, then he doesn't need training in all this. So he should be clear it in mind that he.
What you're trying to tell me is that you don't want the training of these things to be given in the 3 years course which we are running for the DNB or DM. Dr. Usha Datta?
Yeah, I would say here we have to look at it from the patient's perspective. When a patient comes in with a cholangitis to a gastroenterologist, he should be able to put a biliary stent, and that is what is the minimum expectation. All the other things can be referred to other places. So we should see what does a person need to do in an emergency setting and should be able to then pass on for more complex procedures.
So what, if I got you right, you want that ERCP should be trained during the usual course and the rest can be left for later on. Okay, yes. Let's move on from there. No other comments? Now, what is the present status? And I divided them into structural training and a non-structural training. We are sitting in a place which I will call it a non-structural training. But what is the status of the structural training? This is what I could get from the net and talking to some of the colleagues. I may be wrong, it may not be complete list, but this is what it appeared to be, that we have only about 8 centers. We have some semblance of structural training going on in advanced endoscopy. CMC Vellore possibly started in 2008, 1 seat. VGM Hospital Coimbatore have 2 seats under MGR University. Med India Hospital, Dr. T.S. Chandrasekhar, 2 seats again under MGR. Until 21, 6 people were trained as per the net. AIMS Delhi have 1 year, 1 seat. Amrita Kochi, 2 seats, 1 year. SGPGI Lucknow, I've been told there are no takers for the last few years. There's only 1 seat. BITS Mumbai was started by Amit, 2 seats. And there is a center in Sangli called PIOG, which again is under MUHS, and I don't know the status. So if you look at, we train about 600 doctors as DRNB or DM per year. And we have only about 10 or 12 seats for advanced training. So it's a very, very poor situation. And the last center which I talked about, the entry point is DNB, MD or MS in medicine and surgery rather than DM or DRNB, while the rest of the centers are only taking those who have completed DM or DRNB. Now, this is very, very surprising, and I wanted to show this to T.S. Chandrasekhar, who is sitting here, that I looked at Tamil Nadu MGR Medical University Advanced Fellowship course, and I have outlined with red what is expected during that advanced course. 25 ERCPs, out of which 5 stent placement, 25 esophageal dilatation, 5 esophageal stenting, 10 varicose ligation, polypectomy 10, ERCP metal stenting 1, pancreatic endotherapy 1, EUS-FNA 1, achillea dilatation 1. That's what we are planning to train them in the advanced endoscopy training. Where are we? This course must have been made 10 years back and nobody has bothered to upgrade it. This is I've downloaded from the MGR University yesterday.
Yeah, I will tell you about that. In the whole country, 2011, I found a necessity for giving advanced training in endoscopy. There was necessity. So I have the adjunct professor that time, the MGR Medical University. So I formulated that time and we said those who have already done 3 years course, they will come for ERCP training. When we formulated in 2011, we didn't have much of bariatric and other things. Now we have revised it also, number of procedures we have increased. But the problem here is you have to stay for 1 year and the selection is done by the institute and the exit exam is there, that will be done by the university and there is a certificate given by the university. It's a very good.
They're all good, TSC, but do you think that you should have looked at this curriculum?
Yeah, we have already
upgraded it because this is still, now my point is, TSC, let me be blunt here, that if somebody looks at this curriculum, I am not attracted towards this curriculum at all.
Yeah,
if you're going to allow me 1 metal stenting in 1 year of course under supervision, I don't want to join that course.
No, the thing it was done in 2011, we have reframed it. The number of procedures have increased and we have included EUS also in that 1 year course. But the problem here is students want to come for 1 month and 2 months. I don't want to do that.
So I think you need to look at this. This is as it stands today. So we need to upgrade it if we really want to attract people. Any comments from anybody?
Can I make a quick comment on that? See, this is what I told you initially. There is no updating of what is created in the care. Even in DMDNB, same thing. And something is happening now.
So, yes, Radhika?
Sir, I already discussed that ASG have their competency benchmark program, is how many USA they have to do luminal, pancreatobiliary, and even FNA. They have given this should be the number, should be performed by a candidate. So that program we can incorporate in our.
We'll talk about what we can do. Let's first look at where we are. So where we are is that there's other ways to look at the, yes, Prateek.
So, Mahesh, I don't know if you can go back to your first slide, which talked about the different things. Yeah, right here. So, my question is that, is there an expectation either on part of the patients or the institution that everybody needs to be doing everything? Because the reason I say that is, it's a little bit of a different system in the US where referral actually happens. What I see here is referral doesn't happen. People want to do everything all the time, whether it is ERCP, EUS, bariatrics. There is really no super specialization amongst that. That you want to be able to do as a one-stop shop, that if a patient comes, you should be able to offer everything right there. So I think that is part of the mindset. And when you're talking about being blunt, so I'm just talking about it.
So I think you raised a very important point, and I have a discussion on that subsequently, that even when we train someone for advanced endoscopy training, we want that all 6 aspects should be trained. So we'll come back to that. But at this moment, where do we stand? And we stand in a very wet situation, very bad situation. Dr. Usha Datta, you have been doing some unstructured program, and E-Pathshala is one of them, where you try to train people about endoscopy training. But if I look at the unstructured training which is going on, is endoscopics initiated 1 or 2 days program. I don't want to label them. There are various programs which are done regional, national level program, but they're really not structured. There are 1 or 2 day program. People come, see live transmissions. Sometimes they go back and they start doing the procedure. I don't think that's the way forward. We have Endocon program like this. We have occasional international meeting like APDW, TTT, which we did recently. We have AUS group and Indian EUS meetings which are happening, and of course E-Pathshala, which we talked about. We have hands-on training, good things to have. We have lectures and live transmission, and we'll come back to the issue of live transmission a little later. Dr. Usha Datta, do you think that this is the way forward? I mean, do you think that this is a fallacious way of training people?
Actually, 10 years back, I realized that the training system is not structured in PGI. We made changes. First change we made was to ensure that we saw that our residents were going out and getting training in ERCP. So we have now changed the system. Now all our residents who leave PGI know how to do ERCP and stenting and stone removal with sphincterotomy.
This you are talking of 3 years course, or if they stay back?
No, this is during the 3 years. It is our mandate to ensure that they are trained in diagnostic upper GI, diagnostic lower GI, with therapeutic upper GI and lower GI, the basic ones, not EMR and ESDs. But the basic polypectomies and GI bleeds and all they can manage. The second thing is we have introduced a GI mentor. So that is one of the virtual programs in which residents can train themselves before they come onto the patient. So that has improved their colonoscopy rates. And by the third thing that we have done is in the first 6 months, they have to do upper GI and sigmoid. In the next 6 months, it is colon. And in the next 6 months, therapeutics. So slowly, all these are introduced, and by the end of 3 years, they are competent in these components.
Is there anybody from PGI Chandigarh who has passed recently and is not afraid of Dr. Usha Datta? Anybody who can come up and talk about their training? Anybody from PGI Chandigarh who has left PGI? They are still afraid of you.
No. Jimmy is right here.
Mahesh, the fear continues. The fear continues.
Dr. Rohit.
That's what I was saying, that even if it's there in PGI Chandigarh, that's good, but say 9 out of 10 or 95% of 100, no training is given for ERCP or even in diagnostic EUS. Forget about other things.
So do you think it should be given, or do you think we should train only the basic procedures during the 3 years course and the advanced training should be done later on.
At least ERCP, you should be good, and EUS diagnostic, maybe a few FNAs. That should be good enough. Then after that, he can learn and go into a sub-speciality which he wants to.
Naresh.
Sorry, I'm going a little away from this because I may forget what I have to say. Now, the question is that we said you found out some curriculum, X, Y, Z number of things. But I think at the end of the day, if you're giving them advanced endoscopy training, they should be credentialed to perform that when they leave and go. So if you're going to say that ERCP, at the end of it, he should have done, and we have standards that are in the West, in the European societies have, we should have some standard and say, okay, at the end of that 1 year, I have trained him in ERCP, he should be able to perform it independently when he leaves his institute. There's no point in saying he has observed 5, done 1 under supervision, because that is inadequate.
So you think that the credentialing should be internal or it should be external? If Usha Datta is training her student, she should she credential her, or should the credentialing be external?
No, it can be internal. It can be internal as well, because we can't expect external credentialing all the time. It can be internal, logbook based, that much amount, and if she says at the end of it that I will allow you to do a procedure when Rakesh is not there, or one of your other consultants is not there independently, fair enough. I think that's good enough.
Dr. Lakhatia.
I think during the DMD program, it's the exposure which is more important for all these advanced procedures. They're also doing hepatology, IBD, IBS,
Yes,
I think too much to be done. I think endoscopic advanced procedures should be a dedicated 1 year afterwards, depending on their skill set and their interest.
So, do you agree with the rest of the people that at least the basic ERCP should be trained during the 3 years course, and we leave the rest of it for the later on?
I think so. In basic ERCP,
Okay.
some of the people actually remove stents, do a side wing endoscopy, focusing the papilla. That can be done at that time.
So the next question is to our incoming ASG president. What is the US's status? I've been told that at least 70 centers who are doing advanced endoscopy training. How is the intake taking place? What is the training program? How's the output? And what's the net result? And what are the prospects?
So right now, again, ERCP, so Usha, it's not part of the 3-year program. So the 3 years of fellowship are on basic upper GI and lower GI, but it includes both diagnostic and therapeutic. Some of the centers will allow some ERCPs, but the majority of the people don't get credentialed for ERCPs at that time. As Sandeep mentioned, maybe it's just how to pass the side viewer. EUS probably most of the times never happens. So after that, you can apply for an advanced year. And the advanced year is quite focused. It is either ERCP/EUS, or it is bariatrics, or it is third space. So it's not all of the above. So it's very specific training programs, have specific areas of expertise that they offer all those things. And that happens through a matching program, and the match is run by the ASGE, in which the different institutions will inform the ASG how many seats they have and what kind of training they will offer during that 1 year of advanced training, whether it's ERCP or third space or bariatrics, etc. And during their time period, there is a structured curriculum which happens. Of course, there is no pass or fail. We are trying to introduce competency-based assessment rather than just going by a number of procedures, because we know that somebody can do 10 colonoscopies and can be very competent at this, and somebody can be doing 1,000 and still not be competent at it. So we have to introduce competency-based assessment. And then in the exit, it's all dependent as to how the 1 year has gone. In terms of prospects, at least in the US, what happens is that just finding pure jobs in which you are doing only advanced are gradually decreasing. So most of the fellows who graduate after the advanced years still end up doing quite a bit of general GI along with the advanced that they're doing. But the advanced they do is very specific in that area. So you probably won't have a person who's doing everything on that list that you showed. There probably may be 2 or 3 people in the country.
So before Vikram asks his question, 2 clarification. So how many subspecialties for advanced are there? You talked about bariatric, you talked about ERCP, EUS. So like there are 2, 3, 4 sub-branches, number one, and number two, we are aware that for a pancreas fellowship, an Indian can go and do it without going through the fellowship program. Is there any scope for an Indian doing an advanced endoscopy fellowship in USA?
No, so the short answer is no, that it can't happen. In fact, it is the other way around, that many people from the US are coming to India to do the advanced fellowship. So I think that's the reason it will be good that you have a structure here, so that even if you want to accept somebody from the US or from anywhere outside of India, that there are certain set criteria. Should not be based on, I know Mahesh, so I can go to Kolkata, right? It should be based on very specific criteria. You should have some entry criteria in there so that it's a win-win situation. You can get the best candidate, and then the best candidate can get the best job here, which is possible. So that's how it is.
Second part of my question was that one is EUS ERCP. What are the other?
EUS ERCP, bariatrics, third space. And many centers also offer resection, which means mainly EMR, very few ESDs as part of the ERCP EUS.
I know of at least 2 people who have come from USA after doing advanced fellowship course. I can see Sunmun Mahapatra sitting here, and I know Saurabh Mukewar. I don't know whether he's in the hall or not. So we like to hear from them their experience, but before that, Vikram.
So most on the dais and down below agree that during 3 years beyond rudimentary ERCP exposure.
What is rudimentary?
As Dr. Usha Datta said, at least focusing the papilla, exchanging stent, and draining a obstructed biliary tree which is infected. So basic ERCPs. Others would be unrealistic possibly with the course requirements. The problem is that beyond 3 years, once the resident or fellow has passed, there is no 4th year avenue for the vast majority. You just displayed it on your slides. It was hardly 5 or 6 posts. And so many DNBs are coming out. So the students all aspire to learn or to do more, but we are failing because these avenues for the 4th year are just not there. And that's the discrepancy.
Sunmun, you want to add something? Your experience?
Sure. So I did 3 years of GI fellowship in US, and then after that 1 year of advanced endoscopy fellowship, specifically EUS-RFA. And then because I had interest in third space, I did another year of ESD. And
so you did 2 years?
Yes, I did 2 years in total of advanced fellowship. So my experience is I do not think that 1 year of EUS-RFA training in that year, it's enough to learn third space as well. So additional 1 year, I think, makes more sense for if you are interested in third space. But if you are just interested in third space, not EUS-RFA, you can enter directly. I mean that the EUS-RFA is not necessary for you to learn before entering to the third space.
So if I can ask you more pointed question, and I looked at the net also for this, that how many ERCP EUS a candidate would have done during that 1 year course? Either supervised or unsupervised?
Okay, so in my experience, I did around 450 ERCPs in my advanced year, like my 4th year fellowship, not my 5th year. And then around 300 EUS, including both diagnostic and therapeutic. And because I was in the same program for the ESD fellowship, I had the opportunity to do ERCP EUS as well during that time.
Any comments from
Mahesh?
the house? Yes.
450 will be a very high number. You think you independently did 450
No.
ERCP?
No.
So you have to be very specific.
Yeah.
First 3 months you will observe, because my
So
son,
let's hear from her. Actually, how many out of this 450 would be you saw it? How many you were supervised?
Yes.
And how many you actually did?
So again, ERCP is different from other procedures. So specifically for ERCP, so the first day I entered, I was given hands-on, but not for cannulation, but just for balloon extraction, stent removal, and focusing the papilla. So that was for a month or so. So I would say first 6 months, I was supervised. My last 6 months, I was independent. And for the first 6 months, probably I was like somewhere 180 ERCPs. And after that, I was able to do all by myself most of the time.
If I'm allowed to quote here, my son did the fellowship course with Dr. Pratik. After that, he went for the Mayo Clinic for the advanced GA fellowship. He chose the ERCP EUS, and from what he has told me, first 6 months he was thoroughly asked to observe and supervise under supervision, and last 6 months he was carrying out of the 150 ERCP. That I know that.
So
very
the
well.
only issue is that the number has to run. See, we talked about competency, but number is related to competency. You can't be competent without doing the procedures. So I think it has to be in hundreds, not in double digit or not in single digits. So that's what I wanted to say, that if you're really running an advanced endoscopy course, you have to have the volume along with supervised
Mahesh, number matters. Even for a poem, initially they said 20, now 40. Now for advanced, I mean, the master has to, I mean, for competent, they are telling now 100 cases would have done it. You just imagine how many centers
you
will have
want to
100
add,
cases.
Jimmy, you want to add something?
I want to ask one question. So during your 4th year and 5th year, do you used to see outpatients, inpatients, patient follow-ups?
No.
Okay.
It's
She
only
doesn't see now
procedures.
also, that's the problem. Jimmy, you want to add something?
Sir, in ERCP also, when we see number,
Use the mic.
it has to be more homogeneous when we count the numbers. Let's say out of 450, how many papillas were naive, what level?
Yeah, I agree with you that it must be a
very
mixed
good
bag.
question.
Because heterogeneous data will not be suffice.
Yeah.
Second thing, whenever we are starting, or let's say if we are starting a different kind of a fellowship program in India, what we need is a good data recording. So ESG is now developing the quality improving apps where you can lively feed the data of one patient, and you can check that out of how many patients, let's say in a 1 year, what is your competency rate and what is your
I think
and all
was
the
a proper
competency
logbook maintained? What's
Yes.
that?
Yes, the proper logbook was maintained from the beginning, and I still have the numbers. And I was being evaluated every 3 months regarding my progress. For ERCP, it was the percentage of native papilla I just cannulated by myself and successful. So initially, I was in my 70% in my first 6 months, and then I gradually increased to 90% when I was graduating.
Thanks, Sunmun.
I would like to add to all the young colleagues as well that when even I started my training in ERCP in US, we do not have that much amount of rigorous criteria or logbook. But I usually used to, write down in 1 month how many papilla I have done naive and what is my competency rate. And I think everyone should be able to, track their competency rate throughout the year.
And that's right. It's same for me. I manually entered and maintained a logbook. There was nothing structured in that way. It was a manual logbook by me. So at the end of the day, I usually log myself how many procedure I did and how much I was successful.
Okay, let's move on. So what are the hurdles? And I just looked at my way of thinking at it, and I thought there are 3 main hurdles for advanced endoscopy training in India. One is there is a reluctance on the part of trainee in view of family responsibilities. By the time you complete your DM or DRNB, you have a lot of responsibilities of family, so you want to settle down and you don't want to invest another year or 2 in advanced endoscopy. And if you look at the available 10 or 12 seats, sometimes they also go vacant. So we need to really look at it, because what's the cause why people are not joining? Are they not invited enough? I mean, is the program not interesting enough? Or is the genuine problems on the personality level? So I thought the reluctance on the part of the trainee is one. We have a DM course where a lot of DMs have to go through a bond after they complete their DM course. And so they are entangled in that bond service. And as I said, their programs do not look very inviting on the pages as yet. So let's look to Dr. Chawla.
Sir, I think reluctance is not an issue because many people are passionate about advanced endoscopy. If we see and endoscopy is one of the fascinating things once a trainee passes his 3-year course. And so I think reluctance in the part of trainees is not there, but limited structured courses are there and they don't know where to go, and lack of actually mentors which are offering the, initially like Dr. Mahapatra told that initial 6 months, if someone can guide at each small step, each procedure, then we have structured courses in India, then it will be a very good thing.
But I'll tell you, Dr. Chawla, I got your point, but there are 12 seats available. But let me tell you that even they go vacant sometime. So is it that the courses are bad, or is that something more which we are not understanding? Because even these seats are going vacant. SGPGI seats are going vacant. So what is happening? My own feeling is that somebody is going to stay back in SGPGI as a registrar after completing his DM or DRNB anywhere. Why he cannot at least be enrolled into a program where he is giving service as well as a part of the advanced endoscopy training? Why that is not happening? Let's listen to Prateek, Jimil, and then Dr. Usha.
But Mahesh, do you think it is because you are allowing them to learn it in a month, in 2 months, in 3 months, that they can go somewhere and do it and start practicing that, and that's why they don't want to, do a full year? If you have a structure in which you don't allow people who've gone through a year of training to do those procedures, then everybody will go through it. It's probably, if you step back, that's how DNB started, right? Is that you have to be credentialed or you have to be qualified in order to perform those procedures. So the reason somebody doesn't want to do a 1-year course is because if they think they can go to some place with TSC and learn it in 2 months, why should they be spending a year?
Or you look at one EUS-GJ here and you think I can go back and do a EUS-GJ tomorrow.
Sir.
Mahesh, there's
Yes.
one more hurdle I want to point out, over-ambitious attitude. I get many times a call that first month you want to learn ERCP, second month EUS, third month will be poem, fourth month will want to do bariatric. I said you have to go through this structured program for 1 year, and normally he says he cannot afford 1 year. Cannot afford to be with for 1 year. I think you have to be very specific what you want to learn.
So I would just share an interesting story. I had a DNB candidate who joined me about 6 years back, and he asked me, the first day he asked me a question, how many hours I have to come every day because I have a running practice. So that's the attitude sometimes, that he has a running practice which you want to continue and complete his DNB course along with running practice. Jamil, quick comment.
Sir, I would partially agree about the reluctance part. So in India, there is you don't require any credentials to perform all these endoscopic procedures. So what is in last few years, I would say in last 6 or 7 years, what the mentality has shifted, that we'll start the practice and down the line we'll learn gradually by trial and error method. And second, there is so much increase in number of the ghost surgeons, which has increased a lot in last.
So I think here there's a very important point you have raised. I'm heading a hospital department, and in my department, everybody has to be credentialed for doing a procedure. If somebody comes and tells me that tomorrow I want to do a single balloon endoscopy, I will not allow it. I will not let the administration allow it because he is not credentialed for doing a single balloon endoscopy. The only problem is, on what basis do I credential them? So the only way of basis is that I should have some evidence that he has undergone some training in that particular, because there is no structured things available. So that's the way. So I think it's a hospital's administration or the head of the department's responsibility not to allow anybody to do any procedures without a proper credentialing. Yes, Dr. Rohit Gupta and Dr. Laktakia, please.
So the problem is, yes, I agree. I had students who would come and after 3 months, 6 months, their wives would be jittery and they want to go back. They had enough, after 6 months, they don't want to stay back. Vis-a-vis,
for that, you have to make Allahabad an interesting place.
Vis-a-vis a candidate who was in bond for 2 years in the medical college, and he stayed back and he learned everything. So duration of time, because you can't give the scope to a person who doesn't know.
Does it mean that less than a year is enough?
Less than a year is not enough.
Okay. Dr. Laktakia.
I think we need to find a middle path of all this. We can't have dedicated like what they have in US. When the person passes our DNB program, he can be absorbed in a group as a part of the faculty there, and he learns on the job. He is also doing other work which is equally required. If you post somebody in ERCP as a 1-year dedicated fellow, advanced fellow, then he is not seeing clinics, he is not seeing other things like we heard from Dr. Mahapatra. I think, and once he is as a part of faculty, then he finds his way which
I think
path he can follow.
That's exactly what I said, that at least the faculty which is joining you can choose a particular specialty, and we see to it that there is a proper credentialing and understanding.
And when we frame the
short
route,
comments, we have lot to talk about. Dr.
Just
Usha
a
Datta.
short comment. The advanced trainee position is best in the primary institution because it's easy for the person to learn there. To go to a totally new institution and learn.
But I think, Dr. Usha Datta, you are looking at it with a different perspective. You are looking at it from PGI Chandigarh perspective. If I am not working in PGI Chandigarh, I should be absorbed in PGI Chandigarh. Why can't I go to PGI Chandigarh and get absorbed for advanced training?
Of course, you can be. The issue here I'm saying is any student who finishes 3 years is preferably absorbed in the same institution for an advanced fellowship in the same program. It will facilitate their learning process and it will also facilitate research in that area. The second point is in India, people are going to single practices rather than group practices. If after gastroenterology they go for group practices, they can focus on one particular area. If they go out and they are doing liver also, they are doing EMR, ESD also, they are doing ERCP also, that is a problem.
So I think what we have a place for a general gastroenterologist. We cannot take away the need for a general gastroenterologist. The only thing which we are saying is that advanced endoscopy should be limited to if there are 600 people are passing out, all of them do not become advanced endoscopists, but at least 5% to 10% of them should be chosen or should be selected for advanced endoscopy course, which should be structured. Naresh, quick comment.
I was just talking to Rakesh that not everyone is treated equally, even in the same program. I'm sure all of us would give more chances to the guy who appears to have more commitment or more skills. In fact, I remember asking Nagi, I said, you run such a thing, whom do you push? And he made a very cryptic remark. He said, when my technician tells me that this guy is safe, this message is for the youngsters on training. If you are perceived as being safe, you'll perhaps get more chances and more chances to train.
Dr. Rupray.
To retain a person to go for this advanced endoscopy procedures, ICMR in good olden times, if you write a project, give it to them that in this field I am going to work for 1 year and work at this center. They can be given a good salary to sustain themselves.
But why ICMR? Why not talk about national boards? We have two national boards, National Medical NMC and DRNB.
Do they have enough money of that sort?
You don't need money for starting the course. You need money to pay to the student. And I think it's the duty of an institute where this guy is going to get the training, because he's going to give a service as well. We are paying to our DNB students, we are paying to our DM students. Why can't we pay to the advanced endoscopy trainees? They're going to add value to your department.
I think it's right, but still we can approach these group of people, those who can give the finances. It's a good amount which is there.
Sir, one small point that it is still available. In CSIR, pool projects are still available if someone wants to apply and join.
I don't think that's the right way of moving forward. That we depend on these institutes to fund our advanced endoscopy training. I don't think that's the right way. This is my personal view.
Sir, I think in addition to having a structured training, we should have a counseling session also attached to it. Because when we are in the final year, we know a little bit gastroenterology, but we don't know where to go. I remember our head of the Department of Medicine used to invite faculties from all across the country for cardiology, nephrology, endocrinology, so that we get oriented where the course are being offered, what are the things we can do. So that must be a part of at least last 6 months. A good counseling opens up our mind about the prospect we have and what are the courses being offered.
So what you are saying is that a counseling for the options available.
Yes, from the experts.
Magesh, as Sandeep said, we don't admit them just to do ERCP alone. We use his service also for running OP outpatient, so that he is in touch with the entire aspects of gastroenterology and the program organizer. For I have an advance, I pay for my fellows here. So I don't depend on ICMR or DependB to pay for my student. But you will be able to absorb his service and utilize him for service, and he does the procedure. So he is in touch with the entire aspects of gastroenterology.
Okay, Dr. Usha, we have only about 11 or 12 minutes left.
10 seconds. Private centers can pay, government centers cannot pay, so we have to rely on CSIR, ICMR.
But who pays for your DM students?
The government pays.
So that's why I'm saying that the government has to extend that training for the advanced endoscopy training also. So let me just talk about this issue, that we have two main boards. One is NMC, which is controlling most of the DM seats, and there's a national board which is controlling the DNB or DRNB as it is called. So we have a medical gastroenterology specialty board which have a few members, and some of them, Dr. Roop Rai, Dr. Ajay Kumar, are part of that. And we discuss at various forums as to the need for advanced endoscopy course. And we have had several meetings with the administration, with the president of NBE board. One meeting I had only about 4 days back. And then we decided that we'll press for an advanced endoscopy program to be started by DRNB. They are very, very positive about it. So I wrote a letter after talking to all of them and after discussing with them, and this letter was written as late as 16th of April, just 4 days back, maybe pressurized by this particular meeting that we need to do something. So I've written to them and I've talked to them, and they have promised me that they will revert back to me within a month with a structured program which will be started, how the syllabus will be done and how the things will move are looking into. Their only concern was, and this is genuine concern, they said we started intervention cardiology and there's no takers. He says their seats are going vacant, nobody is coming to get the training for intervention cardiology. Everybody thinks that they have been trained properly and they start doing coronary angiographies. So their main concern was that, are there enough takers for this course which will start, because starting a course is not an easy job. They have to go through a lot of paperwork and all. So I have promised them that there will be enough takers provided you listen to us and you structure your course as per what we who are working in the peripheries know that what is the need and how the structure should be generated. So they have given the responsibility to us and they are very positive about it. We in fact asked for 4 courses. One was advanced endoscopy course, second is hepatology course, third is IBD course, and fourth is pancreas course. So we are now working on hepatology and advanced endoscopy, and later on we'll work on pancreas and IBD as well. So this seems to be a positive outlook for the national board support, which is likely to come very soon. So this will have possibly some of these, but as we discussed, how many such centers we need, what should be the duration of the course, and whether a particular fellow should be trained in all of them or most of them or some of them. We already discussed it. Matthew, you have anything to add there?
No, I just want to make a couple of comments and I will be very brief. See, when DNB courses are happening to us, when they leave, we actually give them an opportunity to stay back with us. If you're actually speaking, we know only 30% want to remain with you because of many other things. And regarding the training program, I think 1 year fellowship is sufficient if they want to be trained in EUS and ERCP. But in India, there is a problem. They are not dedicated only for that. They are also dedicated for some other work, And another thing which we have not discussed here, this is not only advanced endoscopy and training, but we should bring in research into them. For that, actually, the central institutes or major institutions should take part in that. And I think at least the society should.
Well, my last line is that structured research and publication. I think there is a sea change which is happening in India. In the last 5 years, there are plethora of good papers, research work which has been done in India and has been shown very nicely in this last 2 days of our attending here. But I think the more can be done. And the one which we are lacking is multi-center studies, and we need to do multi-center trials. I think we have the gold mine of patients and good doctors. Only thing is that we need to collaborate together to reach an endpoint. Radhika, you have been very silent till now.
Yeah, one should get trained in one procedure at a time rather than giving both the procedure EUS and ERCP together. So let him get trained in ERCP first, at least for 6 months, and then you can see his competence and you can give an endoscopy.
See, the only problem is that, Radhika, we had a long chat with DNB board.
I object. EUS and ERCP should go together.
Yes, what, come again?
EUS and ERCP should go together.
Yeah, that's fine. I think the major concern at this moment with the DNB board is they have not allowed us to reduce it from 2 years to lesser period. So I wrote a very strong letter that if you really want the program to be successful, you have to make it 12 months program and not a 2 years program. Gaurav.
Sir, just the program should be like that, like Dr. Sandeep told, one mentor should be there, or in a group where the newcomer is counseled in a year that EUS, ERCP, then third space, whatever he wants in a structured way, and it should be supervised by a proper.
So that would happen once the accreditation takes place through the NBE board. There'll be definite mentors. They will have a requirement of a senior faculty being present who is good in advanced endoscopy before they give the accreditation.
I got a message now from one of the participants, Mahesh here. Is that many places when they are selected not
you got it from here? You got it
here. They don't want to stand
don't
up.
want to come on the mic.
And another thing is there is one place at least which you have shown, take a fees prior to joining, a reasonably good amount. So it is not that it is not that simple as what we think.
All right. So what's the role of professional society? The SGI has moved. This is the previous logo and this is the present logo. So there's a lot of been done. So let's discuss that. Quick comments from the people.
Sir, one thing.
Can you introduce yourself?
My name is Rishabh Bose. I'm from AIMS Rishikesh, sir. I would first like to thank you for thinking about this to make a fellowship course. One of the things that you mentioned regarding one of the first few slides, that there was a list of places that offer fellowships. Most of us, we only knew of CMC Vellore and AIMS Delhi. Other centers we did not know of. And regarding AIMS Delhi and CMC Vellore, we know that there's one seat per year, and that is very difficult for non-institute people to get into.
So Rishabh, let me interrupt you. The deficiency is also on your side.
Yeah.
I clicked yesterday night, Advanced Endoscopy Fellowship courses in India, and it comes down, all of them. So I think if you, this would have taken you just 5 minutes to find out which are the courses which are available. So be brief in your comment.
With the fellowship course, I hope that there would be more centers which would start the course so that we can have a common centralized exam like NEET SS.
I think some of these courses are done by the independent institutes or deemed universities. Now we need to have courses which are run by NMC or by DRNB to structure and standardize it. Yes, comment quick. We have only about 5 to 6 minutes left.
Sir, my name is Dr. Tanmay. I am from AIMS Rishikesh. So my question is, how will we ensure the transparency in the selection system? Like for example, suppose I'm doing from AIMS Delhi and I want to get a seat in PGH Chandigarh, just for an example. So how will that selection process be transparent so that equal opportunity can be given to all the candidates?
I think that's what we were discussing earlier also, that there is a set pattern of entrance exam for DM also. So that, which is quite transparent. You have an entrance exam and a theory exam, and some of the centers have a practical exam also, but most of them are theory exam. So in theory, you can't doubt that there is a lack of transparency. Nadeem.
Yes, sir. Sir, after completion of DM or DNB, it is not being mentioned that they are entitled to do these procedures. Once they complete DM or DNB, many of the hospitals, even nursing homes, they approach them and they go and they start their practice. So, but many of them, they are not trained in ERCP, they do and land into complications. Even many of the residents I have seen, they are not able to control, GI bleed. So I think there should be some mention of the things or procedure that they are entitled to do this, or whatever you are talking about, that they should go for advanced procedures.
So I think credentialing is very important, that there should be a credentialing for doing procedures. Satish.
Just a small point. A major concern in our country is that, especially in DNB and DRNB program, the patient volume and all this is not so much in many of the institutes, and they are not up to the mark, and the students coming out, they are not even trained in the basics.
You have hit a very important point. In fact, when I talked to Dr. Abhijat Seth about 4 days back, he told me that there are many centers which we are not able to get the volume for the DNB training. I think that's a very important point. While the government wants to increase the number of postgraduates, you have to have a volume to learn. I think what have SGI done in the last 12 to 13 years? Accreditation of the institutes has been done for advanced endoscopy training. We have also developed some training level guideline. We of course do these endoscopy workshop and endocons, and Pratik may not remember, but he was a part of this position paper by SGE where we told that what should be the numbers for the minimal number for table 1 shows that this is for basic training, this is for somewhat advanced training, and this is for really advanced training. This is the number which we suggested in this paper, which was published in SGI journal some time back. And I also got a support for the National Board Fellowship from the present President and Secretary, which I have forwarded. This is April 9. I wrote to Pramod and Rajesh, and I have convinced the board that SGI is with us, and I think SGI can play a very important role, just like what Pratik was talking about ASGE, that we can find out and help in finding out the institute, do the matching, find out which are the centers which are good in bariatric, which are good in EUS and resection. And I think SGI can be a pivot being played, and present MBE board is very, very positive about involving the societies. In fact, they have told me that your president of the society will be a permanent member of the medical specialty board. And as the president changes, you go on adding the new presidents to the society, to the medical specialty board. So I think with this coordination, we can move forward. Yes, please.
I'm Deval Parikh from Ahmedabad. Sir, you are talking about the new students, the DMB students, the DM students. But what about those guys who have passed 5 years, 7 years, 10 years back? Because there is a half-life of our knowledge of gastro. Say in 5 to 7 years, half of that will be obsolete. A person who has passed 7 years back won't even know anything about endoluminal surgery.
I understand your question.
So there should be, no, the way you are structuring as an association, you are structuring the modus operandi for the DM students. Same way for the practicing doctors also.
We got your point that you are talking of somebody who has passed 5 years back, or somebody like me who has passed several decades back. How do I learn
new things
advanced
have been coming, and the half-life is becoming smaller and smaller as the days go by.
I agree that that's a different challenge, and we can discuss it in a different forum. I'm running out of time, so we will just Jimil.
Yes,
quick comment.
Sir, last year there was a survey from the ASG side that the more than 70% of the advanced endoscopy fellowship fellows could not secure the job up to the level of their skills. So whenever we are accrediting we should not make the same mistake that whenever in future we are accrediting the institutes for the SGI accredited advanced endoscopy courses, SGI has to be sure or double check that their center has that much amount of volume that they are able to generate a good quality advanced endoscopy fellow or a good amount of an advanced endoscopist. It should not be a plethora of the centers with inadequate amount.
No, I agree that there should be limited number, there should be very strict accreditation criteria. We should look at the number, the experience, and I'm sure if we work with the NBE board, they would be there. Ajay is a part of that group. I don't know whether Ajay is around or not. And we are looking at how to go ahead about it.
Mahesh, one sentence I want to say.
We need to move forward.
One sentence I want to say. I think, this is a crucial step. SGI or the society stepping in. I think in many countries, actually, the society does the advocacy for training and treatment. But I think it's a very crucial step, which we have discussed many times in our meetings earlier.
Quick, brief comment, Raju.
I think the simple thing is demand and supply. If you are supplying more, demand is less, you are going to make it useless. So make sure that these training procedures should be in tune with the demand of the day, and it should be progressively increasing and not keeping it to the impractical possibility of that.
Dr. Singh.
Dr. Mahesh, I think we need to have a survey from those people who are already doing it and how they have learned, how they have grown. And based on their experiences, only the program should be formed.
All right, good point. Yes.
Sir, we have 600 people who are coming out. We need at least 100 centers, which are actually there in India. I think 100 means 100 centers who do at least 500 or 600 ERCP in a year or 1000 ERCP in a year. And then instead of going for a DNB, why not SGA itself can do this?
See, because the problem with that is that there are many programs which are done by society. Critical care, pediatrics, and many other societies. But they cannot be considered as official degrees. They are society accredited program. It cannot hold. If you want a government job based on these, you cannot get a government job because these are society programs. Critical society is very highly rated program. But I think until as the NMC or the DRNB comes into, we will have a limitation. So society has a role to play as we discussed. But it cannot be the controlling authority for the whole thing.
Because people are getting trained unofficially, but they are doing. At least SGA, if it makes some centers which at least they can go and they can learn.
I will leave that for Rajesh. He has something to tell you. Dr. Umesh, quickly.
Yeah, one quick comment. We are talking about credentialing and all these things, and these things are mostly followed in the bigger institutes. And if people go outside and practice and there's nobody to check them, and how do you control that?
I know this is a point which we discussed. So what should the tools and techniques of imparting advanced endoscopy training, lectures, models, we need to develop better models for EUS. Some models are available, supervised and independent procedures. And I think I have learned through my own learning process of TTT, and Michelle mentioned that today in her talk, that when you train a program, you have to deconstruct the procedure into parts. You cannot somebody teach the whole steps of ERCP in one. You have to possibly deconstruct, and I learned this during the TTT program recently. Praveer was a part of that program, that you need to demonstrate, deconstruct the procedure, comprehension, and then performance. So I think we need to start this procedure of training through these 4 steps, which was from the Oxford Piton, started this long time back, and somehow we are not following this. I think for any training it's very important. And I must say that live transmission, we are fortunate that we are able to have live transmission now, but very soon live transmission will become a history in India. There is strong objection from patient advocates who are saying that live transmission is detrimental to the safety of the patient. It not only increases the anxiety on the part of the person who is performing it, but safety is compromised. And there was some study long time back which showed the ERCP, you require more general anesthesia when you are doing the live transmission. The efficacy is less when you are doing live transmission. So I think the live transmission, while they are all very good to look at, needs to be looked from the different perspective as well. With that, I will move on to Rajesh. Rajesh has something to add. Yes, Jimil.
One small comment, sir. I think recently only Dr. Anthony Teo has published a paper on his experience of last 10 years of procedures, complications during HK live versus a procedure which were not doing as a part
What
of
was the result?
Equal, no increase in risk of complications.
You need validation from various centers.
Yes, sir.
Rajesh, we are with you.
Yeah, good evening, everyone. And I have not listened the complete discussion because doing some procedure left over. But few words, I was listening Jimil, I was listening B.S. Ravindra. I always feel we should have start from somewhere. Thinking of ideal situation will never happen. When I was student, that is in around 15 years before, the same discussion in different form has happened. And we keep on discussing, thinking we should start ideal. And I'm going to talk what we have done in the last 3 years, that is the SITAR program. And SITAR is SGI School of Innovation, Training and Research. So it was discussed by Dr. Goenka and the panelists that each year's around 550 to 600 students pass out. And they have a basic knowledge of upper GI, colon, dilatation, doing the glue injections or doing the bending. But everybody wants to learn third space endoscopy. People wants to learn advanced ERCP. People wants to learn advanced EUS and so on. So thinking that when I become the secretary, 3 things come in my mind. How to get the advanced training for the young doctors? How do we develop the research? And how do we develop the innovation in endoscopy? I remember my time when you discuss, there was not much of the centers, and the private center who are teaching, there is a fear of complication by a young doctors. And most of them was told that it is not possible to give hands-on training and you can observe it. And that lead the training to go out. And that was the reason I thought, let's plan something through the SGI. But what are the challenges? The multiple center offering fellowship, observership of different duration and different quality of teaching. I think that was discussed in the last 1 hour. There is no central accreditation body. National board is doing, I know Dr. Mahesh Goenka is trying, and I think he has taken a significant lead, but there is no clear direction or the defined quality criteria. Decentralized application, but no clear selection criteria, which person is going to use for which kind of specialization. Need to unify participating institutions. So what I thought, this with the help of SITAR, I developed in the last 1 year with the help of Dr. Pramod Garg. I'm really thankful to him. He has made my dream true because I'm discussing this from the long time. A young endoscopic upskilling program, which I'm going to talk. SGI postdoctoral fellowship, which I think Jimil was talking, I'm going to talk. SGI research grant and the traveling fellowship, and SGI training videos. So let's talk few words about the EUS program. And EUS program is Young Endoscopic Upskilling Program, and we thought that those students who has recently passed out, give them the exposure of the advanced endoscopy in a different way, like one time ERCP, one time EUS, one time third space. And we plan to do the 4 courses in 1 year. That is, every quarter we plan to do 1 course, and around 15 to 20 young students guided by 5 to 6 mentor for 2 days in the form of didactic lectures, followed by the live demonstration. And the first program we did 2 months before in All India Institute of Science with the help of Dr. Pramod Garg, and 3 more programs, one by Dr. Mahesh Goenka, one by my colleague Dr. Vinay Dheer, and another in the Coimbatore. So 3 young endoscopic upskilling program is due in the 1 year. Second is a research grant and the travel fellowship. This year we have given 2 research grants, one to the disinfection, which was discussed few days before, and Chalapati Rao is heading that. And there is another grant of 5 lakh rupees is given to Sudipto Dhar for doing the multi-center trial for EUS coil and glue versus endoscopic glue. Young Indian researcher up to the age of 45 is given. These are the criteria, and all these criteria are mentioned on the website. I request everybody to look at the website of SGI, and that is recently made, and beautifully everything is done electronic. The traveling fellowship to DDW ESG days has been done. The best paper or the oral presentation for DDW, 2 grant of 1.5 lakhs rupees, and ESG days 1 lakh rupees. And these details, who can apply, what are the criteria, is available on the website. Postdoctoral fellowship, this is very important. And this was thought that the post DM and the DNB fellow, keeping in mind for the advanced fellowship, we have enough resources in India. We were discussing, we have a more center. At this moment, we have chosen 20 center to give the advanced training, and each center can give 2 to 3 months. Like some center who is very good in third space, some center has a multiple advancement, so they can give the fellowship, and SGI is going to fund the young doctors for doing the 3 months training. And there is a point-based selection criteria, again available on the SGI website. I just wanted to request young doctor to see the website, look at the criteria, apply to the centers, not only for the research as well as for DDW, but you can apply the postdoctoral fellowship for 3 months, and SGI is going to fund at least for 50,000 rupees to each candidate. This is the new website I want. Recently made, and you must see this website, and you see here is the journal, which is developed by Dr. Mahesh Goenka. You can see the detail of journal. Then the event, like Endocon has happened. What is the next event is coming, which will be shown on this journal, followed by the procedures, the guidance to the patients, then the resources in the form of videos. At least 10 doctors has provided the videos, the teaching videos, and this was the plan during this time only. This is the governing council page. And after this, you can go to the membership now. Earlier, we have to fill the form, but now it is electronic. You can directly go on the website and you can become the member. So now this website has been matured, and I want to make this website. I would like to thank Srihari, Sridhar Sundaram, Vikas Singla. From the last 1 year, we are trying very hard, and thank you these guys for making this website possible. So I think SITAR is like a footprint of a new endeavor which will pave the way to the advanced vistas to open for better training in India. Thank you for patience, patient hearing.
Thank you, Rajesh, and thanks to all the panelists and all of you for a very interactive session. We look forward. Let's see where we have to start somewhere, and we'll move forward. Thank you.
For the next session, for the state of art lecture of innovations in endoscopy, my journey, I invite the following chairpersons to please come on stage. Dr. Horst Nuas, Dr. Martin Freeman, Dr. Dong Wong Seo, Dr. Anthony Teo, Dr. Nageshwar Reddy, Dr. Mahesh Goenka, Dr. Pramod Garg, and Dr. Rajesh Puri. I request the chairpersons to please come on stage.
Good evening, everybody, and we'll start off now as we get into the time. It's my great pleasure to introduce Ken Binmola for this very important oration. Ken has been is the director and founder of Interventional Endoscopy Services, California Pacific Medical Center. He's, of course, everybody knows him because of the Axios Stent, which actually should have been named after him. But anyway, he was the inventor of this, and he's got about 50 patents in different devices. An outstanding endoscopist and teacher, and I think he's been here, of course, several times, a close friend of India. And Ken, thank you very much for coming, and we're looking forward to hearing you.
Thank you, Nagi. Well, Rajesh just asked the very important question, how do we develop innovation? The way to develop innovation is mentorship, and I was very fortunate to have had the mentorship of Nib Sahendra, who not only mentored me in interventional endoscopy, but he mentored me in innovation. And as you know, his name is associated with so many innovative tools and techniques that have changed the landscape of interventional endoscopy, enabling us to do procedures like ERCP biliary stenting that was inconceivable before. Necessity is the mother of invention. The need is revealed when we encounter difficulty or challenge in our daily practice. It doesn't matter what procedure you are doing, you will encounter moments of difficulty and challenge. Embrace these moments, because these are moments of opportunity to spark a vision for innovation. What we need is, this is the question that should be popping up in your mind while you're doing your procedures. What is it that we need? And what that solution should be is, it should fulfill these 4 criteria. It should be simple, it should be easy, quick, and affordable. A simple tool or technique, easy to learn, quick to perform. It should be performable really within the span of 20 to 30 minutes in our practice. And it should have affordable cost. And of course, it should show safe and effective outcomes. So I'll share with you a little bit, just a taste of my personal journey of innovation. I have 3 tools here that I'll present. I have various techniques that I've also developed, such as underwater EMR, the coil and glue, which you saw today, and full thickness loop ligation for sets. You had the opportunity to see a bit of that today in the live demonstration as well. But this is where my journey started with EUS-FNA. I joined Nib Sahendra's group in 1991. And at that time, the first CLA echo endoscope was commercialized and available. And Peter Villman came to our unit almost monthly to trial various prototypes of an FNA needle that later culminated in the Hunke-Willman FNA needle. That was the only needle that was available. That's how we were doing FNA at that time. But we faced several limitations, difficulty penetrating indurated lesions, such as the pancreas, often very indurated, difficulty targeting small and mobile structures, subepithelial tumors, small lymph nodes, and our yield was very scant. It was only cytology, there was no histology. So there was an unmet need for a better tissue sampling tool. And that's where the gears started moving in my mind. And I came up with a concept for a EUS-guided spring-loaded biopsy device. This is an example of translational medicine. I just looked across the aisle to our radiology colleagues who were performing FNB with these spring-loaded needles. So I adapted it to the echo endoscope with 3 key features: dual manual and automated operation, high velocity puncture when automated, and precise control of the shot depth. There were engineering challenges. I worked with an engineer in Hamburg. The transfer of a high velocity thrust to the needle tip. It's a long needle length, many angulations, and the friction between the sheath and the working channel, very different from a percutaneous radiology guided biopsy. And we had to minimize transfer of force to the scope handle itself. We actually destroyed several echo endoscopes in our early trials. Well, finally, this was patented first in Germany and then worldwide. An automated EUS-guided biopsy needle. We published a case series using this biopsy device in Endoscopy in 1997. Interestingly, in 2 cases where the cytology was negative, we got a diagnosis of chronic pancreatitis. You can see the beautiful core biopsies that we were able to obtain. Olympus was interested in this needle. They commonly visited, often visited our unit. They saw me using this prototype, and so they commercialized this as the power shot needle, and they even added my 2 initials here, KV. Enabling manual puncture, automated puncture. You press on this button here, it shoots the needle out with high velocity into the lesion, obtaining this beautiful core specimen, and you can calibrate the exact depth of penetration. And in that very same year, the first disposable EUS FNA needles were commercialized. This was the 510K that was allowed to cook, and they developed the first echo tip needle, a disposable needle, and many followed after that. And this basically eclipsed the need for this power shot needle, and really the nurses, the staff preferred a disposable needle to a needle that a device that needed to be reprocessed and assembled. So the message here is every innovation has a window of need and market opportunity. So you need to catch that wave of opportunity. Next is the lumina-posing metal stent, which you're all familiar with. Now, the roots of this actually, and this is really destiny at work. I had no idea when I was a fellow at Oregon Health Science University in Portland, Oregon. I was fascinated by the self-expandable metal stent, which was invented by Charles Dotter. Charles Dotter was at OHSU. His protege was Joseph Roche, and I spent a year working in the lab, many hours spent placing expandable metal stents. This is the Gian Turco Rush stent in pigs, and I published on the first experimental studies placing these SEMs in the esophagus. So this was really the world's first experience using self-expandable metal stents in an animal. Then comes Hamburg in 1992. We had a patient with a non-bulging pseudocyst. We had the CLA echo endoscope prototype from Pentax, and we performed the first EUS-guided pseudocyst drainage for a non-bulging cyst. And then we continued to use this method, but in one case, I mistook the gallbladder for a pseudocyst, and I punctured and later realized that I was in the gallbladder, which then leaked into the peritoneum, and this patient became critically ill and expired. And this was the lesson that if you get leakage, this could be disastrous. The need is we need to develop tools to prevent leak and perforation. We were immune with pseudocysts because they were adherent to the bowel wall, but it's a different story if you're talking about the bile duct or the gallbladder, and certainly a neighboring loop of small bowel. So the need was to develop a transluminal anastomotic stent that is lumen opposing and seals off the tract, and an exchange-free stent delivery system where we could access the target lumen with a stent-loaded catheter and eliminate over-the-wire exchange completely. So there's no opportunity for leakage. So the LAMS concept was born in 2007. This is what I filed with the USPTO, the patent office. It had a different look back then. The LAMS, these were more of these rounded shoulders, but the concept here was a device that brings two luminal structures in the body drawn together towards each other to create a fluid conduit formed in between. Then I founded the company Exlumina 1 year later in 2008. Here you can see the founding team to go beyond with advanced transluminal therapy. So this was the first company with a vision to develop tools to enable transluminal therapy. Then EUS-guided, of course. So the biggest challenge is to get money to start your company. So after many dog and pony shows, elevator pitches to VCs, we finally got our first round of funding, $6 million, which at that time seemed like a lot of money to me. Little did I realize that it would take more than $73 million to finally create, some 8 years later, an actual device that could be used in the clinical setting. Now, I don't have time to go through the medtech stages, but this is